oral papers on the final day of SZIRACON 2024. I hope everybody had a very good time in the gala dinner and are fresh now. At the outset, I would like to request our esteemed guests who have come all the way from the UK, Dr. Glaston Chelaya and Dr. Arumukam Murthy, to come onto the dais to chair this session. So you can. We'll start with the oral presentations. Starting of the day will be Dr. Akansha.
Good morning to one and all. My topic is diffuse alveolar hemorrhage in rheumatic disease. So the DH, it is a life-threatening condition which can be due to the immune as well as non-immune causes. The early identification of underlying immune disorder, that is mandatory to prevent the complication. So this study aims to describe the clinical spectrum serological outcome of patient with the DH present in the rheumatic disease. It was a retrospective observational study that was conducted over the 5 years. The inclusion criteria was more than one pulmonary symptom in the form of dyspnea, hemopsis, cough, acute diffuse new infiltrate on chest imaging, and a drop in the HB more than 1.5 gram per dl, and BAL showing the evidence of hemocysteine-laden macrophages more than 20%. So the results were, the mean age of presentation was 42 years, and female is to male ratio was 3:1. So it was a female predominant, and among the ANCA vasculitis, the predominant clinical feature was the constitutional and the renal, that was a 43%, followed by the ENT manifestation, that is 37%. And in the SLE, the most predominant manifestation was the constitutional, mucocutaneous, musculoskeletal, and serositis, followed by the renal. That was the class LN4. In the lab parameter, all patients, they have in the BAL have the hemocysteine-laden macrophages, that is more than 20%. The C ANCA was positive in 37, and P ANCA was positive in 31. ANA positivity with elevated anti-dsDNA by ELISA with low C3, C4 was seen in 31%. DCT was positive in 31%, mass worker was positive in 12%, and APLA was positive in 6%. The mean disease activity, so among the ANCA vasculitis, the mean BVAS score was 4.5. Among the GPA, it is 4.8, and for the MPA, it is 4.2. In the SLE, the mean SLEDAI 2K, it was 13. And concomitant infection that was seen with the DH among the 3 patients, out of which the CMV was seen in 2 and H1N1 in 1. The DH in the rheumatic disease, so in our study, the ANCA was the predominant cause, that was a 69%, followed by SLE 25%, and overlap, that is of SLE with the scleroderma, that is 6%. Then DH in the ANCA vasculitis, it comprises in our study, the predominant was the GPA, that is 55, and MPA was 45. So all patients received steroids, and cyclophosphamide given to 75%, followed by rituximab, IVIG, plasma exchange in 18%, then MMF in 6% and MMF in 6% and hemodialysis in 12%. Then among the ANCA vasculitis, the treatment was given, all patients were given steroids, cyclophosphamide in 50%, rituximab in 18, plasma exchange and IVIG also same 18. Treatment in SLE with DH here, all patients received steroids and cyclophosphamide was given to 25% and 6% received MMF. The mean follow was 30 months and the recovered patient, 56 were recovered and loss to follow-up time is 38%. Our study, the SLE was 25% and ANCA vasculitis 69%, which is comparable to the Salvia and Adrin study. Then then the renal predominant was the most common organ involvement was 68%, which is comparable to the Salvia study. And cyclophosphamide was given to 62%, which was comparable to the Adrin study. And rituximab, that was 18%, which is given to, which is comparable to the YP Singh study at all. Same. About the disease activity, the SLE disease activity was 13%, which is comparable to the Salvia study. So we have seen that there is increased disease activity among the patient presented with the DH in the rheumatic disease. And Hudson in 2002, they have seen that DH patient who are having with the diagnosis of SLE, they have LN class 4 and 5. So our conclusion is the most common rheumatic disease presented with the DH was ANCA. The most common organ involvement was renal, all having the disease activity high, and the steroid and cyclophosphamide showed excellent response. Thank you.
So any questions from the floor?
I have one question. So you said the mean BVAS was 4.8, but just DH gives a score of 6 in BVAS, plus a significant number of patients had renal involvement. So don't you expect the BVAS to be higher?
So mean, when we calculate, it is around 5, mean 4.5.
Yeah, but everybody has DH, plus they must have one more manifestation. So shouldn't the mean BVAS be higher? Yes, I think that's some confusion. How many patients needed Plex?
Plex 3. Okay. That was more predominantly, sir, MPA patient only they got plasma exchange.
What protocol of Plex did you use?
Sir, for the, that is UVAS only for the, sir, cyclo.
Yeah, how many cycles? Like, how many cycles of Plex did you need in these patients?
Sir, we have given at least 5 cycles.
Okay, thank you.
So,
at what stage did you choose to use rituximab rather than cyclophosphamide, and what made you choose that decision?
Sir, among the, when we have a concomitant infection and we are giving IVIG, that time we have given rituximab later on for those patients presented with the CMV. And for the latest, those patients who presented with the DH, for the ANCA, we have given rituximab, sir.
Sorry, I didn't understand that. You gave cyclophosphamide in the acute phase.
Yes, sir.
When did you introduce rituximab?
In maintenance phase, sir.
I beg your pardon?
Maintenance.
In the maintenance. Okay, fine, thanks.
okay, thank you very much.
Next, I welcome Dr. Anirudh Maslekar from St. John's, Bangalore.
A very good morning, everybody. I am here to present an interesting case which proved to be a learning experience for all of us. So let's open the pediatric Pandora's box. So this is a case of a 13-year-old female child who was born of non-consanguineous marriage, who presented with recurrent ulcers over both lower limbs since 9 years, episodes of Raynaud's phenomenon since 6 months, a gangrene of the left great toe since 1 month, and constitutional features in the form of loss of weight of 8 kgs in the last 6 months. These are some of the images which are showing the dry gangrene of the left great toe and multiple healed ulcers of the right lower limb. She has had recurrence of these ulcers over the last 4 years. We also found this rash over her bilateral palms, which we considered as a livedoid rash. So at this point, some of the differentials which we were considering were medium vessel vasculitis or a cryoglobulemic vasculitis, whether it was a primary APS itself or whether we were dealing with another CTD. So we did some lab investigations to confirm the diagnosis. The complete blood count showed anemia and leukocytosis with a normal maintained differential count, no thrombocytosis. The inflammatory markers were elevated. The complements were normal, creatinine was normal, the urine routine was normal, no proteinuria or active sediments. APLA workup, serum cryoglobulin was negative, ANA immunoline were negative, and the viral markers were negative. Even there were no signs of arterial insufficiency also in our patient. Now subsequently what happened was she started complaining of episodes of pain abdomen, persistent, no localizing features. We did a routine ultrasound, amylase, lipase, which were normal, but still it could not explain the pain abdomen. We did a CT angiogram, which was showing this typical multiple aneurysms of the various arteries. So, now given this constellation, hypertension, peripheral gangrene, cutaneous ulcers, abdominal pain, aneurysms, livedoid rash, you are sure of the diagnosis of a medium vessel vasculitis. Now, is this DADA2 or is this childhood pan? Why should we differentiate? We have to differentiate because it has therapeutic significance. If it is DADA2, we will go with TNFi upfront, and DADA2 will have a suboptimal response to conventional immunosuppression and steroids. So now we looked up literature to see if there are any markers which can help us differentiate between these two. So after our literature review, we came to understand that a younger age of onset, a median age of 4 years, consanguinity, presence of neurological manifestations, presence of lymphopenia, lack of thrombocytosis, and a livedoid rash all favor DADA2. Whereas for childhood pan, an older age, that is a median age of 7 years, thrombocytosis and presence of panniculitis favors childhood pan. She was in the middle actually. We were not able to differentiate exactly. So we went ahead with a genetic analysis. Then we initiated her on pulse IV methylprednisolone and injection cyclophosphamide 600 milligrams and managed her hypertension. But after even 3 doses of cyclophosphamide, these are the ulcers which were very painful. The patient used to cry in pain literally. So we immediately shifted over to TNFi. We went ahead with injection adalimumab 40 mg every 2 weeks. But she continued to progress despite 4 doses of adalimumab. Now, by now we had her exome sequencing results. So we had confirmed the diagnosis of DADA2 now. She had a homozygous mutation of this ADA2 with the typical glycine 47 arginine mutation. It was a missense mutation. Her parents by Sanger sequencing were also known to be carriers of this gene. So now the picture was clearer. We decided to first change the brand of adalimumab and see if there is a response. However, again she progressed to have multiple other ulcers. So now we switched over to increased dose of adalimumab of 80 mg. Then our further plan was to plan for infliximab if there was further worsening. Her last follow-up with us was in June. And then I just had a telephonic conversation with her last week where she was doing well and there were no further ulcers. So right now she is on injection adalimumab 80 mg every 2 weeks. So what are the key points of this? DADA2 should be considered in familial and early onset cases of PAN. They are often clinically indistinguishable, but the presence of neurological features, livedoid rash, cytopenias favors DADA2. Differentiating these two entities is important as it has therapeutic significance. And the current case is a unique presentation of DADA2 without neurological manifestations. Previous Indian case series by Dr. Aman Sharma et al. Have reported the neurological involvement in as many as 82.4% of our patients. Our patient did not have any of these. Thank you.
How often you get aneurysms in DADA2 syndrome?
Sir,
Because
DADA2.
aneurysm is a rare feature. It is not a feature of DADA2.
Yes.
When the cutaneous span is not responding to conventional line of treatment, then you suspect DADA2.
Exactly, sir.
But how often you get DADA2, aneurysms in DADA2?
So that was our concern also, because that is why we were in we were confused whether it was which of these diagnoses. Literature review has shown less than 5% cases as in a Turkish cohort, sir, which can present with aneurysms even in DADA2.
Even in cutaneous span, they can have neurological features.
Yes, sir.
Whether is it a overlap of DADA2 with cutaneous span?
So that can be a differential which can be considered, sir. But initially what immunosuppression we gave, despite 3 doses of cyclophosphamide, she was worsening. So we had to make a clinical decision of switching over to TNFI.
Do you still consider a diagnosis of cutaneous pan or pan?
Sir, we would stick to the diagnosis of DADA2 right now, sir.
No, that's right, okay. Do you still consider a diagnosis of pan? Is it still in the nomenclature?
Did you do a histopathology of the
no,
ulcer?
No, ma'am, it has not yet
We
been
should
done.
have demonstrated,
Yeah,
no?
we are planning to do it, ma'am, actually.
No,
There were some
the final verdict will be only with the histopathology when we are in doubt.
Yes, ma'am, we were planning.
Why did you choose adalimumab
Yeah.
80 mg fortnightly over infliximab? Is it something documented?
Sir, it was more because of logistical reasons, sir, rather than data, because there were no head-to-head comparisons in DADA2 among the various TNFIs. So for logistical reasons, we chose adalimumab, sir.
Have people tried 80 mg?
Sir, there are only case reports, sir. So there is no strong level of evidence for the same, but based on the limited data we had, we went ahead with that.
So when you gave 80 milligrams of adalimumab,
Yes, sir.
have you seen more complications or benefit from this?
Sir, I
because
think
it's a
that,
very unusual dose.
Yes, sir. So the duration of follow-up is very low to comment. Like it has been only 1 month since we have given that. So till now we have not noted any complications, and we did all the pre-TNFI workup before starting, sir.
Okay, thank you.
Thank you.
Thanks to Dr. Anirudh for a very nice case presentation. Next, I welcome Dr. Lakshmi Tejasvi from SRM Chennai.
A very good morning to one and all. Today I'll be presenting a paper on health-related quality of life in rheumatoid arthritis assessed by short form 36 and its relation to disease activity. Rheumatoid arthritis affects patients' physical and mental domains of well-being. Health-related quality of life outcomes are the patient's primary concern. The aim of the study is to assess health-related quality of life in RA patients using SF36 form and its correlation to disease activity. SF36 form has 36 items with 8 subscales and 2 summary scores. Physical component summary is a composite score including physical functioning, role limitation owing to physical health, bodily pain, general health. Mental component summary is a composite score involving vitality, social functioning, role limitation owing to emotional health and mental health. This is a cross-sectional study done at Department of Rheumatology, Sri Ramchandra Medical College, Chennai from March to June 2024. 100 patients aged more than 18 years diagnosed with RA by the revised ACI-EULA 2010 classification criteria were included. Their demographic data, complete medical history, clinical examination details were collected. Disease activity was assessed by DAS 28 ESR. Health-related quality of life was assessed using SF36 questionnaire, scored from 0 to 100, highest scores denoting better quality of life. Statistical analysis was done using SPSS version 21. Out of 100, 86 were females with a mean age of 51.9 years. Below graph showing distribution of patients in less than 50 and more than 50 years age group. Mean disease duration was 6 years. Graph showing distribution of patients in less than 5 to 10 and more than 10 years disease duration. 31 patients were in remission, 24 had low disease activity, 29 had moderate and 16 had high disease activity. Majority of them, like 79%, were unemployed. Other parameters like financial burden, caretaker burden, treatment details were also analyzed as shown in this table. This is a radial chart showing mean SF36 scores in various domains of SF36. As we can see here, role limitation secondary to physical health is the most affected with the lowest score. Mean physical component summary scores were lower than mean mental component summaries. Both physical component summary and mental component summary scores were lower among females as compared to males. As the disease duration increased, both physical component summary and mental component summary scores were lower. Both physical component summary and mental component summary scores showed significant negative correlation with DAS28. So did all the individual components of the SF36 domains. In this radial chart, we compared our study depicted in blue with other national and international studies assessing quality of life in RA using SF36 form. As we can see here, mean SF36 scores in our study were higher compared to others. Among all the studies, like in ours, role limitation secondary to physical health was the most affected with lowest score. In all the studies, like in ours, physical component summary was affected more than the mental component summary. So comparing our study with other national and international studies, these similar observations were made. There was significant negative correlation between DAS28 and all domains of SF36. Females and longer disease duration had poorer health-related quality of life scores. Limitations of our studies, we did not include a normal healthy cohort. There could be confounding factors like comorbidities, even extra-articular features of RA. SF36 scores could have been correlated with other indices of RA like SDI, CDI, and the functional disability like HAGD for better understanding. Conclusion, disease severity, longer duration of illness, and female gender have negative impacts on all domains of quality of life in patients with rheumatoid arthritis. Physical domain is affected more than the mental domain in rheumatoid arthritis patients. Thank you.
Thank you. In that study, in SF36, you have the DAS28 by ESR.
Yes.
Why then rather than CRP?
So because most of the patients were doing ESR, like our OPD patients, when I initially started with both, but when I saw most of our patients were coming with CBC with ESR. So since that was available, I went with DAS28, sir. No other particular reason.
You came out with a negative correlation.
Yes, sir.
So if you would have done for DAS28 with a CRP, do you think there will be some difference? Because ESR can be a difference on that one.
It could be like other factors can also affect ESR, like anemia and all. CRP also will show negative correlation only, sir.
A negative correlation. Okay.
Yes, sir.
Thank you.
It will show. Sir.
John? Yeah.
Were unemployed. Was it related to the disease or some other factor?
Somehow, like most of them were females. Like 86 were females, sir. What I've noticed is males were only employed. Most of the females were unemployed. Very few employed females only I've seen, sir.
It's maybe nice to compare with general unemployment among women with
Yes,
rheumatoid.
sir. And there were like few patients who had to change their occupation because of the disease.
Okay, thank you. If there is no further question, we'll move on to the next case.
Yes, thank you, sir.
Thank you.
Next will be Dr. Kavya from CMC Vellore.
Good morning. Today I'll be talking about a case series of myocardial involvement in SLE. It was conducted as a one-year retrospective observational study. Myocardial involvement in SLE can be seen in up to 5 to 10% of patients of SLE. The causes of myocardial involvement can be lupus myocarditis, antiphospholipid antibody-mediated pauci-immune microangiopathy, which can cause microthrombosis, ischemic heart disease due to accelerated atherosclerotic cardiovascular disease. There can also be maladaptive myocardial involvement because of uncontrolled hypertension or valvular heart disease, and also adverse effects of medications such as HCQ, which can cause myocardial involvement. There are myriad manifestations of myocardial involvement. Patients can be completely asymptomatic, where they can present with incidentally detected elevations in biomarkers of cardiac injury, to life-threatening cardiogenic shock and dysrhythmias. Literature regarding the demography, the immunologic and clinical profiles of patients with SLE who have myocardial involvement is outdated, and specific data pertaining to patients with South Asian origin is essentially non-existent. So we have conducted an observational study to describe the contemporary demographic and clinical profile of patients with lupus myocarditis. This was conducted as a retrospective observational study in the Department of Clinical Immunology and Rheumatology at CMC Vellore, spanning the last 1 year between July 2023 to June 2024. The electronic medical records of inpatients were assessed, and data regarding the clinical presentation, the laboratory parameters, and relevant imaging during the presentation with myocarditis was compiled and subsequently analyzed. There were 369 patients with SLE, out of which 14 patients had a diagnosis of myocardial dysfunction, in which 6 patients had a diagnosis of new onset myocardial dysfunction. They were adjudged as possible myocarditis based on their clinical presentation. That is, features of myocardial dysfunction such as when patients are presenting with exertional dyspnea, or if they had orthopnea or PND, features of congestive heart failure, arrhythmogenic palpitations, pre-syncopal attacks, and ECG abnormalities, along with significant elevations of cardiac biomarkers and lack of regional wall motion abnormalities of coronary artery distribution. Demographic profile showed a mean age of 22.17 years with a range of 19 to 30 years. All our patients were females. The mean duration from the first symptom attributable to SLE to the onset of myocarditis was 33.33 months with a range of 4 months to 7 years. And coexistent major organ involvement most commonly seen was lupus nephritis in 67% of patients, and neuropsychiatric SLE, which was seen in 50% of the patients. Most common presenting feature was dyspnea on exertion that was seen in 3 patients. There was pedal edema in 2 patients, and 1 patient presented with cardiogenic shock requiring ICU admission. The most common ECG finding was sinus tachycardia, with 1 patient having diffuse T-wave inversions. Leukopenia was present in 33% cases, but notably thrombocytopenia was not seen in any of our patients included in our study. All patients had high disease activity even after excluding the presence of myocarditis. Immunological profile showed that there was elevation of dsDNA levels in 5 out of 6 patients. There was low C3 levels in all patients, that is 6 out of 6 had low C3 levels. On cardiac biomarker evaluation, 4 out of 6 patients had high serum troponin levels, and 4 out of 6 patients also had global LV hypokinesia with a reduced ejection fraction. 1 patient had presented with a normal LV function but had incidentally detected heart block. 1 patient had a high-risk antiphospholipid antibody profile with a triple antibody positivity. All patients received steroids, and among the immunosuppressive therapy, half of them received MMF, 2 patients had received rituximab, and 1 received cyclophosphamide. And all the patients had clinical improvement at the time of discharge. 1 patient who had an incidentally detected heart block had eventual resolution of the PR prolongation at a 3-month follow-up. Among the patients who had LV global hypokinesia with a reduced ejection fraction, that was 4 patients. At 3-month follow-up, 2 patients had stabilization of the LV ejection fraction, whereas 2 patients are yet to follow up. So myocardial involvement is an uncommon manifestation of SLE that can show significant variation in terms of clinical presentation. The treated patients did well in our cohort after 3 months of treatment. So high index of clinical suspicion for the diagnosis of SLE myocarditis is thus warranted, as there are no specific criteria for the diagnosis of SLE myocarditis. This remains largely a clinical diagnosis. Thank you.
Thank you. I've got couple of questions for you. Do you think it is, if you label it as cardiac involvement of SLE, cardiac involvement in SLE, than a myocardial involvement? And you said a number of times that the disease activity is high. What is the tool you used? And when you say myocarditis and myocardial involvement, what are the investigations you considered?
So for myocarditis in particular, it was mainly a clinical diagnosis based on the features of myocardial dysfunction, like I mentioned, as when they presented with dyspnea, and along with an elevated cardiac biomarkers or echo showing any features such as reduced LV ejection fraction or regional wall motion abnormality not in a coronary artery distribution, because there are no specific criteria for SLE myocarditis. The gold standard remains an endomyocardial biopsy, which is difficult to do in a clinical setting, or even a cardiac MRI, which again is not specific for SLE myocarditis. The features still are described only for viral myocarditis or myocarditis of any etiology. So,
But it does describe about myocarditis, isn't it, if you do a cardiac MRI?
sorry, sir.
You can say whether it is a myocarditis or not.
Definitely,
with
sir.
yeah.
We can
So you
say
got
that.
other tools to substantiate it could be SLE, isn't it?
Yes, sir.
So what is the disease activity? How did you calculate the disease activity?
The disease activity here mainly was based only on the immunological profile. So that is elevated dsDNA and hypocomplementemia was present in all our patients.
But does it work like that?
The SLEDI could not be calculated retrospectively, so I only considered the dsDNA and the low complement. So.
No, we do agree it is a observational retrospective study.
Yes, sir.
But yeah.
Dr. Ravichandran, yeah.
Out of more than 360 patients, how many of them had overall cardiac involvement in SLE? That is question number one, because only 14 patients had myocardial dysfunction.
Yeah.
And your statistics shows only for 6 patients.
Yes, sir. We didn't. We considered.
How the diagnosis of clinically myocardial dysfunction was arrived?
We considered only
And
myocardial
how many of them
involvement.
had associated hypertension and hypothyroidism?
We considered only myocardial involvement, sir, because many patients can have evidence of serositis such as pericarditis. Our study was only mainly focused on the myocardial involvement in SLE. So when we did a retrospective study, the patients who pinged as involving myocardial dysfunction were only assessed. And only those who had a new onset of myocardial dysfunction were included in our study. So we did not include any patients who had any endocarditis or pericarditis in this. Patients did have associated hypertension, especially there were 67% of patients who had lupus nephritis. So there were patients who had hypertension, but hypothyroidism was not there in any of our patients. So.
Dr. Rajamani?
I appreciate that the treatment of this can be extremely difficult. And by and large, most of the cardiologists will call us and say, hey, look, I've got this chap with severe heart failure, almost cardiogenic shock. Are you going to give him pulse steroid? Are you going to give him cyclophosphamide? And I do appreciate the management is difficult. But you at random quickly run through that and said, we gave steroid, cyclophosphamide, MMF. You had only 6 patients. Can
Yes.
you tell me what did you do when you had this acute phase?
Initially, all patients have received high-dose steroids, sir.
So you gave a patient with heart failure IV methylpred. I'm just giving this because I know there are many clinicians here.
Yes, sir.
You gave IV methylpred, correct?
Some patients received 1 mg per kg steroids, sir, and some patients had received IV methylpred. It was also largely affected by the presence of concomitant lupus nephritis in these patients.
How many patients did you use cyclophosphamide straight away?
3 patients had received MMF, 2 patients
No, not
cyclophosphamide.
MMF. Talking about cyclophosphamide.
One patient, so 2 had received
Of the
rituximab.
6, 1 had cyclophosphamide
Yes, sir.
straight away, and the remaining of them had IV methylpred.
No,
Correct?
sir. No, sir.
It's a clinical question, actually.
No,
This
sir.
is important for all of
Yes,
us
sir.
because we are clinicians here, and you had only 6 patients, and all of them had congestive failure or heart block or even in cardiogenic shock. And many of you have the questions, hey, can you give 500 or 1 gram of methylpred? Can you give IV cyclophosphamide? So we're learning from your experience. That's what I want to know.
One patient presented with cardiogenic shock, sir. The other patients had a reduced LV ejection fraction that was approximately an average of around 40% ejection fraction was there, sir. Only one patient had a heart block that was a first degree heart block as PR prolongation. So only one patient had presented with cardiogenic shock.
Thank you, Kavya.
So for the next oral presentation, I invite and welcome Dr. Le-meredian, sir.
A very good morning to all.
Today I'm going to present the different cases with the different facial manifestation, and let's go for the clues over face. And this is the first case with it's a 17-year-old girl presented with the acne-like distribution of symmetrically distributed inflammatory papulopustules on the face with the background of erythema for last 6 months. And there were no systemic symptoms, and on examination there were bilateral lacrimal gland enlargement, cervical lymphadenopathy, it was non-matted and non-tender, and other system examination was within normal limit. And this is a picture that shows this lesion over the face and over the anterior aspect of the scalp. And we can see that the lacrimal gland enlargement of the face. So we proceeded with the investigation and shows normal CBC, liver function test, electrolyte, and so initially what happened outside they were did skin biopsy that shows features of granuloma over this lesion. So we proceeded with the ACE, IgG4, and for the suspect of tuberculosis, we did HRCT, thorax and abdomen, and also in view of lymphadenopathy also we included abdomen in CT, so it was normal. So due to the enlargement of bilateral lacrimal gland, we proceeded with the MRI orbit, which showed bilateral lacrimal gland enlargement with homogeneous enhancement. And the skin biopsy shows granulomatous non-necrotizing inflammation. Also we did biopsy from the lymph node and the lacrimal gland. It also shows the similar kind of non-necrotizing granulomatous inflammation. So there are cutaneous features over face with the granuloma of non-necrotizing inflammation. So it was actually the diagnosis of lupus miliaris disseminative facie. And so the differential we have to consider in case of LMDF is tuberculosis and sarcoidosis. And this patient actually, there are no features of tuberculosis and it was non-necrotizing granuloma, and she was started on methotrexate and prednisone 0.5 mg per kg. And these are the skin lesion after 3 months. You can see that there is improvement, but there is scars are there over face. And second case is a 50-year-old woman with history of non-deforming inflammatory arthritis for last 3 years present with the submental swelling. And there were no other complaint for patient. And on examination, there were firm to hard subcutaneous swelling over the extensor aspect of the right elbow was also there. And there were no systemic symptoms, and examination showed babasal crepitation and other system examination were within normal limit. And there was history of inflammatory polyarthritis with the subcutaneous swelling, and we considered a diagnosis of rheumatoid nodule or paniculitis, and the investigation revealed everything normal, including rheumatoid factor, ACP, and ANA. But the calcium level was 11.4, and the PTH was normal, and the AC level was elevated, it was 185, and HRCT showed NSIP ILD. So biopsy from the submental swelling showed necrotizing granuloma inflammation suggestive of sarcoidosis. And this is actually Darrier-Rossi sarcoid. And the third case is a 50-year-old male presented with a recurrent periorbital skin lesion characterized by erythematous papule and nodule only over the left eyes. And he is also having polyarthralgia involving multiple small joints including PIP and MCP. And there were no other systemic symptoms, and examination showed soft to firm subcutaneous nodule and papule in the left periorbital area. And other system examination was within normal limit. And there were good response to low dose steroid from outside. So in view of recurrent periorbital skin lesion, good response to low dose of steroid and no systemic manifestation. We proceeded with the skin biopsy directly, and it's nothing to suggest to any other disease. The biopsy directly showed non-necrotizing granulomatous inflammation. One of the close differential for this diagnosis is cutaneous tuberculosis. So these three patients with the different facial manifestation, one is like LMDF type of presentation, other is subcutaneous nodule, and other is recurrent periorbital skin lesion. So all comes to the diagnosis of sarcoidosis. So usually we will not suspect only if the patient presents subcutaneous nodule, we will not suspect sarcoidosis in our first differential diagnosis. So LMDF is basically a granulomatous disease predominantly involving face, and we know that sarcoidosis, the sole manifestation as initial presentation is only in 3% of cases, and there were only 2 cases of LMDF with the sarcoidosis have been reported. So we should always rule out cutaneous tuberculosis in case of LMDF. And this cutaneous sarcoidosis is known as a dermatological masquerader, affect roughly 25% of the people with the systemic illness. And regarding Darrier-Rossi syndrome, it's a rare presentation of sarcoid present clinically as non-tender fleshy nodule with range in size between 0.5 and 2 centimeter. And it's strongly associated with systemic disease, especially ILD. In our case, it is associated with ILD even though patient is asymptomatic. So what you see may differ in these cases, but the truth is same and the diagnosis is same. So thank you.
In your case series, did you see any extra pulmonary manifestations other than cutaneous, particularly about the joints, spine, or peripheral joints?
One patient is having symmetric inflammatory arthritis, other patient is having polyarthralgia, and there were no other systemic symptoms.
Which joints are predominantly involved?
Which
Joints.
joint is basically the PIP, MCP in the patient with the polyarthralgia, and other patient it was like it's PIP, MCP, it's like a RA distribution of involvement. So that's why initially we thought the possibility of rheumatoid nodule in presence of nodule over the extensor aspect and over the segmental area.
I presume the CCP antibody is negative, yeah?
Yeah, it's negative. Yeah, serology were negative. Actually.
Thank you. Okay, thank you. If there is no further question, we'll move on to the next case. Thank you.
Thank you.
So next presentation, Dr. Jitin Varghese Guruvilla, sir.
Yeah, you can start.
Good morning, respected judges and dear colleagues. I'm here to present about the gender-specific profiles of SLE patients in our center. My mentors are Dr. Sridevi S. and Dr. Jacob Annie from Department of Rheumatology. So coming to it, SLE is a multifaceted autoimmune disease, and there is a significant difference among the male and female genders because male population represent only a minority in majority of the studies that is previously published. So our study aim was to uncover any significant gender disparities in our center. And a retrospective gender-based analysis was done, and all patients diagnosed as SLE by ACR regular criteria were included. From the results, we can see that a total of 106 patients were analyzed, and the mean age was somewhere between 24 and 25 for the total study, and the duration was less than 4 years. The most common initial manifestation here was musculoskeletal. Most patients complained of arthralgia, but the significance is that male patients had more complaints of arthralgia, and also they presented with neuropsychiatric manifestation compared to females, and this was significant as well. You can see from the clinical features, the patient subsequently developed constitutional symptoms, musculoskeletal and cutaneous. They dominated, which is in literature as well. But here you can see that hematological was also somewhere around 60%, with 50% of our population having thrombocytopenia as well. And neuropsychiatric was also somewhere to 40%. On the antibody profile, the ANA was positive in all patients. Anti-DSDNA was in 60 patients, and anti-Smith in 35%, which corresponds to literature as well. From mortality, 5 patients expired, unfortunately, in the female group, and 3 in the male group. So the discussion part, the systemic involvement showed notable gender disparities. One was the neuropsychiatric issues. That is, males were 3 times more likely to present with acute confusional state and seizures compared to females. And also, they were found to have leukopenia as well, which was significant, 64 versus 28%. And coming to pulmonary involvement also, we had 3 patients with lupus pneumonitis. That was 21% in our cohort. So these were the significant findings we found. And also the males had higher number of hospitalization after the initial diagnosis, with at least 57% having 2 admissions compared to 26 in females. Then 46% of our patients had at least 1 episode of disease flare, but only 16% had an infection. The SLE damage index at 1 year was 14 for females and 4 for males. However, we did not observe a significant difference among the sexes in damage index. The comorbidities were only present in females, and that too, the most prevalent was hypothyroidism. So coming to the comparison with other studies, a recent study published in BMJ showed that the disease course were similar, but the male patients had displayed of higher APS. And men were more likely to have experienced neuropsychiatric manifestations in the Hopkins lupus cohort in 2012. And a study published in 1994 from SLE in Indian population, there were incidents of mucocutaneous and renal involvement, but the neuropsychiatric was comparatively less in that study. Coming to the mortality outcome, among females, musculoskeletal involvement was universal in all patients who expired. This actually aligns with the study conducted in Spanish rheumatology cohort that was published in Oxford, and they found that particularly musculoskeletal and cardiovascular involvement has a significant predictor in mortality. In males, however, the pattern slightly differed. All the patients who were expired had cutaneous involvement, and 66% had neuropsychiatric symptoms as well. Most of them had acute confusional state and seizures. And the interesting thing is that out of the 3 patients, male patients who expired, 2 were APL antibody positive as well. So this means that somehow the APL antibody may have a contributing factor such as an increased risk of thrombotic events. And so we suggest that APLA could also serve as a critical biomarker in assessing mortality risk for male patients in our study. So this was the key points. Males with SLE exhibited higher rates of arthralgia and neuropsychiatric manifestation with a shorter duration from onset to death. APL antibodies were significantly positive in those who expired as well. The clinical implication is that we could identify the at-risk individual and have a warranted close follow-up, and also treatment could be tailored for them. The limitations is that since the male population is less, there is a chance that I'm committing a type 2 statistical error as well. So, thank you.
Thank you. So
Thank you. You are trying to tell us quite a lot of information in this slide, and in the topic, you're talking about gender profiles and the complications of each profiles, and it's difficult to, as we know, neuropsychiatric complications are not easy to diagnose, and they are not a very common complication. It's usually arrived after quite a lot of workup. So what was the commonest complication you had in the few set of patients you had?
Among the neuropsychiatric presentation, they presented with acute confusional state, and one patient had seizures as well. We did a lumbar puncture. The proteins were elevated, but the MRI also we did, and that showed focal hyperintensities which were suggestive of vasculitis. And the APL antibodies and the anti-dsDNA and ANA were positive in these patients as well.
have you checked the ENA profile? Have
Yes.
you looked correlation of anti-SM antibody with neuropsychiatric manifestations?
You said you have in your slide.
Anti-SM, yeah.
The anti-Smith was positive in 35% of the
35%.
population.
Okay.
The neuropsychiatric patients among that group, we haven't analyzed it yet.
Okay, thank you. Dr. Ravichandran?
Yes. The youngest patient in our cohort, was diagnosed at the age of 10 years. So, from 10 to 16 years, there were 20 patients.
Childhood SLE and adult SLE, because pediatric they have equal, both men and female are equally affected. Only in adolescence, the females predominant.
Yes.
That is why you get more positive report in males, because you are mixing the pediatric and adults.
Okay.
I think that is my observation.
Okay, thank you. One
Thank
more
you, sir.
question from Dr. Rajeshwari.
I may be wrong also if I listened, I didn't listen properly. The anti-dsDNA levels, did they correlate with the neuropsychiatric component?
The patients had ANA positivity, and anti-dsDNA was positive in 2 patients also.
Neuropsychiatry,
Yes,
what is the
in
correlation of anti-dsDNA with neuropsychiatry involvement?
We did not do that analysis, madam, but
No,
usually...
I'm asking
no,
about what you
there's
read.
there's not a correlation.
Does not correlate.
There's no correlation, but we got positive in 2 patients.
That means they had disease activity elsewhere also.
Elsewhere, yes, madam. They had renal
Did
involvement.
it correlate with renal?
They had renal involvement as well.
So the upshot, what madam is trying to say is it was not specific.
Yes, sir.
So if I am a physician and a rheumatologist, a confused patient comes in, I normally think it's an infection, so I start from there. So there was no specificity there. That's what.
Yes. Thank you.
Thank you.
Dr. Aravind P.
Aravind P.
Good morning all. My topic is analysis of ACR, SLIC and EULAR by ACR 2019 classification criteria in childhood onset systemic lupus erythematosus in a tertiary care center in South India. So the background, the childhood lupus constitutes 10 to 20% of overall lupus cases. It is associated with rapid course and higher disease activity severity compared to adults. There are no exclusive classification criteria for use in childhood lupus. Very few data are available regarding the epidemiology of childhood SLE in our population. So the primary objective is to analyze the performance of 1997 ACR criteria, 2012 SLIC criteria, and EULAR by ACR 2019 criteria in childhood SLE. Secondary objective is to study the epidemiology of childhood SLE in our center. So methods, it's a retrospective medical record review of children with a clinical diagnosis of SLE. The inclusion criteria is children less than 18 years of age admitted with a diagnosis of SLE in a tertiary care center between January 2019 and July 2024. Exclusion, child with SLE overlap with other CTDs, they are excluded. All the three classification criteria, ACR, SLIC, and EULAR ACR, were applied to these patients and were compared against a gold standard of physician diagnosis. That is by 3 qualified rheumatologists in our center. So, results, the total number of patients were 75, out of which the female to male ratio was 6.5:1. So, the median age at the onset of SLE in our cohort was 15 years. Median time from the onset of symptoms to diagnosis was 4 months. So 7 cases were diagnosed after 1 year of the onset of initial symptoms. Those cases were presented with arthritis, that is 3 patients, 2 patients presented with ITP initially, 2 patients presented with skin involvement, and 1 patient presented with abdominal vasculitis initially. That was the reason for the delayed diagnosis in these 7 cases, that is more than 1 year of onset of symptoms. So the mean score of ACR, SLIC criteria in our cohort was 5 and 6 respectively. The mean score of EULAR ACR 2019 in our cohort was 21. So this is the chart representing that. So the most common clinical domain that was positive in ACR criteria was arthritis, and that was positive in SLIC criteria was alopecia. Whereas the most common clinical domain that was positive in EULAR ACR criteria was fever, because children present more with constitutional symptoms. So ANA positivity was the most common clinical immunological domain positive in both ACR and SLIC criteria. The most common immunological domain that was positive in EULAR ACR 2019 criteria was dsDNA positivity. 16% of patients, that is 12 patients, who did not classify the 1997 ACR criteria had a positive score of more than 4 in the SLIC criteria. None of the patients who satisfied the ACR failed to meet the SLIC criteria. 2.6% of patients, that is 2 patients, who did not satisfy both ACR and SLIC criteria were diagnosed based on the EULAR ACR 2019 criteria. 1 patient who did not satisfy all the 3 classification criteria of SLE was diagnosed based on the expert consensus opinion. 80% of patients satisfied the ACR criteria, that is 60% patients out of 75. That is, the sensitivity of ACR criteria was 80%. 96%, that is 72 patients, satisfied the SLIC criteria. That the sensitivity of SLIC criteria was 96%. And 98.66% was the sensitivity of the EULAR ACR 2019 criteria. Only 1 patient did not classify the EULAR ACR 19 criteria. Conclusion, EULAR ACR 2019 criteria had better sensitivity compared to ACR and SLIC criteria in childhood SLE. This is due to the wider spectrum of manifestations covered under the EULAR ACR 2019 criteria. Thank you.
Good attempt. Just a quick question on that numbers. EULAR ATR, you said 65 out of 75 fulfilled the criteria. Your numbers said 65 out of 75.
No, sir. 74 out of 75.
74 out of
Only 1 patient did not classify the EULAR ACR criteria.
Sure. There was a mistake in your thing. I think, yeah. Instead of
what is the total number of SLE patients during that study period? Out of that, you come to a conclusion of 74 patients.
Yes.
And as per the criteria, you said 18 year or 16
18
years?
years, sir. 18 years was taken in our study, sir.
Why? Because any pediatric onset, anything onset less than 16 years considered as a childhood
Yes, sir.
onset.
There are
Why 18 years?
Yes, sir. There are different studies quoting 16 years few studies and 18 years as in few studies. Sir, there is no definite criteria cutoff for as 18 years in or as 16 years in most of the studies. Some studies are also there citing 18 years as childhood SLE. Sir.
The total number of SLE during that study period?
75. Sir.
No, that is your pediatric. No, I am asking about total adult and pediatric.
Sir, we selected only the pediatric patients coming to our OPDs.
So no out.
Of course, all these criteria for, most of the criteria for pediatrics are evolved from adult onset diseases, isn't it? But the manifestations of pediatric lupus are almost, many of them are totally different. The initial onset, etc., the neuropsychiatry, the renal, all of us know all that. So I don't know, it's a genuine doubt. Yours is a very good analysis, a very creative idea, but how far is it going to be applicable to children when we apply these adult criteria, especially lupus being a very heterogeneous disease?
Yes, so the main difference in the presentation of lupus between adults and pediatrics is the predominance of constitutional symptoms in the pediatric population. The other two criteria, initial criteria, they did not take into consideration the constitutional symptoms at all. So in this 2019 EULAR ACR criteria, the weightage for constitutional symptoms is given. So in that way, if we apply this EULAR ACR 2019 criteria to the pediatric SLE population, the sensitivity of picking up more cases because of the constitutional symptoms is increased. So in this way, this study is validated. As far as now, the studies which validated this criteria in pediatric SLE found that this EULAR ACR is more sensitive. But studies are still lacking in this aspect, especially in India, these studies are still lacking. Thank you. We need more studies on this. Thank you.
The constitutional symptoms, it's always a hallmark of adult SLE also. It's not only for the pediatric one. Pediatric present, as Madam said, in a very different way. Because the kids, sometimes they do not know how to express on constitutional symptoms, so I'm not sure.
Fever, actually, yes, sir, that is correct. Fever is more, in our study, fever is present in most of the kids, sir. Most of the patients, fever was the main presenting complaint, sir. 1 month fever, 2 months fever. That helped us gain more sensitivity in the third criteria. Sir.
Okay, thank you. There is no further question. We'll move on to the next case. Thank you.
Dr. Ashwati Sukumaran.
Good morning all. Today I am here to present on our study, could isolated anti-Rho52 be a harbinger of occult inflammatory myositis, a single center experience. So as we all know, anti-Rho52 autoantibodies are common in different autoimmune diseases. Despite their prevalence, Rho52's diagnostic specificity is still debated. So the idea of this study was prompted by a case of a 46-year-old lady who was symptomatic from 2003 in the form of joint pains and Zika. She presented to us with a similar complaints in 2013, and we diagnosed her as Sjogren's based on arthritis, Zika symptoms, ANA profile showing Rho52 positivity, and a positive Schirmer. She was managed with hydroxychloroquine and leflunomide and attained remission. And in 2023, she developed intractable cough followed by dyspnea and desaturation. And during admission, she was hypoxic with an SpO2 of 74%. And her HRCT thorax revealed subpleural ground glass opacities and nodules on the lower lobes. And on evaluating for the course of ILD, she was found to have strong OJ positivity. And hence, she was diagnosed to have rapidly progressive ILD secondary to anti-synthetase syndrome. All the infective workups, including BAL, CBNAT, fungal growth, everything was negative. So she was managed aggressively with the pulsed with the steroids. She received 3 sessions of plasmapheresis, cyclophosphamide, later was treated with tofazanine. Despite all these therapies, we couldn't save the patient, we lost her. So usually, in our clinic, when a patients come with a non-specific symptoms like arthralgia and myalgia, we will perform an ANA. If ANA is positive, then we will do an ANA profile. And in ANA profile, if there is Rho52 positivity, we will label them as Sjogren's or UCTD based on their clinical symptoms. So are we missing the real diagnosis or should we test for myocytic specific antibodies was our research question. So the aim of our study was to assess the presence of myocytic specific antibody in isolated Rho52 positive individuals. So we included all the subjects with isolated Rho52 positivity and excluded the patients with a diagnosis of previous diagnosis of myositis or ILD. So coming to methodology, we collected the data of patients who have done ANA profile between 2019 to 2022 with an isolated anti-Rho52 from our electronic database, and their samples were tested for myocytic specific antibodies using Euroimmune myositis profile 4-line immunoassay. These patients were then extensively evaluated for occult myositis. These are the initial results of an ongoing study. So after screening around 512 patients, we identified 62 patients with the isolated Rho52 positivity. Until now, only 26 patients were recruited, and among these 26, 9 had OJ positivity with 6 strong positive cases. This is another case. She's a 37-year-old lady who have joint pains and myalgia and initially was on Ayurvedic treatment. She presented to us in 2023 and we diagnosed her as Sjogren's and was managed with colchicine, hydroxychloroquine and low-dose medrol. And after evaluation, she was found to have strong OJ positivity and an HRCT and a whole body MRI was done, and HRCT revealed fibrotic NSIP pattern 8 to 10% of lung involvement, and MRI revealed mild edema on the gastrocnemius muscle. Hence, her diagnosis was revised to ILD with OJ positivity, and the treatment was switched to MMF. So these are the data showing of all the OJ positive patients, 6 patients. So the first one was the index case. As I have already explained, she expired. The second one, we picked up NSIP pattern and mild edema, so we switched her to MMF. The third case, she had IPA, rashes and myalgia and Rho52 positivity. And on evaluation, she found to have a elevated CPK and LDH, hence she was also switched to MMF. So out of 6, 3 patients had occult features of myositis and the others are on our follow-up. So whenever patients come with an isolated Rho52 positivity, perform a myositis profile because it might be helpful to detect potential underlying myositis activity early, even in the absence of clinical symptoms. So future studies involving larger cohorts and follow-up is required. Thank you.
Thank you. So in the first case, so the case was treated with hydroxychloroquine and leflunomide.
Yes, sir.
Why not methotrexate than leflunomide? That is the first question. And I'm not sure whether I've seen a CK level in any of your cases.
Sir, CPK level I have given, sir.
I may be wrong.
For the index case, she had an intolerance with methotrexate initially. That's why we switched to leflunomide, and she was maintaining remission. Her CPK during the time of admission was also checked, and it was normal.
Thank you. You were doing the profile of these patients. You're saying that we have to think about the Rho antibody positive patients for myositis screen.
Yes,
and how often it is present?
Sir, actually,
extended myositis screen, which is what you're doing. And if you confirm the myositis, did you do a muscle biopsy? Or the management point of view, did you try any patient with rituximab rather than just methotrexate?
sir?
Did you try methotrexate or did you want to try rituximab on this group of patients? It's okay.
Just the first patient, the index patient, had a rapidly progressive ILD. Leflunomide is well known to cause a rapidly progressive ILD. So that's one possibility we have to keep in mind.
Okay, sir.
Yeah, because generally OJ may not be as aggressive as a rapidly progressive ILD. So that patient may be leflunomide induced in this lung disease.
So another one is the colchicine. I saw that in one of your patients, third patients. It started with colchicine, isn't it?
Colchicine, yes, sir.
Why?
Because the patient had intermittent arthritis, that's why.
I'm learning.
Okay, thank you. If there
Thank
is no
you, sir.
further questions, we'll move on to the next one. Thank you.
Dr. R. Aishwarya.
morning. I'm presenting the small airway dysfunction in patients with systemic sclerosis. So we know that scleroderma lung disease is typified by ILD and PHT, and there are increasing reports of small airway dysfunction in patients with ILD and IPF. Structurally, the small airways are known to resemble the small vessels, and they are usually evaluated by use of nitrogen single breath wash technique. Alternatively, impulse oscillometry and spirometry can also be used for assessment of small airway dysfunction. So our primary objective of the study was to evaluate the presence of small airway dysfunction in scleroderma patients using the spirometry and impulse oscillometry. Secondary objective was to assess for the large airways and elastins using the same techniques. Coming to the techniques that we have used, we know that the spirometry has already been established for diagnosis and monitoring of ILD in systemic sclerosis, and these are the various parameters in spirometry and impulse oscillometry that can be compared for the resistance, reactance, and small airway. It takes about 6 seconds for the spirometry to be performed. For impulse oscillometry, it is 30 seconds. Both are done in sets of 3 and the best of the 3 act is taken. Advantage of using the impulse oscillometry is that it is completely patient friendly, does not require the effort of the patient. All the patient has to do is to take the tidal breathing, and incremental oscillations will be provided at the mouthpiece, and the reactance and resistance can be calculated. In the real world, the cost of investigations remains comparable, and as we can see in the picture, there is not much of difference between the obstructive and restrictive pattern when we use a spirometry, but when we use an impulse oscillometry, it is possible to differentiate whether it is a large airway or small airway and whether it is a resistance pattern. But the problem with use of impulse oscillometry is that the values are not standardized and is not homogeneous. For this study, we have used the reference quoted below that was being done in the asthma, and the values have been taken for comparison. So coming to the methodology, we have included consented patients with a diagnosis of scleroderma as per the 2013 ACR EULAR criteria. We have excluded children less than 18 years, patients with a history of smoking, with a risk of occupational lung disease, overlap with other CTTs, and recent history of exacerbation. The total number of inclusions were 40. The clinical details, investigations including the immunological investigations were taken. Borg dyspnea scale was graded. Their HRCT in the previous 6 months was taken into consideration, and they were subjected to the impulse oscillometry by the Antilla machine, followed by spirometry by the same technician on the same day. So these are the results. A baseline character shows that it was predominantly the females, and the mean age was 39 plus or minus 8. Mean disease duration was 4 plus or minus 2. Predominant type of scleroderma in our study was diffuse cutaneous, and the predominant antibody was SCL70. 80% had ILD, 20% without ILD, and the predominant ILD was NSIP. Coming to our primary objective, we could see that 20 patients were detected to have small airway dysfunction by oscillometry and 23 by spirometry. So they both performed comparably in detecting small airway dysfunction in patients with systemic sclerosis. And of these patients with a small airway dysfunction, a considerable amount of them also showed a airway reversibility following inhaled short-acting bronchodilators. So there is a component of reversibility in the small airway dysfunction that is detected in systemic sclerosis. And when coming to better airway localization, we can appreciate that the impulse oscillometry was able to pick up whether it was small airway obstruction, large airway obstruction, or restrictive pattern, while the spirometry showed that it is only obstructive or restrictive pattern. So impulse oscillometry has a better airway localization when it comes to identification. Coming to our other secondary objective, as we can see, as per HRCT, ILD was reported in 80%, PFT detected a restrictive pattern in 92%, and impulse oscillometry detected restrictive pattern in 70%. So there was an extra overestimation by the PFT, probably related to the poor patient efforts. And we tried to perform a multiple regression analysis and removed the possibility of pulmonary hypertension and restrictive lung disease as a cause of dyspnea. And we were able to demonstrate that the Borg dyspnea score did correlate with spirometry and impulse oscillometry, spirometry performing little better than the impulse oscillometry. So to conclude, we conclude that the small airway dysfunction is seen in patients with scleroderma, and a considerable amount of them do demonstrate reversibility, opening additional therapeutic options. And impulse oscillometry may be an effective alternative to spirometry in diagnosing small airway disease and the other patterns, and it also shows a better airway localization. But the limitation of our study is the lack of standardization in the impulse oscillometry, requirement of the special equipment. The sample size was little less, so the generalizability is a question, and we did not include any healthy control population for the study. Thank you.
Thank you. Did you consider pulmonary function test in this?
So we did not perform the complete pulmonary function testing, sir. We did only the spirometry, sir.
Why?
So we don't have the access for the body plethysmography.
Do you think you need to?
So it does include all components of lung function if we do it as a pulmonary function test.
Does it necessary in this case, scleroderma?
Maybe, sir.
I think it will be, isn't it?
Yes, sir. GERD was present in about 40% of the patients. That was present in 40% of the patients, ma'am, but we did rule out when we did a regression analysis, ma'am.
Thank you. Thanks
you,
so much. Thank you.
Thank you.
Thank you very much for all the case presenters. And I think we finished all the cases. And thank you very much for your active participation. And that concludes the session. Thank you.
Thanks to Dr. Gladstone Chelaya and Dr. Murthy for chairing this session.
So we are going to start the So we are going to start the session 1, hopes and disappointments. And for this, I invite the chairpersons, Dr. Jacob Anthony, Professor of Medicine, HOD Rheumatology, Government Medical College, Trivandrum. And also I invite Dr. Ruchika Goel, Professor in Department of Clinical Immunology and Rheumatology, Christian Medical College, Vellore. So I request the chairpersons to introduce the speakers.
So very good morning to one and all. At the outset, I thank the organizers for giving me the opportunity to chair these very important sections. As we all know, rheumatological disorders are, once it is considered as incurable, untreatable, or uncontrollable diseases, now we know that we have a number of molecules in our therapeutic armamentarium to treat, to control, to cure most of the rheumatological conditions. So even then we have some lacunae are there. So to enlighten us this topic, we have eminent speakers and hopes and disappointments. First I invite Dr. Vikram Raj Jain to present his topic.
So, very good morning to one and all. Thanks to the organizers for giving me this opportunity to talk on this hopes and disappointments in rheumatoid arthritis. So, I'll just start off with a very common story which all of us face in our OPD. A 56-year-old lady came in wheelchair. She's seropositive rheumatoid since past 20 years. She has severe deforming arthritis. She needs bilateral TKR. She has other extra-articular manifestations. And she has been treated with NSAIDs and steroids in the past by various GPs and orthopedic surgeons. She got a little bit disheartened. She started for alternative therapy, and she didn't get any significant relief. And she visited rheumatologist, and she had various DMARDs, some of which she was intolerant. She received rituximab. She didn't get response. She had good response to TNF. And yeah, I just want all of you with this background to just sit back and think about this patient and see how did we reach here and what we could have done differently in this patient, not only in this patient, in future patients, so that we avoid such a scenario. And this is where I'm coming to my topic, that is hope. Hope is to want something to happen or to be true. And we want in our patients that we are able to diagnose them early, we treat them early, we prevent deformities, we prevent complications. This is our hope. And today's hope obviously is, can we predict the development of rheumatoid arthritis? Like in this patient, could we have predicted her arthritis beforehand? If we could predict, could we prevent her rheumatoid arthritis? And if not prevent, at least could we pick up the diagnosis at an early stage so that we could initiate appropriate treatment, put her disease in remission, and personalize the treatment to get better, better outcomes, and also prevent complications which is suffering from present. So that moves to my first hope, that is, can we predict rheumatoid arthritis accurately? Now we all know the pathogenesis and the evolution of rheumatoid arthritis. Now it is very well understood. Though we have a preclinical phase where there is, in presence of genetic and environmental factors, there is local and systemic autoimmunity, which progresses to arthralgia and non-articular symptoms, and finally arthritis. And at this preclinical stage, can we detect patients of rheumatoid arthritis? And this is a big area of research which is presently going on. And we know all the traditional risk factors like the shared epitope, genetic risk factors, first degree relatives, the female sex, as well as cigarette smoking, obesity, inflammatory diet, and infections like lung disease in the lung or periodontal inflammation, which are known risk factors for rheumatoid arthritis. But do we have better biomarkers to predict rheumatoid arthritis? And in most models presently, still high levels of ACPA antibodies impart the highest risk. There are other antibodies like anti-CARP, anti-MMA, anti-PAD, which still need more validation. Alteration T cell subsets, B cell signatures, type 1 interferon signatures are also associated with increased risk of incidental RA, but again, this needs more validation. There are studies on serum proteomics, sputum abnormalities, which also suggest potential utility. Moving on from biomarkers, other imaging ways that you can predict rheumatoid arthritis, and this is where probably we are better than biomarkers. We already have ultrasound and MRI, which can detect subclinical inflammation. Tenosynovitis of the hands, we know, is an independently associated with future RA, especially flexor tenosynovitis of the hand or extensor carpi tenosynovitis. In presence of clinical suspect arthralgia and aqua positivity, can predict the development of RA. Other prediction models, there are various prediction models where they have combined all these various biomarkers, clinical data, autoantibodies, genetic data, lymphocyte subset, and cytokine analysis to form a combination of models which have now shown to be effective at predicting, but we still need long-term studies, we still need validation. So where are we now? To a certain extent, yes, we can predict RA accurately. At-risk individuals can be increasingly identified. Understanding of our disease pathogenesis and evolution has improved. So definitely we are better placed at predicting RA. But how does this translate? How does this help us? So if we can predict RA, can we prevent RA? And this is the burning question right now. And there have been various studies on methotrexate and hydroxychloroquine which have not shown prevention of RA. The prior study in rituximab, where a single dose of IV rituximab, 1000 mg was used, did not prevent RA, but could show delay in onset of RA by at least 5 months. This was in 2019. But the exciting part in this year is the two trials. One is the ARAYA trial, which was abatacept inhibiting inflammation and onset of RA in individuals at high risk, where individuals who are ACPA positive with subclinical inflammatory changes on MRI, who are at high risk of developing RA, received weekly abatacept for 6 months, and which showed that decrease in MRI inflammation, clinical symptoms, and you can see the blue line is patient on abatacept and the red is on placebo. And at 6 months of treatment itself, there was, the y-axis is cumulative incidence of RA. There was significant difference in the incidence of RA. And this is 1 year treatment-free interval. Even after 1 year, there was significant difference in development of RA without abatacept. So the effect of intervention persisted through a 1 year drug-free observation period. Similar is the APIPRA trial, which actually had a slightly different primary outcome. And, but again, they use abatacept for 12 months with a 12 months drug-free interval and still showed a significant difference in the development of RA at 6 months as well as the end of 1 year. So rapid strides are being made, but still we need long-term data. This is the most exciting area of research, and definitely hopeful that these will give us better treatment strategies. So if we miss the bus, what if we miss the bus, we could not prevent RA? Can we diagnose our patients early? Because diagnosis has shown, early diagnosis has shown definitely significant improvement in outcomes. And here there are a few different strategies. We know that diagnostic tests are now easily available. I remember when some of the seniors used to tell that even in Bangalore they had to send ACPA antibodies to Mumbai, but now it's available everywhere. Tier 2 cities, towns also have the tests available. All investigations are possible. They're reasonably affordable. And more of us rheumats also are increasing day by day. So the increasing awareness, increase of trained professionals, definitely we see that we are diagnosing rheumatoid arthritis early and definitely leading to better outcomes. So as our numbers increase, we are hopeful that we'll be able to diagnose more and more patients at an early stage. So if patient has developed RA, with availability of more trained doctors and diagnostic tools, definitely early diagnosis is now possible. So if you've diagnosed early, we still need better treatment strategies. So can we cure the disease? Obviously, at present, no, but at least achieve remission in most, if not all. And just to quote Philip Hench, during his Nobel acceptance speech, he said that give us the tools and we will finish the job. And he was in fact re-quoting Winston Churchill here. And we have large number of tools. We have large armamentarium of drugs, from conventional synthetic DMARDs, biologic DMARDs, as now targeted synthetic DMARDs, which have definitely shown that better remission rates are possible. So, but still we have a significant proportion of patients who are difficult to treat and polyrefractory. But we should understand that we live in the JAK era. The arrival of JAK has completely changed the game for us. And we have shown that generic JAK has definitely been the single most important hopeful thing which we now see seen improvement in outcomes. So apart from the remission, the important thing now, this teething problem is the personalization of treatment. And we know that one strategy does not fit all. We need personalization of treatment based on their molecular and clinical phenotypes. And here a lot of research, basic research is going on, which we feel hopefully will be an important parameter for us to treat patients. One of the remaining frontiers in treatment of RA is personalization of treatment based on molecular and genetic and phenotypes. So to conclude, in every step of disease evolution of RA, advancements are being made. Better treatment options and strategies are already making a difference. Predicting and preventing RA is a very exciting concept and hopefully will translate into reality soon. Personalization of treatment based on biomarkers seems to be the need of hour. Thank you.
So shall we, we'll call the other person, Dr. Suresh Adimolu, for the disappointment in rheumatoid arthritis.
So, good morning everyone. The time I got this email from Arul sir, I was actually going through some disappointments of my own. And I'll just tell you the story of these disappointments. My story won't be a lot of graphs and papers, but it'll be more of art of rheumatology rather than science of rheumatology. So the first story is of a patient who is a mother of a friend of mine. So my friend calls me one evening and says that my mom is going to go for a TKR. And he said, just WhatsApps me her X-ray. And I said, well, the X-ray doesn't look bad. And he says, no, I've already made arrangements and she's gone for a replacement. A few weeks later, I came to know that she passed away. And when I went to the funeral, I was cursing myself that, he is a friend of mine. I could have kind of insisted him to bring her either to me or somebody else. And, we could have discussed this over and this was an unneeded death. So I was cursing myself. So forwarding it to a few months. So I'm a keen golfer and I was on the golf course with one of my friends and we were like walking from hole to hole and he was like, oh, by the way, Suresh, today evening I'm having bilateral TKR. And I was like, you're walking fine, why do you need bilateral TKR? And he was like, I've got pain in my ankle. I was like, you have pain in your ankle and you're getting bilateral TKR done. He said, no, both the ankles are swollen up and I was told that I need bilateral TKR. So I was like, well, this is even worse. Then we'll look into it. So we went to the car parking. In the car parking, he opened up his X-ray and he showed me. And the left knee was like as good as my knee, and the right knee was looking as grade 1, grade 2, and it was slightly flexed, so it was looking worse than what it was. So I kind of told him that it's not too bad actually, but let's look into it. So because the previous story was in my mind, when I went to the clinic, I kind of called his son up and said, look, boss, this is not too bad, and I don't think he needs to go for a replacement. Why don't you bring him? And this was in the busy clinic, so they turned up, and I kind of put a probe on them, and he had rip-roaring inflammation in the ankles, and his Achilles tendons were inflamed. He had dactylitis. Of course, he didn't have rheumatoid arthritis, but he had very active psoriatic arthritis and the enthesitis, and certainly he was not a candidate to go for a replacement. So anyway, we had a long chat, and they were like, oh, we are convinced with you, we want to get it treated from you, but our only thing is we don't know how to tell the orthopedic surgeon. And I was like, that doesn't an issue. I'll spoke to the orthopedic surgeon and spoke to them. Anyway, fast forward, after 2 days, I get a WhatsApp message saying that we have had bilateral TKR done, and everything is fine. So I was like, okay, this thing, and I was like cursing myself. I'm a rheumatologist. I don't go and tell people out of the way what to do, and why did I even bother to tell them? So after a few weeks, again, I get a phone call from them saying that, actually we've got a big swelling on the calf, and then the doctor says that it's got an abscess and it needs to be treated surgically. So by this time, I was like thoroughly disappointed. Like, if you tell people what is the right thing to do, they're not following you. They don't follow you, and then they call you, and I was really, really upset and disappointed. Anyway, let's get into the disappointments of rheumatoid arthritis. So disappointments can be to the patient, and disappointments can be to the doctor. So the first disappointment the patient faces is, they come to see a kind, soft doctor, and imagine the disappointment when they see a bodyguard like my doctor sitting there in the clinic, and they're like, oh my God, I got to treat it. Half the disease is gone already. Okay, coming on. So the disappointment to the patient, see, the diagnosis itself we give to them is a shocking one, and they find it very difficult to take this diagnosis when we give them a diagnosis of rheumatoid arthritis. For us, it's just a rheumatoid arthritis. For them, it is a big shock to their life. They expect permanent cure, but we all know that permanent cure is not there. And also there is incomplete remissions. Impact on daily life, this is something that we don't always take into consideration. Again, this is a story. I went to one of my friend's house for dinner, and the lady was like, the curry is ready, can you come and pick it up from the stove and put it aside? So I was like, why are you not able to do it? Oh, ever since I got the arthritis, I'm not able to do it, but I'm pain-free and absolutely fine. So in the clinic, we always assess that is there any pain in the swollen tender joints, but still there is some things which impact their life, which the patients don't always tell to us. So it's very important that we should look into this. And looking at the side effect of medications is also another thing. Little bit of nausea, little bit of headaches, small rashes. Patients don't always tell us, but these things do impact their lives, such as little bit of alopecia. Psychological impact, I'm going to touch a bit on this one. So a lot of our patients, you must have noticed that patients, their relatives are generally quite a little bit of angry and upset on us. So a lot of their biological needs are not met. If you understand, like for us, eating, sleeping, sex, these are basic things of human life. And a lot of these patients, you can't expect them to have sex when they've got rip-roaring inflammation in the joints. So these things do play in their mind, and there is a lot of psychological impact that happens to the patients, and that comes to us in different forms. So it is important that we should understand them. Financial impact, for us, we think that, okay, this is one more blood test, one more thing, and but for some patients, every 1,000 rupees that keeps adding on to their budget is a constraint on their family budget. So that is another thing. And we know these all domains towards various quality of life measures. I've only put up SF36, and we know that all the domains, whether it be physical functioning, physical health, emotional health, overall vitality, emotional health, pain, and general health, all of them are quite low in patients with rheumatoid arthritis. Coming to the disappointments to the doctor. The biggest disappointment we all know is somebody comes to us and tells us about the alternative medicine. Sir, in your medicine, this problem is there, but in alternative medicine, there is no side effects, there is permanent cure and this and that. So this is something that all of us have to deal with, and my special respects to the doctors from Kerala. They have to deal with more alternative medicine therapies. Coming to patient adherence, see, I've got hypothyroidism, and since I've come to this conference, I've not taken a single tablet. And even when I'm at home, I don't always take a tablet. So we label them patients as having poor compliance or poor adherence. Being such a senior doctor, I myself am not taking it. I'm sure a lot of you will agree that we often don't complete our courses of antibiotics. And it is very difficult for us to expect patients to take tablet day in and day out. And it doesn't happen, we can't expect them to do that. Patient relatives, especially the ones from USA, well, I don't need to go there. All of you have faced these phone phone calls. In the busy OPD, they'll call you and eat up your time and mind, so let's not get there. Google is another thing which is as much beneficial as it's a strain for us doctors. Patients, half knowledge is more dangerous than full knowledge, as you know. Time, it's a peculiar thing, because when we doctors don't have a busy practice, we've got plenty of time to look at patients adequately. But as we get busy, as we are very busy practitioners, that's when we are not able to give time to patients. So if you are able to see, like, 5-10 patients, then you'll give them your full attention. But as we see more and more numbers, all of us will make mistakes, and this is what happens. And of course, in conferences, we kind of come and rubbish the presenters, saying that, why didn't you do this, why didn't you do that? But in the constraints of time, all of us make mistakes, and I think that is one of our disappointments as doctors. Coming to these packaged blood test results, this is another big disappointment, because patients often come with this big file of reports, and they want us to answer each and every single report which they've gone through a package. Another thing, lack of MDT, which we don't have in our setup. Coming to I know we are in a pretty much pharma-sponsored conference, but the pharma companies, like people coming in one after tofacitinib, write our tofacitinib, that is another disappointment that we all doctors face. Coming to the drugs itself, we all know that adverse drug reactions are there, cost of therapies, newer therapies, whichever come, are inevitably costlier, and this is a big disappointment. Variable response to different patients is there, that is another issue. Let's look at the efficacy of the drugs. Vikram was telling about different drugs that are there. So look at methotrexate monotherapy. So DAS28 remission is seen in only about 20 to 30%. And if you look at combination therapy, whether methotrexate with conventional synthetic DMARDs, it's about 30 to 40%. Triple therapy, 40 to 50%. If you go to targeted synthetic DMARDs, again, that's not much. Again, if you use methotrexate with biologics, it's about 40 to 50%. And if you look at long-term sustained remission, it's only about 10 to 15%. So, coming back to the previous story, so I wanted to end my talk with an illustration from Mahabharata. So, Arjuna, after the Kurukshetra Yuddha at the end of Dwapara Yuga, was taking about 100 ladies safely from when the Dwarka was sinking. And at that time, a group of bandits attacked him. So this is Arjuna, who has got the best weapons. He's the most skilled person on earth, and he was not able to kill these bandits. And some of these ladies were, killed, raped, and whatever. So he goes to Krishna and asks that, I'm the most skilled warrior. I'm the most having the best weapons in the world. Still, I was not able to save them. And Krishna replies to him that, look, the ones you were able to save is because their karmas were good. The ones you were not able to save is because their karmas was such that they had to face this thing. And the same thing, it was the answer to my disappointment which I was facing, and the disappointment to lots of you as doctors, that why do some patients, despite us giving the best of the care, we are not able to save their joints. And I think Mahabharata is one answer from Sri Krishna, saying that, you cannot cure everybody, you cannot treat everybody, accept, do your duty, and just understand that there is only so much that we can do, even with the best of therapies. The ones who are not destined to get better, even if you give them CAR T-cell therapy, will not get better. So with that, I would like to conclude. Thank you so much for giving this opportunity. Thank you very much.
Thank you, Suresh, for the nice presentation. So since we have two speakers, any clarification, any questions? Hopes and disappointments of rheumatoid arthritis?
If there's no question, I'll ask one question to Dr. Vikram. So Vikram, what do you think, how should we manage preclinical RA according to you, after PRAIRIE, APRAIRIE and APRAISE?
I'm looking at the trial data. Obviously, we are all really excited and thinking that maybe we should, but we need more data. We need more information. I think that to jump in right now. Data from methotrexate and hydroxychloroquine has been disappointing. So our common, usually what at least I would do was in preclinical put hydroxychloroquine in many patients if at all, if I have clinical suspect arthralgia in ACPA positive. But I think the data is not very strong for that. So as of now, I think we need more information to actually jump in and start biologicals, whom in patients who really require, we are many times not able to do. In these sort of patients, I think we need more information before we jump into that.
Thank you. Actually, these trials to me looked more of a less than a hope. It looked more like a disappointment, because finally, after giving abatacept or rituximab, at the most, you're just delaying the progression. I mean, progression of a patient from a preclinical to clinical RA by maybe some 5 to 6 months.
And that is only for rituximab. Abatacept actually showed significant difference in development of RA.
Yeah, development of RA over particular.
Yes.
Fine.
Yes.
Thanks.
Thank you.
Any more questions? If no more questions, we'll call the second.
So now we'll move to the next session, that is hope and disappointments in lupus. For that, I would like to invite my very dear colleague, Dr. Subramaniam R. So Subramaniam has finished his training in CMC as well as SGPGI as far as rheumatology training is concerned, and currently is working in JSS Mysuru. And his research interests are rheumatoid arthritis and interstitial lung disease. Subramaniam is a very, very fantastic clinician, a very good friend, and a great academician. Over to you, Subramaniam.
Thank you for the kind introduction. At the outset, I would like to thank the organizers of South Zone SZIRACON for giving me this opportunity to address this August gathering.
You're not audible.
Am I now? Yeah. At the outset, I would like to thank the organizers of South Zone SZIRACON for giving me the opportunity to address this August gathering. It still seems hopeful on a Sunday morning to have a talk on lupus. I hope I don't disappoint the crowd at all. So basically, I'll start with an index case. It's a 26-year-old female with rash, arthritis, nephritis, a straightforward case of lupus, class 4 lupus nephritis with high titers dsDNA. She was pulsed with methylpred and given cyclophosphamide as per NIH, and the usual story of loss for follow-up that exists amongst the best of the centers. Then she comes to me, then she follows up locally with steroids 20 milligrams per day and azathioprine 0.5 mg per kg per day. So this is what usually happens. On follow-up in 2021, she comes back to me with 3 months of amenorrhea, nephrotic range proteinuria, APLA positive recommended and agreed for MTP, repulsed with steroids, started MMF 2 grams per day, bettered, follow-up after 6 months with proteinuria less than 1 gram, so no activity elsewhere other than the renal, this thing. Again, lost for follow-up, followed up after a year, maintaining well at low-dose steroids and full doses of MMF. She has an arthritic flare, nephritis, seizure, rashes, and the usual story of that she wants to conceive. So that is the usual garden variety case that we usually come to, us. So where do we stand in this particular patient? So do we repulse with steroid, increase MMF? Naturally, pregnancy is not an option in this patient. How many of us believe in combination immunosuppression, and how many of us do practice in combination immunosuppression? And what are the B-cell depleting strategies? Because that has been the greatest hope in lupus per se at present in our scenario. Okay, so this is the thing. But lupus is fully ridden with problems. There is a clinical heterogeneity as far as organ manifestations are concerned and the clinical responses to treatment is concerned. And there is a biological diversity in the form of hyperactivation of innate and adaptive immune systems. And currently the interest has shifted more from the downstream rather to the upstream pathways. That is breakdown of tolerance and nucleic acid and activation of the interferon system. That is the part that we are trying to address by the newer therapies that are available to us. So what are the things in armamentarium for hopes in lupus per se? We have got biological therapies in the form of belimumab, anifrolumab, and obinutuzumab, small molecules, JAK and TIKE, CAR T-cell therapy, gene therapy, targeted immunotherapy, novel combination therapies, nanotechnology and drug delivery systems, and gut microbiome modulation. It's out of the purview of my talk to talk about gene therapy, nanotechnology, and gut microbiome, so I'll restrict myself to the other 5. So when you look at the pathogenesis of lupus per se, be that as it may, we have to accept that there is a lot of overlaps in the pathogenesis or immunology of lupus as far as the immune-mediated pathways are concerned. Do we have a pointer here? Okay. So as far as the immune-mediated pathways are concerned, as represented by the green circle, then you go to the saffron circle, that is a gene, then the blue circle, that apoptosis, gut microbiome, and the yellow one, that is the epigenetics that is associated with it, together with the environmental and UV factors. So it is practically impossible for any one of us to find one drug that suits all in a patient with lupus as far as the immunology of lupus is concerned. So that is why it's always better to keep your foot in different places in lupus rather than just trying to address one particular domain in lupus per se. So that is the era in which we are living with, and we'll have to go with combination immunosuppressants with most of our patients. So when you look at the triggers, I mean, most of the therapy so far was concentrating on this particular cell alone, B cell, but nowadays it has moved upstream for interferon therapies, BAFF receptors, and addressing these particular innate immune mechanisms that has come in the treatment of lupus. When you talk about rituximab per se, this, I think my colleague will address that it has been a major disappointment in a randomized control trial as far as rituximab is concerned, and that is probably the reason we have moved up to belimumab in most of the patients with lupus as the response to therapy. So they've got BLISS 52, BLISS 76, and so on and so forth. So what the BLISS 52 and BLISS 76, basically they showed that the systemic lupus erythematosus response index was much better at week 52, however, was not sustainable up to week 76 of treatment of belimumab per se. So this does offer a hope. However, this particular drug at present is not available in India. So again, we'll have to rely on some kind of a combination therapy. I think most of the treatment aspects that we look at is possibly the area where we practice. That's what my sir used to say. Wherever the area where you practice, that is the area, that is the needs of that particular area. You may not harp on to very hi-fi therapy. You may end up combination of drugs, but your whole idea is the basis or the biological basis with which you use these drugs have to be correct. So you do have a lot of armamentarium as far as your BAFF and APRIL are concerned. There is belimumab, atacicept, tabalumab, and blisibimod. Then interferon therapies in the form of anifrolumab, rontelizumab, and selalimumab, and proteasome inhibitor in the form of bortezomib. Most of these have been a disappointment per se, primarily because of the incidence of adverse effects, incidence of infections, or incidence of infusion reactions. So that is why belimumab tends to stand out as far as the other compounds are concerned in the management of lupus per se, and the interferon and the anti-interferon related therapy, you have got the anifrolumab which stands out. So when you look at most of the studies, your belimumab tends to stand out. There is superiority over placebo, and the other B-cell therapies have sort of not met the endpoints, or they are ridden with infusion reactions or infections, which led to failure of these particular trials, which again is out of purview of my talk per se. Then you look at anifrolumab, you have got TULIP 1 and TULIP 2. So basically TULIP 1 was a failure, but TULIP 2 has been with some amount of success. Why was there a good amount of success with TULIP 2? Because the study design was much better in TULIP 2, and they changed the way they looked at these particular aspects of lupus per se. So they were looking at SRI less than 4 itself, but that itself was not enough to measure the success of this particular molecule. So they looked at different aspects, and particularly the aspects in which interferon alpha is involved in the therapeutics of lupus per se. So that is why your TULIP 2 has been a success as compared to TULIP 1. They had changed the goals of therapy, and they found out that anifrolumab was much more useful in patients with lupus in certain domains of lupus per se. However, we are still living in the combination, just like we use combined DMARDs in rheumatoid arthritis. There is a hope for combining B-cell therapy, and this is what these particular studies are basically going to address. That is rituximab combined with belimumab, and these studies are ongoing or in process, so it's too early for me to comment on any particular results in these particular modalities of treatment per se. So apart from your B cells and interferon, you do have interleukin inhibitors and JAK inhibitors. As far as JAK inhibitors is concerned, we say that it is either a non-specific JAK inhibitors or a specific JAK inhibitor. The non-specific JAK inhibitors, though they do have certain amount of effect on the downstream pathway of JAK, they do have a certain amount of effect on the downstream pathway of this thing, but we don't know whether this actually helps in controlling the immune dysregulation that is involved in lupus per se. So again, it has not been very successful, but in certain domains of lupus per se, in the form of cutaneous lupus, your JAK inhibitors or tofacitinib, which is actually available, seems to be helpful. Your arthritic manifestations of lupus seems to be helpful. Nowadays, we do come across terminologies like type 1 lupus and type 2 lupus. Type 2 lupus is basically addressing the psychological impact and the patient's perspective impact of lupus, which is gaining a major way in controlling the symptoms of lupus per se. So that is the thing that is coming into play, wherein other non-pharmacological treatments may also come to play in the management of lupus per se. So again, when you look at all the JAKs, probably your baricitinib, though has failed, their studies have been terminated, have been shown to be superior to tofacitinib in the management of lupus. Again, it has to be validated in a better study per se. The one that is coming into action now is deucravacitinib, that is a type 2 inhibitor, and they are assessing that this thing of the responses of lupus in a major randomized controlled trial, which is going to be underway. So then we have CAR T-cell based therapy, whether it is useful or not. However, again, it doesn't seem to be affordable to most of the patients, and definitely not good enough in the Indian scenario as far as finances is concerned. So probably we may end up seeing these kind of therapies more into action. And I think most of it has been talked about in yesterday's talk by Dr. Dharmanand, where he has stressed, where he has mentioned about CAR T-cell therapy. Then you've got gene therapy in lupus and this thing. But the problem is any genetic therapy or any gene-related therapy, that it has got a lot of ethical considerations because it has to be targeted to that particular local area of inflammation that is occurring. So that is the lupus nephritis that we are talking about. Again, it has got a major this thing. This targeted therapies in lupus, basically voclosporin is the one that has shown to be about a good amount of success in most of the patients with lupus nephritis. And this trial, I mean the AURA trial, has been relatively successful in maintaining remission in patients with lupus nephritis who are on steroids plus mycophenolate per se. So yesterday someone was talking about multi-omics of ankylosing spondylitis or spondyloarthritis. Same thing in any rheumatological disease, there is going to be multi-omics, and that is where we are at present in the management of most of these diseases. So where do we stand in our patients? We have to address the pregnancy issue, these many components, and these are the preventive measures which possibly could be added in years to come. So this is where we stand as management of lupus is concerned. I thank you for your time.
Thank you, Subramanian. We'll take the questions after the disappointments. So, may I call upon Dr. Abhishek Patil. So, Abhishek has done his DNB in rheumatology in Delhi, and currently is the head of the Department of Rheumatology and Clinical Immunology at Manipal Hospitals, Bangalore. So over to you, Abhishek.
Thank you, ma'am, and thank the organizer for this opportunity to talk about disappointments in lupus. Well, my dear Subbu sir talked about hopes in lupus, but we all know how heterogeneous of a disease is lupus is. Some people have a lot of, IFN-mediated manifestations manifesting as skin and arthritis. Some have mainly a renal disease, probably B-cell-mediated disease predominance in them. That is why, probably if you look at all the trials, I'm sure at least the disappointment in lupus outweigh the hopes by at least a factor of 10:1. So I have picked up those trials which I feel are important disappointments after the initial promising. Bear with me if I missed few because the list is just endless. And this is a similar cartoon that Dr. Subbu showed earlier. Basically, lupus, involves everything that between antigen-presenting cells to B cells to T cells. You know that your own body generates these apoptotic materials which trigger the lupus disease. And so basically everything that is to be targeted are being targeted. So right from innate activation, targeting interferons, to targeting the B cell by causing B cell deflation by using all the three molecules which are there on the B cell surface, that is 19, 20, 22. Right from B cell survival blockers, that is BAFF-APRIL pathway inhibiting, right from B cell T cell interactions, that is CD40, CD40 ligand, ICOS ligand inhibition, then abatacept, and then you have cytokine blockers. So including TNF blockers and IL-6 blockers. So all of them, whatever you think of in this diagram, has been tried in lupus, and I dare say that most of them have ended up as disappointments. So that resulted in this abysmal survival rates of lupus. The lupus from 1950s to till 85, 90, with advancement of cyclophosphamide and base regimens, the mortality came down from nearly 50% in lupus nephritis, 10-year mortality, to 85%, but that's where it is stuck for the last 3 decades, even with all the newer development. So this is how B-cell targeted therapies are basically classified. Basically, you can target the surface molecules, that is 19, 20, 22, deplete the B cells, or you can use B-cell survival inhibition, that is by using BAFF-APRIL pathway inhibition, and terminal B-cell immunomodulation, that is bortezomib, very well used in multiple myeloma. And we are all aware of these 2 studies about rituximab. I'll start talking about each of these studies. And basically, this included Explorer and Luna trials, Explorer in the non-renal and Luna in the renal lupus phase 3 trials. Both of them are though heavily criticized by the endpoints that they used. For example, the major response rate that was used for Explorer trial meant that there should all the manifestations in each of the organ systems should be at category C, BILAG C, which is, as we know, clinically it's very hard target to achieve. Despite of all that, it's important to note that it has not received a regulatory approval. Rituximab, all of us use them, but there is no regulatory approval. Then we have other CD20 molecules. So we humanized the rituximab. It's a chimeric monoclonal protein to ocrelizumab and tried in Begin Belong. And the trials were ended because of the severe infections, fatal infections that was seen with ocrelizumab. Then ofatumab, it is a humanized completely human monoclonal CD20 antibody, and it is being used in case series and reports, 16, 20 patients where rituximab caused severe allergic reactions and is found to be useful, but somehow it has not hit the clinical trials. Then we have obinutuzumab, which is a type 2 CD20 blocker. Type 2 means it doesn't cause receptor aggregation on the cell surface, so it causes more apoptosis. And obinutuzumab is a good hope, but I'm not going to talk about too much because it comes in the hopes of lupus. Then we have epratuzumab, which was a CD22 blocker. This was postulated to have fewer side effects because it doesn't cause the B cell depletion completely. It causes more of immunomodulation. And affects the functioning of B cells. However, the phase 3 trials of the same thing, that is Embody 1 and 2, failed to show the clinical efficacy. Then coming to the BAFF-APRIL pathway, all of us are aware of this. There are 2 molecules, BAFF and APRIL, and then there are surface receptors, BAFF receptor, TACI, and BCMA. So you can inhibit any of these steps, and what we use already an approved drug through BLISS trials, but there are other molecules in this, like tabalupam. It was evaluated extensively in Illuminate 1 and 2 trial. Combined population maybe approved 2,000 patients. It did meet the criteria in one of the Illuminate 2 trial, SRI-5 in response rate, but further pursual was not done by the company. Then we have atacicept. Again, it was prematurely withdrawn because of the severe fatal infections developing, causing death in 2 of the patients. Then we have interferon therapies. We are already aware of the success of anifrolumab, but there were also, which is an interferon receptor blocker, but we also have interferon blocking agents, rontalizumab and cifalimumab. Rontalizumab failed the phase 2. Cifalimumab did pass through the phase 2 trial, but again, it was not further pursued. So we have a lot of these trials where, there was phase 2 trials which showed success, but the company itself did not pursue further development of those molecules because they did not observe the significant difference. So that is some clinically significant difference between the placebo groups and the active comparator. Then we have a co-stimulation blockade, nice concept to think about when you talk about inhibiting the B cell and T cell interactions. But the ASSESS trial, which used abatacept in addition to ELND regimen of cyclophosphamide, again failed to show the superiority. Now, there are other 2 co-stimulatory blockers, ruplizumab and toralizumab, blocking the CD40 ligand this time. They were withdrawn because of the severe reaction, thrombotic complications, because CD40 ligand is also present on the platelet, so it caused excess of thrombosis in these patients. Then we overcame this by pegylating the agent. So we removed the FC portion and put pegylation there. So it is called dupilumab pegol. Again, phase 2 studies, BICLA responder indices did not significantly difference from the placebo. Then we have an important concept, Rigerimod, which was a linear peptide, which was supposed to not have any infection risk because it just modulated the immune system, causing energy of the autoreactive T cells. However, as by my previous trial, this lupusar failed to achieve significant SRI response. Abetimus, interesting molecule, which is a heptamer, which tetramer, which resembles dsDNA and thus acts on those B cell secreting dsDNA antibodies which are involved in pathogenesis of lupus. But again, 317 patients with active lupus with dsDNA, this did not help. Baricitinib, we hear a JAK-STAT pathway inhibition in number of disorders, but unlike in rheumatoid, we have hardly had any major phase 3 success in SLE. Baricitinib was touted to be the most prominent among them, JAK1, JAK2 inhibitor, but SLE BRAVE 1 and 2, which is a baricitinib molecule, which used SRI-4 as the primary outcome, discontinued due to absence of any further improvement. So it was an interim interruption in the trial. Then we had a BTK inhibitor, Bruton tyrosine kinase. Most feared side effect of this was whether it could cause immunodeficiency, combined immunodeficiency, but however, the trial was discontinued because of failure of achieving the target. So phase 2 trial failed. Then came the ustekinumab. It was a resounding success in phase 2 trial, where it caused SRI-4 response rate of 66% in the active group versus 30% odd in the placebo arm. Now that led the investigator to be very hopeful and take a large phase 3 trial, but low test trial. Of the 512 patients, half of them dropped off by the end of 1 year. So a complete lack of efficacy in this drug also. Then IL-6 inhibitor, tocilizumab is used only in some case series. There are other molecules such as sirukumab which have been used but not successful. So I would attribute this reason of failure in pivotal trials of lupus purely because of heterogeneity of lupus. And despite of knowing so much and developing SRI, BICLA4, still there is a difficulty of finding an apt instrument to capture all that is relevant. A very high background standard of care medication, including mycophenolate, cyclophosphamide, plus or minus steroids, and possibly an overinterpretation of signals from phase 2 trials. So this is my last slide. So multiple pathways are postulated as target in lupus. We have tried a lot, but major disappointment have been in terms of baricitinib, ustekinumab, epratuzumab, and possibly even other T-cell modulating drugs such as Rigerimod. Thank you.
Thank you, Dr. Abhishek, for synopsizing it so very beautifully. Now the floor is open for discussion. Anybody who wants to add more to hopes or disappointments in lupus?
Looking at all the works done so far, I think we are groping in the dark. I think we should go towards tolerizing the immune system instead of evading the immune system. Because the patterns you see are so heterogeneous. This is just a general comment. Probably in the years to come, like what the xenograft story had come, how to tolerize, probably we'll have to find some mechanisms where you can tolerize.
Yeah, rightly said. I think for me the biggest hope is that we are able to improve. Whatever we are doing, we are able to improve the quality of life. So the target of the hope has to be quality of life. And the biggest disappointment is not being able to give a cure to the patient, drug-free remission.
Thank you.
Fine, thank you.
Thank you. Thank you, Abhishek.
Thank you, sir.
The next topic is hopes and disappointment in ANGA-associated vasculitis. First, I invite Dr. Rajesh to talk about the hopes in ANGA-associated vasculitis. He is a graduate from the, post-graduation from the Madras Medical College and now working as a consultant with rheumatologist, senior consultant rheumatologist, KIMS Hospital, Trivandrum. Over to Rajesh.
Thank you, sir, for that introduction. So I'm here to talk about hopes in ANCA-associated vasculitis. I would split into 3 areas. One is hope to know more about the disease. 2 is hope to know more about whether the disease is active or not and to know about the damage component. And then hope on therapeutics. So as everyone says, data is the new oil. So it is a gold mine. And if you have the A as the proper tool, with all refinement, we are going to get more data. So this is hot from the press, August 2024, Lancet Rheumatology. What does it say? So this is basically a multinational group of cohort. As you can see, it's 60 years of data from countries like Germany, Poland, Sweden, Czech, and France. So almost like 3,868 patients. And what they did was analyze this data. And what they found is, what you can see there, it is not more a binary construct. It's not GPA or MPO. It's a phenotype which has got 5 types or clusters. As you can see, they are distinct phenotype. They got certain biochemical presentation and disease outcome. So that's what we are going to learn more in the days to come, and that's my primary hope, know the disease more based on the phenotype. So the 5 clusters, the first one was a severe renal kidney cluster, and this had high CRP, high serum creatinine, variable ANCA, and that was one with significant amount of renal involvement. The second one was MPO positive with limited extrarenal disease. The third one is PR3 ANCA positive kidney involvement cluster with widespread extrarenal disease as well. So that is a PR3K cluster. There are 2 other clusters which were relatively not involving the kidney. Those were the IMS cluster, which is a predominant PR3 ANCA positive cluster with inflammatory multisystem disease. And the other one is predominantly upper respiratory involvement, low CRP, and basically more of younger patients. So we got these 5 clusters, and what they found is, of course, as expected, the severe kidney cluster and the MPO positive cluster didn't do well in terms of prognosis. They had more amount of renal involvement, ESRD, and mortality. Whereas the last 2 ones with relatively less renal involvement did fare better. So what this data says is, there's going to be subclassification of ANCA-associated vasculitis, which will give more predictive value and change our approach towards how we deal this group of patients. Because I'm sure that in the next disappointment talk, you're going to hear a lot about the toxicity and how not we are able to control remission, why there is a relapse. So all those things needs to be split into, delineated by more data. Again, based on the same group of patients, this is basically from the rare kidney registry, around 600 patients were put into this group of study to find a computable phenotype to predict relapse. So what they did was basically it's more of AA stuff. So I just tell in basic terms, like first one is to know the ground truth, which is the independent assessment of the case based on the primary case registry. The second level is to address the computable phenotype. What are the data? That is what they say as a categorical data element. What are the elements which we can put in to find a solution or a real plan? So that is a categorical data element they need to pick, and then they move on to the multi-level model regression, wherein they formulate a computable phenotype and then subject it to validation. And then if there is anything missing, they add up additional models. So what this phenotype does is it helps us to know which person or patient is going to have a poor prognosis, the relapse possibility. So this analysis, as it says, this is the first study to demonstrate the feasibility of a pragmatic data-driven algorithm to accurately automate the identification of relapse in real-world data. So this is not just for ANCA-associated, this is going to be a framework for any relapsing remitting disease and for automating the identification of the key outcomes or cohorts in registry data. So that's the hope I want to bring in ANCA-associated vasculitis, to know more about the disease, to know more about the phenotype, not just blindly treating it, just like with the guidelines. The next part is hope in knowing more about whether a disease is active or there is damage component. So we need biomarkers. So this is a systematic review, as you can see, recently published, and they looked into high quality data. They pruned it from 4,374 studies to 22 high quality studies, which looked into biomarkers in ANCA vasculitis. So this is the tabulation. If I am going to end for want of time, I just want to rush through. So these are the blood-based biomarkers. We know MPO ANCA. There are circulating immune cells, complement factors in the blood side. Urinary, you can have complements, C5a, C3a, BB, C1q, all those things. And you have the urinary soluble CD163, CD125, EGF. This review article also tells about biomarkers for organ damage, which is very new, which is very relevant. Blood-based biomarkers for organ damage is endotrophins and CCL2 for lung damage. And urinary biomarkers for organ damage is, again, urinary endotrophin and mitochondrial DNA. So for want of time, I just put in these snippets there. So as you can see that CD5 B cells are significantly increased in active disease, and they do predict whether a person is going to relapse, as well as CD14 positive and CD16 plus monocytes, again, significantly correlate with BVAS, and low level of complement C5, again, found in active MPO ANCA, and likewise, soluble complement particles like C5b9, C5a, all those are found to be significantly higher in MPO positive ANCA. Genetic profiling, yes, it does help. What they found is the pro-inflammatory gene module, which is S100A12, S100A9, were more abundant in active ANCA-associated vasculitis compared with patients in remission. Urine, again, soluble CD163, correlated with fibrinol necrosis, correlated with interstitial fibrosis and damage. Likewise, urinary EGF also were significantly lower. So just to skip through, damage predictors, again I told, same, endotrophins, CCL2, and urinary mitochondrial DNA. So what are the RCTs, therapeutics, moving on to therapeutics? There is this endurance study, which is actually a combination of rituximab and cyclophosphamide. We've had uncontrolled studies using low-dose cyclophosphamide along with rituximab. It has been found to be effective when compared to rituximab alone. So this endurance is a randomized controlled study which is already completed and the data is being looked at. So what we have already, we already know that it does help. Combivors is rituximab, belanumab. That study is going to end by this year, 2025. Ritux GoPro is in rituximab in good prognosis MPA. The other aspect, complement inhibition, is again, there are newer molecules coming in the picture, monoclonal antibodies. Maintenance phase, there are a couple of things I'll just pass through, just mentioning about the latest KDIGO guideline 2024. As I said, rituximab with low-dose cyclophosphamide does work, and that's been put up here. As you can see in the induction phase, There is a mention about rituximab plus cyclophosphamide along with glucocorticoid taper. Where do you use it? Patients presenting with markedly reduced or rapidly declining glomerular filtration rate, and where there is a limited data that rituximab helps because RAVE didn't include severe renal disease. So what they say is you can use, and they've given the formulations which you can use. Rituximab in 375 milligrams square meter 4 weeks along with 2 doses, or you can use rituximab in the way which we use along with 6 pulses of 500 milligram cyclophosphamide. Obinutuzumab, again, the problem with rituximab is the depletion is not complete. The tissue level depletion is not complete, so that is being fed by obinutuzumab. This is my last slide. This is about glucocorticoids. Like Gloria trial, they have pulled up glucocorticoid to see whether glucocorticoid low dose can prevent relapse. This group of patients, there are 2 studies going on, TAPR and MENASPAN. What they are looking at is patients who have relapsed after remission, they were again put on Ritux along with steroids. And what they did was, they had 2 groups in which they stopped steroids in one group, and they are looking at low-dose steroids to find whether that's going to help. This is a molecule, again, for EGPA.
Rajesh, please conclude.
Yeah. So CAR T cell, this is the last slide. So CAR T cell, there is only one study. This is again an murine model. It's been published in Annals of Rheumatic Diseases. There is hope that B cells can be well controlled with CAR T cells. But I would like to end up saying that ANCA is just not a B cell disease. There is an orchestra of neutrophils, macrophages, and B cells. That's why you need to combine, and that's why how it works. Thank you.
Thank you, Rajesh, for the nice presentation. Next, I invite the next presenter, Avinish Shah, for the disappointment in ANCA-associated vasculitis.
Yeah, good morning, everyone. I'll be presenting on disappointments in ANCA vasculitis. Most of it is hopes and already what we have gained through rituximab and cyclophosphamide in ANCA, but there have been some disappointments on the way. So I would like to divide my talk into 4 major disappointments: the use of plasmapheresis in ANCA vasculitis, the use of mycophenolate in ANCA vasculitis, achievement of drug-free remission, and 4th, a steroid-free regimen for induction. So plasmapheresis back in 1980s and 90s, it was, multiple small trials had come, and by 2007 when the MEPEX trial was published, it was seen as a big hope, especially for these severe disease where renal dysfunction and DAH. However, even the MEPEX trial showed only benefit in short term, but long-term mortality and kidney survival was not affected. So this is the MEPEX trial where you can see there is a significant difference in short term. However, the biggest trial of ANCA till date is this trial, which is PEXIVAS, which has shown actually, which had some benefits, which showed that you could use probably a lower dose of steroid. It was a 2x2 factorial design. So that part, it had shown some benefit that 0.5 mg per kg or a lower dose of steroid for induction may be beneficial. However, the PLEX part did not really show any benefit. However, is it only this trial and the methodologies of the trial that has led to this? So this PEXIVAS trial is a little different from what MEPEX was. PEXIVAS trial has included DAH patients which were not included in the MEPEX trial. Also, PEXIVAS patients' GFR cutoff is different. So this is the meta-analysis of 9 patients, where 9 trials with 1,000 odd patients with PLEX. Actually, there was no improvement with the use of plasma exchange on all-cause mortality, as you can see, as RR is 0.9. Also, 999 patients that reported end-stage renal disease outcome, the reduction at the risk of end-stage kidney disease was 0.62, but the confidence interval was very wide, 0.39 to 0.98, with no subgroup effect. So absolute risk reduction was highest actually for those with highest risk. Means the ones with had the lowest GFR had the maximum benefit with this plasma exchange. But remember, these are also the patients who have the highest risk of infection with this plex. So probably the benefits are getting negated by the infections that this plex may cause. So is there no role of plex? Pertinent to note that different inclusion criteria have been used, different outcome measures have been used, inclusion of DAH as I told in Pexivas. So this niche of plex may be, it cannot be used as a routine practice, but may be individualized in those with rapidly progressive disease who have still not required dialysis, and GFR is somewhere in between. Sorry, that's not GFR, yeah. So next one is mycophenolate in ANCA vasculitis. So the biggest trial of mycophenolate for induction till date stays MySick. MySick trial included 140 patients who had compared MMF with cyclophosphamide, and the remission induction was looked at 6 months. So this remission induction was actually similar to cyclophosphamide, 67 versus 61%, but there was no problem at 6 months. The problem happened in on further follow-up, where the remission maintenance, there were more relapses in MMF group, 33% versus 19% in cyclophosphamide group. So what we say is mycophenolate can be, if given for induction for not very severe disease, they have excluded such patients, but they later relapse. In MPO positive ANCA patient, relapse were similar in both cyclophosphamide and the MMF group. So it was basically the PR3 group which was relapsing. So this is a meta-analysis which was published on use of mycophenolate for remission induction, and basically they looked at these 4 trials, out of which obviously the biggest one is a MySick, but the other trial, 2 trials are from Asia, which are basically Mongolian ethnicity patients who have more MPO positive disease rather than the PR3 positive disease that we or the Caucasians see. So this trial, so this actually showed that the same 6 months relapse rate and ANCA negativity was comparative to the cyclophosphamide arm. However, the and relapse rate was also similar, because the relapses which were more in the PR3 disease in the MySick trial was maintained or by the MPO positive disease in the Asian studies. So these studies are actually highly heterogeneous. The I-square was more than 70%. So you can't really go by this meta-analysis that MMF does not cause relapses later. So can we use MMF as maintenance agent? So this improved study was the biggest maintenance study which was used, and it was showing that there was clear benefit with azathioprine rather than mycophenolate. Relapses were much higher, almost 50% of patients relapsed. So these are a lot of other studies. This is a meta-analysis that was published in one of the nephrology journals, and they found that there is a variation in relapse-free survival with use of mycophenolate, and the heterogeneity is mainly because of the renal disease. And if you take only the renal disease, that is the third column if you look at, the estimated response is, or maintenance of remission is almost in 92% patients. So it is the extra-renal manifestations and patients which relapse with use of MMF. So more data is needed. Meta-analysis shows heterogeneity, can't rely on it, and relapses more likely in PR3 disease. So niche for MMF may be in an MPO positive disease with non-life-threatening disease or in renal specific disease. Drug-free remission. With the use of maintenance agents of rituximab, we are seeing more and more relapse-free survival. So there was a hope that maybe after 3 years or 5 years, can we get a drug-free remission? However, that hope has not been fulfilled, and it is rather a disappointment where relapses are happening even after 3 years and beyond, up to 5 years. So as you see, as soon as you stop rituximab, the curves start separating more and more. And this is the main resistant trial, which has looked at rituximab further being given beyond 28 months versus placebo, and there was a significant difference. So relapse-free survival estimate at 28 months were 96% and 74%, almost 22% difference between the rituximab versus a placebo group. Somebody would say that, yeah, maybe the minor relapses are happening more, major relapses are rare, but still relapses are happening. So even beyond 28 months, patient needs continued maintenance agent. Steroid-free induction is one more thing that came up when avacopan came, when the phase 2 trials of avacopan came clear and classic. People thought maybe we can use avacopan instead of steroid. However, this is the advocate trial, the graphical abstract. What we see is it's not really steroid-free induction, but it is reduced steroid at induction. Although the design showed placebo versus avacopan, the physicians were still allowed to prescribe steroids in the induction regime as required. So the advocate trial actually at 6 months had used 1,676 mg of prednisolone equivalent in the avacopan arm, and as compared to 3,800 in the prednisolone arm. So yes, steroid use was reduced by almost 60%, but it was not steroid free. So, this is still a disappointment for me. That it is not really steroid free. Lovas, Pexivas and Rituximab have shown better efficacy even with lesser steroid use, but it is not steroid free. So thank you. That's all I have to talk on this. Thank you.
Thank you, Avinash, for the nice presentation. The topic is open for discussion. Please remain. Avinash. Any questions?
So, Avinash, just one comment basically regarding the disappointment of drug-free remission in ANCA vasculitis. So actually there is a big study which is going to come up, I suppose, from North Carolina or the US group of investigators. So what they have shown is that at least there are some subset proportion of patients who can achieve what is called as LTROT, that is long-term remission of therapy. And you will be able to identify them based on their molecular phenotype. So that is a big work. It's in US, I'm not able to, not North Carolina, somewhere else. So Dr. Peter Merkels and their group. So they have a big cohort of people and they are able to figure out at the time of stopping therapy that some chunk of patients by certain biomarkers, you will be able to figure out that these patients are probably the ones who will not be able to, who will be able to attain remission of therapy in long term, just to add to your remission.
Thank you. If there is no more comments, we wind up the section. Thank you all the speakers for the nice presentation, and thank you.
Thank you, chairpersons. And there is no stretch break since lack of time. So if you have to have tea or coffee, you can take it. And now we are moving to the third session. Second session. And for the second session, we invite the chairpersons, Dr. Yatish, HOD and lead consultant, Astor Whitefield Hospital. And our next chairperson, Dr. John Matthew, Professor and Head, Department of Clinical Immunology and Rheumatology, CMC Vellore. So we request the chairpersons to introduce the speakers.
Yeah, good morning, everyone. So this session has a lot of clinical inputs. I think I would request everyone to grab a cup of coffee and come back quickly. So first speaker, we are calling Dr. Santosh Sahananda. So he's an eminent orthopedic surgeon, and he has done a lot of fellowships in arthroscopy and sports medicine, sports surgery. So, and he is also active member in Indian Arthroscopic Society and Tamilnadu Arthroscopic Society, and is a lot of publication, lectures, and workshop as faculty. So over to you, Dr. Santosh.
Thank you, sir. Very good morning. First, thank the organizers, respected chairperson, and Dr. Nagaprabhu for the opportunity. Yes, I'm an orthopedician here. Dr. Suresh, who was here, actually gave a good intro of orthopedicians in his talk, talking about unindicated joint replacements. I do agree with him. I don't have conflict of interest because I'm not a joint replacement surgeon, I'm a joint preservation surgeon, so I don't do joint replacement. So ideologies are similar. We try to delay the replacement as much as possible. So to start with, this is a paper, a rheumatology journal by Dr. Robert. I'll talk about him later. This is a picture in his journal, which is a quote of how arthroscopy has evolved over the years. This is a post-Second World War era, around 70s, where scopy was initially started by rheumatologists. Actually, thanks to rheumatologists who actually started scopy, and then it moved on to orthopedicians. Initially, they used to have intra-op. Patients would be electrocuted with minimal voltage of current. Sometimes assistants also used to get electrocuted with current because of the light source which requires over there is incandescence light. The light source usually has some circuits which short circuits are common during those days. But now that's not a problem at all. It's advanced so much that a lot of technologies evolved, and we stand almost equal to anywhere in the world in arthroscopy. In fact, we have Indian companies which are almost second in the European market of manufacturing various implants. So technology has evolved. We've gone a lot of distance. As you can see over here, the lights, that's the camera with the fiber optic cable, and that's the shaver. These two are the most important with respect to synovitis or arthroscopy. These are the most important instruments which make us do so much surgeries with ease. So going back to history, as previously told, arthroscopy was initially started by rheumatologists. Watanabe is well known among arthroscopy surgeons for his classifications and his techniques. He was the one who introduced arthroscopy and trained many arthroscopy surgeons in 70s. But it's come a long way. Back then, a lot of arthroscopic pictures of how the vessels would look during intra-op arthroscopy were noted in detail. That used to help us diagnose, but we don't do that hardly because we have good histopathological samples which we can take. We'll go on and see about it. This is a scopic view of how a synovitis would look like intraoperatively. That's the picture. That's not normal knee. That's how when there is a florid synovitis, that's how the picture would look. What you see white is the cartilage, and the synovium, which is supposed to be pale, is florid and inflamed, as you can see over here. So as these are the rheumatology journals which I've gone through, the indications for scopy and the benefits are noted here. One of this is to differentiate osteoarthritis from psoriatic arthritis and other inflammatory arthritis, but I don't fully agree with that. But maybe monoarticular arthritis, when it's persisting, when other arthritic area pain is less, and maybe in those situations it might be a value, may not be diagnostic, maybe as a therapeutic value also. I'll come into the details later. And as a diagnostic tool, when you're not sure of the diagnosis, it helps us take biopsies and clinch the diagnosis. And apart from that, in research, again, it's not in my purview. For you to know how is the therapeutic value of so many newer drugs, to take a histopathological sample, there is another indication. So these are the limited indications for scopy in rheumatology. I would say limited, but there are still indications which are limited, as I would quote here. This is how we take a biopsy. There are various studies which prove that there are various ways of taking biopsies. There are a few proponents who say ultrasound-guided needle biopsies or ultrasound-guided biopsies are good enough, but that's nowhere near arthroscopic biopsy, where you can take quite a significant amount of quantity of the sample, and the synovial lining is very important to know what kind of histopathological tissue we are able to get. Okay, this is another video where it shows the limited synovitis. What you saw previously was the florid synovitis. Here is a limited synovitis. This is a picture where we go in for another lesion, some other pathology. We come across synovitis, and that's how we shave and remove the synovium. That's the way the shaver, that's called the shaver, which removes the synovial tissue, where it's a rotating blade within the cannula, where it removes the layer of synovium. We just remove the synovial layer without damaging the retinaculum or muscle layer. So common sites which we do scopy are the shoulder, hip, knee and the elbows, but most of the patients would not be symptomatic unless they are unable to walk. So our patients become symptomatic more when they are unable to walk or their ambulation is hampered. So knee are the most common areas which are involved. So for us to decide as an orthopedician whether which areas disabled, clinical examination is the key. Even though MRI has helped us a lot, still clinical examination is the key. The area of tenderness is the key over here to find out which is the pathology which is troubling the patient. The patient might be disabled of pain, but the area of pain is the key over here. If it's somewhere in the joint line, then we have to suspect something more towards arthritis. Then we have to look in those areas where there is pain in the MRI and X-rays and clinch the diagnosis. If the area of pain is somewhere higher up on the synovial area and it's not because of arthritis, it's going to be because of synovitis, then we have to look into the MRI. MRI might report and show so many features, so many lesions. All of them might not be the reason for the disability of the patient. So clinical examination still holds good in treating our patients. So this is an example of MRI. This is one situation where you see a loose body over there. This patient had locking. There is synovitis, but just for synovitis, there is no indication for scopy here, arthroscopy. Because of this loose body, this patient presented with locking, repeated locking, and you can see some contusion in the patella because of the locking episodes. So this is an indication for scopy. Because of mechanical symptoms, because of the loose body, secondary to the synovitis, this may be an indication for scopy in this situation. This is another example where you see the MRI with florid synovitis. Again, X-ray is very important. Talking about X-rays, as Dr. Suresh had told, X-rays are very important, but most orthopedicians also doesn't realize that weight-bearing single-leg standing X-ray is the key to know how much of arthritis is there. So just a lying down supine X-ray is not good enough. Bilateral weight-bearing X-ray may not be good enough. Single-leg standing, monopedal stance weight-bearing X-ray is the X-ray of choice to know how much of arthritis is there, how much of joint space reduction is there to decide. Then MRI comes into play. For arthritis, osteoarthritis, X-ray is the primary investigation of choice. MRI again gives us various areas, synovium, where is the synovitis, which area there is synovitis, and how is the meniscus and ligaments. MRI will help us give us an idea. If there is a synovitis like this, florid synovitis, that's what we go on and do. Remove the florid synovium. You can see the layers of the synovium being shaved off with the shaver. We go in area after area, and initially the most important part is to take the histopathological sample from the most involved area. You can take multiple sites also to make sure you don't miss anything. But clinically we thought this was looked as though it was like a synovial chondromatosis, but this turned out to be pigmented velonodular synovitis because we found a lot of loose bodies. But contrary to our clinical judgment, this histopathology showed to be PVNS. Again, MRI, each sequence is important. We have to go through all the sequence. In these axial cuts, help us know where is the synovitis, in the anterior compartment and in the posterior compartment, whether we need to go posterior to clear all the area in the posterior compartment. This video shows the posterior compartment, how much of synovitis. That's not a normal synovium at all. So this is posteromedial area going behind the condyles. As you can see, so much of synovium is involved over there. That area is cleared with a shaver similar to what I told. So for us to clear the synovitis, anterior compartment is cleared using two portals in the front, a posterolateral portal for a posterior compartment and a posteromedial portal for a medial compartment. But for us to have a complete clearance, we call a 5-portal arthroscopy synovectomy. 1, 2, 3, 4, which is the 5th. Sometimes this is the posterolateral portal, where you go in and clear the posterolateral area, also devoid of all the synovial tissues which is there. But you have to be very careful over here because the vessels are pretty close by. So the last one is the suprapatellar portal. Sometimes the suprapatellar portal will be so much enlarged that you might not be able to reach from your regular portals conventionally. So we might need to take, sometimes the synovium will be somewhere till the mid-thigh in short patients. So you need to make another portal over there to clear the synovium as shown over here. So this paper gives us a good overview on outcomes, the SF36 outcome post. Before surgery is the blue line, post-surgery is the red line. How much of improvement in patient symptoms are there in especially rheumatoid patients post synovectomy, arthroscopic synovectomy. So they do have improvement, but there are clear-cut indications. You cannot do it for all the patients. Patients who are not responding, if there is floral synovitis, this may be beneficial. Okay, this coming to the last few slides here. Will the rheumatologist ever pick up the arthroscope again? These are a few articles by Dr. Robert, and he goes on to say another article regarding arthroscopy. Can orthopedist and rheumatologist be friends? So all of these articles have come from this single author from University of Michigan, who is a proponent of scopy among rheumatologists. And he advocates rheumatologists to go on and do scopy, at least for diagnostic, because there is a outpatient-based mini scopes nowadays available. I guess this is a company, few articles actually company-sponsored articles, where you can do an arthroscopy just for diagnosis. But I would say for diagnosis, there are so many other ways and advances rather than doing an arthroscopy just for diagnosis. Unless you're not able to clinch the diagnosis, you want to know the histopathology. That is the primary indication for arthroscopy now. So role of arthroscopy as a take-home, gold standard histopathology is the gold standard, and to obtain the histopathology, arthroscopy is the gold standard currently. Therapeutic value is of limited, and if it's persistent, monoarticular with probably locking or mechanical symptoms, then probably you can go and do arthroscopy. To clinch the diagnosis, whether it is synovial chondromatosis or pigmented villonodular synovitis, when there is a suspicion of tuberculosis, or I mean all your investigations would be normal, but your biopsy would turn out to be tuberculosis. It would be surprising. So don't underestimate tuberculosis even now. And it will be a very healthy, well-to-do patient, and it will turn out to be tuberculosis. So do not underestimate or ignore tuberculosis even in this day. And finally, septic arthritis. Septic arthritis, among rheumatoid, yes, we have come across, especially post-steroid injections. They do come across with severe pain, and some patients with full-blown arthritis who needs a joint replacement, but because of the disproportionate pain, we would not be sure whether there is overlying infection or not. So before we go on and do a joint replacement, we do a scopy, rule out infection, take biopsies and cultures from all the part, make sure there is no infection, then go on and do a joint replacement. Again, these are very few select indications where we do arthroscopy in a rheumatology patient. Thank you. Thank you very much.
Thanks, Dr. Santosh, for the very lucid and clarity in that presentation. Is there any questions from the audience? Yes, sir.
Once you do synovectomy in RA and other things, so what is the duration or the average duration where next, whether the patient needing a TKR or a repeat arthroscopy for synovectomy or something like that?
As I said, we don't do synovectomy as a therapeutic in RA. It is in a synovial chondromatosis, we see the symptoms. It will recover. Some patients would come after 5 years, some come after 2 years, some come after 15 years in synovial chondromatosis or PVNS. That is known to recur. If it's for a joint replacement, we don't do synovectomy because when we are suspecting an infection, we do synovectomy. When we rule out an infection in 3 to 4 weeks, we go on and do a joint replacement.
In RA, I'm just asking in RA basically. So for like your diagnostic or the other way around, if you do a arthroscopy and do a synovectomy for that one. So what is the next average span for needing a TKR? That's what my question is.
No,
I'm not talking about
yeah,
PVNS
I
or
understand, but
synovectomy.
for RA, there is no indication to do a synovectomy arthroscopically, just like that, unless there are mechanical symptoms. So unless there are mechanical symptoms, you're going to, but if it's already a full-blown arthritis which is indicated for a joint replacement, why do an arthroscopy in that case? So that's not an indication for arthroscopy.
Santosh, shall I just have a quick question?
Sir.
What is your rate of complications post-arthroscopy? And what are the complications?
When one is recurrent swelling, because we do so much of synovectomy, the bag is already swollen, the persistence of effusion. Synovitis reduces, but the knee remains swollen in these florid conditions. So it takes a lot of time because we need to go up high, sometimes until the mid-thigh, to release all the synovium. To getting those swelling post-op come down, it sometimes takes 2 months, 3 months. So patient swelling remains, but pain reduces. That's one thing. Sometimes, rarely, synovial fistulas do happen because we make so many portals and clear so much of synovium.
Any infections post?
No. Arthroscopy, no. Post-synovectomy, no.
And what would be a commonest indication for shaving the synovium? Like you talked about shoulder surgery.
Yeah, our synovectomy involves shaving the synovium using those shavers.
Indication for, what would be the indication for?
In a rheumatoid, not much, but in other PVNS, when we go in to take a biopsy, we clear off the synovium because we have an opportunity to clear the synovium all over. So we reduce the load of synovial tissue which is there. So your drugs would act better.
If there are no other questions, thanks so much, Dr. Santosh. Thanks for
Thank you very much.
Yeah, now I call upon Dr. Sridevi for the next talk on risk stratification and screening for liver fibrosis in patients on methotrexate. Very important topic for all of us because we are very happy to use methotrexate because it feels that we have been taught to use methotrexate in almost all the patients of arthritis, inflammatory arthritis. So now we will have to understand the risks. So I call upon Dr. Sridevi. She has done DM Rheumatology from Madras Medical College. Multiple publications, has won multiple awards. So over to you, Dr. Sridevi.
Thank you. Thank you, organizing team, for considering me for the presentation. And I'm extremely privileged to be a part of SZIRACON 2024. Moving on to the topic. So my topic is risk stratification and screening for liver fibrosis in patients on methotrexate. So I'll be talking about few words on the introduction and methotrexate, how it causes acute hepatotoxicity, liver fibrosis, what association has it with the non-alcoholic fatty liver disease, and how it has affected our clinical practice, and I'll be closing with the remarks. So methotrexate, in spite of having our rheumatology armamentarium enriched with lot of biologics and targeted DMARD, it still remains one of the anchor drug, and hence optimizing the treatment and monitoring is of paramount importance. And mechanism of action, it keeps evolving, and safety is also being updated, and as the number of patients being exposed to it is increased. So new studies of its usage emerge, and potential for hepatotoxicity is also being revised, as is the potential for interstitial lung disease. So, how methotrexate causes acute toxicity? So probable mechanisms postulated are, it binds with the cell membrane, which leads to the liver enzyme, release of liver enzyme into the circulation, that leads to inflammation and apoptosis of the hepatocytes. And that is one of the mechanisms with which it affects the liver cell. And as we know, methotrexate is an inhibitor of tetrahydrofolate reductase enzyme. So that is an enzyme which leads to formation of folic acid, which is a methyl donor. And methyl donor, it's required for various biochemical reaction, like conversion of homocysteine, which is homocysteine to methionine, homocysteine being an pro-oxidant molecule. And so when the enzyme is inhibited, homocysteine level goes up. So that also it's a pro-oxidant phenomenon. and depletion of antioxidants, and imbalance of various apoptosis and regulating factors. So these are the mechanisms postulated. And what we see in practice is that there is usually moderate to transient increase, which is less than 3 times upper limit. And when we stop the drug, it usually comes down and it normalizes after we re-challenge it. So this is a pictorial representation. So this was a meta-analysis which was done on 32 studies with 13,000 participants. So here it was shown that the total adverse liver events were 11% for a period of, for the studies which were conducted. And with the minor liver enzyme abnormalities being only 8% and major liver enzyme abnormalities 3%. That is, minor liver enzyme abnormalities is less than 2 times upper limit and major liver enzyme abnormality being 3%. That is more than 3 times upper limit. But there were no evidence of liver failure, cirrhosis or death when methotrexate was correlated with the liver outcome. And this was a methotrexate being studied in inflammatory bowel disease. So there again, the drug withdrawal due to the hepatotoxic effects of ricin transaminitis was not significant enough. So what could be doing the rounds? If the methotrexate is not doing the hepatotoxicity, should we look for some other etiology? So could it be metabolic syndrome? So then it was studied on people with diabetes and metabolic syndrome of about 4,786 patients for about 2 years with a median dosage of 15 milligram per week. So in which 5 patients developed cirrhosis, but 3 patients they developed within 3 months of randomization. So that could be unlikely be due to cirrhosis. So now coming to the drivers of hepatic fibrosis. So the hepatic stellate cell, it is one of the important cell in the liver which helps in synthesis of vitamin A. So when there is toxicity, what happens is that the stellate cells, they transform into myofibroblasts which secretes collagen and other extracellular matrix which leads to fibrosis of liver. And there are multiple other chemicals which are released like adenosine, homocysteine. So these are all pro-oxidants. They also will lead to increase in inflammation as well as they drive stellate cells to produce collagen. And there is increase in free radicals as well. So, but the protective mechanisms do exist like metalloproteinase enzyme which help in degrading the collagen. But that will be they are underutilized. But it is a dynamic and reversible process. So there is an imbalance between the protective and the aggravating factor. So there is a imbalance in fibrogenesis and fibrinolysin which could lead to hepatic fibrosis. So without speaking little into history, a little bit about history, it's not complete. So how did it all happen? So in 1960, when the psoriasis patients were given methotrexate, there were isolated cases of cirrhosis. And in 1980, when they studied a little more deeper, they found that 26% of the patients developed cirrhosis while on psoriasis. But 50% of them, pre-treatment, they had abnormal histology. So pre-treatment liver injury increased hepatotoxicity. So hence, there was a classification criteria that was validated to look for the liver toxicity in the histological specimen. That was a Ronjic classification criteria. And so the dermatology colleagues, our dermatology colleagues, they came up with the idea of liver biopsy because of, they were apprehensive of methotrexate causing cirrhosis. So they came up with the idea of doing liver biopsies at a cumulative dose of 1.4 gram. And thereafter for every 1 gram. And that was on basis of a meta-analysis which was done in, on methotrexate and liver toxicity. And there again it showed that the risk increases with the total cumulative dose and with the consumption of alcohol. So that was when 2 new discoveries were found out in the medical gastroenterology field. One was the chronic macrovascular steatohepatitis inducing hepatitis C and NASH. So non-alcoholic steatohepatosis. But then its pathophysiology to the insulin resistance and other pathophysiological mechanisms were not studied. And in Denmark, they studied people on methotrexate in patients with psoriasis, psoriatic arthritis, and rheumatoid arthritis. They found out that psoriatic arthritis patient had a worse liver outcome when compared to the rheumatoid arthritis. But the NASH association with the body mass index was not studied. So there again came the disagreement between dermatology and rheumatology colleagues. So dermatology colleagues advocate liver biopsy for a cumulative dose of 3.5 to 4 gram. But then before 2009, they advocated it for 1.5 gram methotrexate. But rheumatology counterpart, they did not recommend liver biopsy. So there was a disagreement, constant disagreement between the dermatology and rheumatology, and hence we needed more advanced tests to differentiate, to come to a consensus. So what is the issue with the liver biopsy? Though it is gold standard, it has got multiple mortality and morbidity associated with it. Even though we get a liver biopsy specimen, it can have interpathology variation of 20 to 30%. Above all, it is expensive. So we need to think about non-invasive tests. That was when the biological fibrosis came up. So in that clinical and biochemical parameters were fed into equations. So it was initially validated in viral hepatitis, alcoholic liver disease, cholestasis, and NASH. And that was superior to the normal liver enzymes which were being measured, and that was less sensitive. So these were the biological fibrosis tests that was used as a first screening test for fibrotic liver disease in targeted population. And then came multiple biomarkers, composite biomarkers tests like fibro test, fibrometer, HEPA score, etc. So why do we need non-invasive testing? So basically it is to predict fibrosis, to avoid liver biopsy, and since LFT is not a reliable indicator for predicting the pathological changes, we need non-invasive testing. So these are the non-invasive testing which are available in market, which include simple biomarkers, composite biomarkers, and imaging. So simple biomarkers uses the AST, ALT, albumin, age, platelet, and BMI. So that can be, these variables can be entered into calculators, and we get AST to platelet ratio index, that is APRI, FIB4, fibrosis scoring using 4 parameters, then fibrosis, NAFLD, fibrosis score. So these are simple biomarkers which can be done in our OPD. But then there came the composite biomarkers. Composite biomarkers included the HEPA score, fibro test, fibrometer, enhanced liver fibrosis, etc. But then these all required procollagen, hyaluronic acid, tissue inhibitor of metalloproteinase. So they are not usually available. So what we usually do is simple biomarkers are usually preferred because that can be done in an OPD setting. So if any of this shows a abnormal value, that is FIB4 is the most commonly validated one, we go in for imaging. So what are the imaging modalities available to predict fibrosis? One is the vibration control transient elastography, shear wave elastography, and MRI. So these are the imaging and the fibrosis score. Simple fibrosis score, composite fibrosis score, and imaging. And FIB4 score, it is calculated as, it has got a, so we grade it according to the values. That is less than 1.3, it has got a negative predictive value for advanced liver fibrosis of 90%. And more than 3.25, it has got a positive predictive value of 70% for advanced liver fibrosis. So what is feasible for us is FIB4. That can be done in OPD basis. So FIB4 less than 1 means ruling out advanced liver fibrosis. More than 1.4 means there is chance of advanced liver fibrosis. So these are, they can be put into mathematical equation and we get a score. So various other scores are NAFLD fibrosis score. So that is usually used for the fatty liver disease, and that is being extrapolated into our own methotrexate drug-induced hepatotoxic indication, and FIB4, NFS score, APRI, etc. So this was the study which was done on rheumatoid arthritis patient treated with methotrexate who were followed up with FIB4, and in which 13 they had screened 14 patients to be undergo a liver biopsy, of which 13 of them they showed advanced liver fibrosis. So these are the various studies which were done in this field showing that VCT, that is FibroScan, and other FIB4 tests could be done for assessing the liver stiffness measurement. And this was done in IBD, Crohn's disease and psoriasis patient. That again showed this non-invasive measurements could be used to predict liver fibrosis. So what is transient elastography? So it is a modality in which it's an ultrasound modality in which the vibration waves are used to produce shear waves which pass through the liver parenchyma. And the velocity, the higher the velocity means more stiffer the liver is. So normal value is 5 kilopascal. And anything more than 8 means it is more suggestive of advanced liver fibrosis. So 8 to 10 is suggestive of advanced liver fibrosis. More than 12 to 15 kilopascal is suggestive of cirrhosis. So we take a cutoff of 8. And issue with the transient elastography is that it can be altered in obesity and if the patient has got ascites. So in those conditions, we can go in for a shear wave elastography or point wave elastography that has got better diagnosis of advanced liver fibrosis. So these are the various tests looking for association between the fibroscan and the biopsy. And in all this, they could find out that methotrexate didn't have any role with the progression of fibrosis. Only the obesity and metabolic condition were associated with the high fibrosis score. So what about the cumulative dose? So that was found to have no association, unlike diabetes, obesity and pre-existing chronic liver disease. That is because liver has an innate mechanism to repair the already existing inflammation and fibrosis to an extent. Probably that is why. So these are the tests. So here, this is a test which was done by Aital, which showed that at the end of 6 years, 8.2% of the patients at 6 gram of cumulative dose of methotrexate, only 8.2 developed advanced liver fibrosis at 6 gram at 6 years. And multiple other publications also showed that methotrexate cumulative dose didn't have any association with the hepatotoxicity. So this was the latest in the row, which showed, which is an article published in Hepatology journal, which showed that there is no correlation between the cumulative dose of methotrexate. And what they did was they did a liver stiffness measurement with the VCTE, transient elastography, and a biomarker test using enhanced liver fibrosis. So both of it did not find any association between methotrexate and hepatotoxicity. Only diabetes, obesity did have a role. So this was the European Association of Study of Liver. This was the protocol that they follow. That is, whoever are at risk for chronic liver disease, we should be checking them for obesity, body mass index, alcohol history, and hepatitis, even HbSAg, anti-HbC, and anti-HbS has to be tested.
Sorry,
so all those has to be.
Sorry, the slide has not moved. Can you move the slide? There's a slide in between. Yeah.
So we were of the habit that we check only the HbSAg for hepatitis screening. So actually the hepatology or the gastroenterology colleagues, they say we need to look at the anti-HbC, core antibody as well as surface antibody also before giving methotrexate. And liver function test, albumin, platelets, etc. Then we calculate FIB4, and if it is less than 1.3, that means it has a negative predictive value of 90%, so we need to assess it only every 3 years. Whereas if it is more than 1.3, we need to look for the transient elastography. So transient elastography, again, if it is less than 8, again it carries a low risk of fibrosis. If it is more than 8, we may go in for patented test. So this is the evolution of NASH. So methotrexate toxicity could be enhanced by the underlying NASH. So that is what is the inference that we have got from multiple studies. So till NASH it is irreversible. After that it is not. So till NASH we have to treat the NASH along with the methotrexate, along with giving methotrexate. And especially that metabolic syndrome exists in 80% of psoriatic arthritis and less with the rheumatoid arthritis. And methotrexate, it aggravates NASH by depletion of folic acid, and it will go and affect the beta oxidation of fatty acid that leads to deposition of fat in liver. That will aggregate the NASH and inflammation. So these are the studies which showed that whenever there is a pre-existing fat accumulation in the liver, that enhances the methotrexate toxicity and not the methotrexate dosing alone. So these are the trials, various studies which supported that. And this was a study which assessed the number of cases which went for liver transplantation due to methotrexate toxicity. Here, that is about 1,58,000 58,900 patients who had registered for liver transplantation or had undergone that. So only 0.7 could be attributed to methotrexate toxicity, and all of them had diabetes. So cirrhosis patients, only 0.7 patients had cirrhosis. So dermatology says do liver biopsy, and they later said do procollagen 3. Rheumatology, our side we do usually monitoring by liver enzyme, but now we have come up with the non-invasive testing. So this is what we follow. So FIB4, the cutoff is 1.3, and by transit elastography, the cutoff is 8. And with that, we could identify more than 90% of the population who has got a risk for hepatotoxicity. So this is the most feasible strategy which could be followed. So the pre-treatment evaluation includes LFT, CBC, and evaluation of diabetes dyslipidemia. If it is normal, start methotrexate. Regularly monitor every 2 to 4 weeks for the first 3 months, and then go by monthly. And if the ALT on follow-up, if the ALT is more than 100, or if it rises more than 2 times from the baseline, stop methotrexate till ALT normalizes, then we can start it at a reduced dose. While if the FIB4 score is more than 1.3 in less than 65 years and more than 2 in more than 65 years, we have to send the patient to hepatology. They do the workup from all the viral hepatitis, occult hepatitis infection, autoimmune hepatitis, hematochromatosis, and if they find any discrepancy, they go in for liver biopsy. They go in for transit elastography, and after transit elastography, they'll consider doing liver biopsy. And in that, if the fibrosis stage is F3 or F4, they will discontinue methotrexate. So how frequently to monitor non-invasive testing? So
maybe running short of time. Can you?
Okay. So risk factors has to be assessed before starting methotrexate: alcohol, diabetes, obesity, folic acid has to be ensured, and other hepatotoxic chemical agents should be, the exposure has to be brought down. Viral hepatitis, any occult infection has to be looked in for. So address all the metabolic conditions before starting on methotrexate, because methotrexate itself has plays little role in enhancing the hepatotoxicity. Address all the metabolic issue and then start. Closely follow up with the liver fibrosis, liver enzymes, do FIB4 score, and if it is more than 1.3, do fibroscan. If it's more than 8 kilopascal, hepatology referral is required, and liver biopsy as decided by the medical gastroenterology, and that requires a constant touch and collaboration with the gastroenterology and hepatology counterparts. So with that I conclude. Thank you.
Thanks, Dr. Sridevi, for a very comprehensive elucidation of that topic. Is there a question in the group? Yes, Dr. Venu.
What is the role of ultrasound? There is a normal ultrasound.
Ultrasound can detect fatty liver, but it cannot detect the right amount of advanced fibrosis.
No, but it can give you a clue, no? Suppose the echo texture is coarse, then maybe you can send the patients for elastography or something.
Probably, but then that has not been found to be of much role. All what has been recommended is the shear wave elastography, and early fibrosis could not be seen
because
by
in most
ultrasound.
fibrosis cases, the ALT and AST will be normal, maybe only slightly elevated, like 5 or 10 IU. So you cannot go by the high ALT and AST alone. But when we do an ultrasound, we come across coarse echo texture.
And for that, maybe if we do a FIB4 score, if it is high, maybe with that you can probably reach a conclusion. FIB4 scoring.
Yeah, but I think basically in practice, in clinical practice.
But even then, even after discussing with the gastroenterologist, they say that even if the liver enzymes are not that very high, we do not usually subject the people to ultrasound, or if incidentally they do ultrasound, they can be subjected to shear wave elastography or transit elastography.
And you said you continue methotrexate till F3 stage. But if it is early fibrosis also and you give methotrexate,
we can give it
it's
at a
going to
reduced
progress.
dose.
It's going to progress.
if we
So
can
why
gi-
do you continue till F3
we
stage?
can give it at a reduced dose, or maybe we can replace it with less hepatotoxic drug like
Even if it is an early fibrosis, it's a warning, no? So you should not give beyond F1 or F2. Okay, thank you.
Next question, yeah.
Just the extension of sir's question. So if you are going to monitor by ultrasound or the other imaging modalities, basically the ultrasound related modalities, so what is the frequency, or what is the, how do you monitor that one? So you want to do it at the early stage and then follow up duration or methotrexate dose?
So,
no, just is it depending on?
That is every 2 to 3 years. Means if it is low risk, it can be done every 2 to 3 years. Otherwise, for NAFLD, they say annually it has to be done.
I'm discussing in RA and methotrexate. We will
So
not
in
discuss
RA,
about the
in RA and methotrexate, already there will be some amount of baseline fatty liver or non-alcoholic NASH. So in that case, we can do it 3 to 6 months. Every 6 months.
Is it dependent on methotrexate dose?
Not dosing. We can do it after.
Only 2 years, 3 years, whatever it is there, you will just get a scan done and look
Every
for the reports.
Yes.
I think you can have the last question from Damu and then my
The patient has got underlying autoimmune hepatitis along with rheumatoid. So now how do you differentiate whether it is methotrexate related or underlying autoimmune hepatitis?
Autoimmune hepatitis, that we have to discuss with the hepatology and the medical gastroenterologist counterpart. So autoimmune hepatitis, we usually go in for azathioprine and all. Methotrexate is less likely. In that case, we may have to go in for other immunosuppressants which are less hepatotoxic, like tacrolimus or.
Thanks, thanks, Dr. Siddhi.
By biopsy, probably we can differentiate.
Yeah, we of course deal with the population. 10% of our population are diabetic, 30% of our patients are obese. So added risk factor for NASH. But I think it's a very interesting topic. I think we should carry it along beyond the stage. So in the interest of time, we'll ask the next person. Thanks.
So moving on to the next topic, very important topic. In the last session, we spoke about a lot of drugs we use in lupus. So now I call upon Dr. Vignesh to speak on non-pharmacological management of lupus. Dr. Vignesh is a consultant rheumatologist at Apex Center for Rheumatology, Warangal. Also assistant professor of rheumatology in MGM KMC, Warangal. He's trained in Madras Medical College as a DM rheumatologist. Over to you, Dr. Vignesh.
Thank you for the introduction, sir. Good morning, everyone. At this outset, I would like to thank the organizing committee for giving me this opportunity to be a part of one of my most favorite sessions, that is lupus. So all whole sorts of inspiration goes to my ex-HOD, Dr. Rajeshwari Madam, who has always been my role model in establishing and creating communication skills with the patient to improve the patient outcome. So the American College of Lifestyle Medicine has talked about 6 lifestyle measures which are really important for any human being who wants to live long. The first thing is good food, physical activity, stress management, avoidance of risky behaviors. I would like to modify with regards to lupus, not risky substances, risky behaviors, a good restorative sleep, and a good social connection is what is all needed. So the next 15 minutes, I'll be discussing about why do we need to discuss a lot about non-pharmacological management in a disease where you have a lot of advanced therapeutic options. I'll take you through the individual 6 pillars of these lifestyle managements, and in each particular topic, I would be discussing on what I do in my day-to-day clinical practice to make it even more practically applicable. So lupus, as we all know, is a heterogeneous systemic autoimmune disease. Despite having advances in newer pharmacotherapeutics, patients with lupus still experience a poor health-related quality of life. Though patients, we are happy as a doctor saying that the patient has achieved a DORIS remission or something, substantial proportion of patients still develop organ damage and they experience severe pain which cannot be treated by the regular immunosuppressants or steroids what we give. They suffer with fatigue and their entire quality of life is impaired. The use of lifestyle changes as complementary interventions in addition to pharmacotherapy has not been thoroughly studied, but yes, the good thing over here is we need evidence to do anything, be it pharmacologic or non-pharmacologic, and the evidence is evolving. So as indicated by this 2024 EULAR recommendations, which was talked at least to start with about the non-pharmacological management of lupus, which we were doing to our patients traditionally. So the first pillar here is diet. The moment a patient gets diagnosed with lupus, the first question what the patient asks is, I don't drink, I don't smoke, I don't have any adverse social behaviors, why am I having this disease? And what food makes my lupus cure? So these are the first and foremost thing our patient asks us. And before going into that, one important warning here is about the lifestyle changes, what is happening in our country, that is the kind of westernization. And as I was telling, about 30% of the patients are obese. When you go with the Indian cutoff of BMI of 23, almost 80% of us in this hall would be falling under the obese category. And if this obesity starts in the childhood, this Danish observational cohort study has shown that a higher BMI or a taller child is at a higher risk of developing lupus in the future. So this is a warning sign, and not only to prevent non-communicable diseases like diabetes and hypertension. So maybe this might evolve and say that if there is a family history of lupus, the children should be taken care to have a very good diet so that they don't get obese and get predisposed to the development of lupus. Lot of randomized control studies, lot of non-RCTs, smaller and larger sizes, trying out each and every potential dietary possibility to cure lupus or treat lupus. A few of things which I would like to share about. There are a lot of talks about polyunsaturated fatty acids, omega-3 and omega-6 fatty acids, which were found to have a significant impact by having a higher levels of concentration of these eicosapentaenoic acid and docosahexaenoic acid in the platelets with lesser lupus activity. The median period of follow-up that was available was between a period of around 12 weeks to 34 weeks. And there were few studies which were in favor of the same, and there were few studies which were in contradictory. There are multiple ways of diets. A few RCTs were conducted on low-fat diet. A few RCTs were conducted which compared a hypoglycemic diet from a hypocaloric diet. None of the diets improved the disease activity of the patient, but at least it had a step ahead to improve the quality of the life of the patient. And whatever diet you follow, if at all it's going to be a healthy and balanced diet, that is going to work in these patients. So this is a systematic review which was conducted in 2015, which said that there is some potential role for polyunsaturated fatty acids, either as a supplement or as a dietary supplement for improving the lupus activity. And in the year 2012, an RCT was published on curcuminoids, which said curcuminoid administration decreases proteinuria, hematuria, systolic blood pressure when compared to the control groups. That was only a single RCT which had an intermediate risk of bias, and there was a potential increase in complement levels, especially C4 after treatment. And there was an RCT which was published in 2017 which talked about green tea extract with most talk of the town as of now, and the results were quite ambiguous. A big blow was given by this meta-analysis which was conducted in 2022, which compared various dietary adjustments and supplementations, and especially the omega-3 fatty acids, what we were talking about before 2015, got proved to be having a no significant impact. There are a few non-RCT designs which shows that higher intake of vitamin C, B6 and dietary fiber are associated with decreased disease activity. A higher vegetable fat intake is associated with increased risk of cardiovascular risk. And there is a recent cross-sectional study which was conducted on Mediterranean diet, which was associated with lesser disease activity and lesser organ damage. So due to the variegated results in pro and in contrast with RCTs and meta-analysis, the EULAR recommendations does not give a specific recommendation on diet. So what do we do in our center? So getting inspired from Madras Medical College, where we do lupus awareness programs every year. So down in Warangal, I've been here for the past 5 years. We are conducting lupus awareness programs to our patients. So sorry for the Telugu language that is here. I didn't want to edit this so that people should be knowing what we are trying to teach our patients in their own understandable language. So there is no hard and fast rule to say what to eat and what not to eat. As doctors, we know patients, as rheumatologists, we know our patients are at, most of our lupus patients would be on glucocorticoids. They would be put into the risk of obesity. And Dr. Sridevi was talking about fatty liver disease and other things. So we generally give such pamphlets to our patients and say, drink more, plenty of water and fruit juices compared to the packed and processed foods. go in terms of more of whole grains rather than going for a refined wheat flour or a maida or something kind of. Prefer a poultry-based animal product or a seafood-based animal product compared to a red meat. Prefer a low-fat dairy product, low-fat milk or low-fat curd over a high-fat milk or curd. Prefer dry fruits which are not salted. Prefer vegetables and fruits that have been taken in terms of salads rather than the tasty and yummy sauces that are available. So whatever look tasty is not healthy. Whatever that is packed is not healthy. There are a lot of awareness about these things in social media about a good diet and a good gut that is really more important. So we also insist on smoking cessation and alcohol cessation apart from other drug behaviors. So in collaboration with a cardiologist, endocrinologist, in Warangal we have also launched an application which is called as Fight for Being Fit. So this is an app which provides dietary consultations by professional dietitians, physical trainers who would give us online sessions about weight reduction strategies. And happy to say that we have got about more than 10,000 downloads till now. And it's a long way to go, and even most of our patients are getting benefited by these diet regimens. So coming to the second pillar, which is the physical activity. So physical activity, yes, various RCTs says that physical activity improves the fatigue and improves the sleep hygiene of the patient, but it does not have any hopes on improving the disease activity or improving the organ damage, depression, or improving the physical capacity. In contrast, there are a few meta-analysis which says that physical activity trained in a particular way, in an appropriate way, improves fatigue, depression, physical health and function, though it does not have any impact on disease activity. So we have beautiful medicines for controlling disease activity. We are concerned about the non-pharmacological points, that is fatigue, pain, depression, and sleep disturbances, which will all improve with physical activity. So my trainer used to say me that if you are not able to give an hour time for you to stay physically fit, and there is no purpose of us living in this world because we need to stay healthy. So yes, we do recommend our patients to be physically fit. And just not by saying that do an exercise, you should be even more specific on what to do. So there are 4 important kinds of exercises that are important. One is an aerobic exercise, which could be a simple walk, a jog, or a run, or a swimming if at all he is interested. Second thing would be an in-home resistant band workout, which does not need costly dumbbells or different weights of dumbbells. Just a resistant band would be enough to strengthen all the muscles. And third thing, which should be followed by stretches at the end of the workout session. And yes, at least 2 days a week, you need to go for some neuromotor coordination, which would be enabled by our own Indian technique, that is yoga. So physical activity should be considered for patients with lupus. And aerobic exercise increases the aerobic capacity, it reduces the fatigue and reduces the depressive symptoms. So this is the 2018 EULAR recommendations for physical activity in patients with inflammatory arthritis and osteoarthritis. This has been taken from the American College of Sports Medicine recommendations, and it is available online. You can go through this and suggest along with your physiotherapist. So what do we do in our center? We have an in-house physiotherapist who focuses on physical activity, exercise therapy, who concentrates on these 4 domains of exercises and caters patient-specific services if at all needed. So we encourage our patients to exercise indoor. We ask them to go for supervised exercises whenever they are feasible or affordable. And we also tell them to go in terms of not only fight fatigue, whatever health application that concentrates both on diet and exercises. The third important pillar is the stress management. So this is the increase in prevalence of psychiatric symptoms with lupus. See, what I say my patients and what we observe from our patients is if a patient is diagnosed with cancer, he knows he will survive or he will die. So if he's going to survive, he is going to survive for long without any more complications. But it is not the case with our lupus patients. My colleague Dr. Balaji in SRMC used to say me that lupus is like an atom bomb. It can burst anytime. So that is a kind of fear and anxiety what our patients develop over the roller coaster ride they had during their initial phases of the illness. So cognitive dysfunction followed by depression and anxiety is the most predominant. As you're able to see from this article, about 55% of the patients are having some kind of mental disturbances, and it's a need of the hour to screen our patients with a basic psychological evaluation. If at all we find the patients at risk, we have to refer them to the psychiatrist. Cognitive behavioral therapies and counseling sessions have been found to improve the pain, physical and psychological function. Counseling sessions improve anxiety and improve sexual function if the patients are having sexual dysfunctions. And meta-analysis also goes in the same favor in addition to improving the health-related quality of life. So here comes the EULAR recommendation, which says that you have to involve our patients to undergo psychosocial interventions to have a better outcome. So this is what we do in our center. We screen at-risk patients. If a patient starts feeling low, at least spend a bit more time when I feel she or he is at deep mental risk. Not only counseling the patient is enough, bringing in the parents, bringing in the spouse, and motivating them and saying that psychiatry is not a stigma to go and meet and get yourself counseled. So that is a kind of motivation. So we should start taking as a role as a family member or a near and dear, so that the patient develops trust over that doctor, and the patient is nearly motivated to go for the psychiatric medicines. So whenever the patients don't be compliant to the psychiatric medicines given in addition to our pharmacotherapeutics, it is our responsibility to reassure and ensure them that they are going to get better and better. The next point, as the most important thing, is avoidance of risk behaviors. So smoking has been invariably proven to have adverse outcomes in patients with lupus. Luckily, with our Indian culture, very few of our female patients smoke, so smoking should be avoided. Alcohol, there is a long-term saying that in moderation it is protective for lupus, but we generally don't advise our lupus patients to take moderate alcohol. This is just an evidence which I wanted to quote. UV exposure, yes, it needs a detailed discussion which we'll be going through now. And cold exposure is another thing which also is important even though the patients are having lupus. Okay. So this is what we do in a good photo protection practices. It's better to avoid sun exposure between 10 a.m. and 4 p.m. It's not only in the summer, it's all through the year. So coming to the fabrics, what the patient wears, the fabrics, in contrast to what we think light colors are good for summer and dark colors are not good for summers. So basically, darker colors absorb the UV light and prevent them from entering our body. Our body might feel hot, but the UV rays are directly absorbed with the dark colored fabrics. So dark colored fabrics are preferred over the light colored fabrics. Tightly woven fabrics are preferred over loosely woven fabrics. And fitting of the dress should not be tight, it should be loose, so that the tightly woven fabric does its purpose of UV protection. And yes, sunglasses should be covered. A few sunglasses are available which is having a UV protection grading of, say, UV protection 400 is what they say. And there are UV protected hand gloves. So we see a lot of Indian patients using a cotton-based hand gloves while they're driving a bike or scooty. That is not going to work for our patients. You need to have, these are all available in the Amazon online. Online it is available, so you can advise the patients to get them. And yes, a fully covered scarf is always better than a half covered scarf. A wide brimmed hat is always better than a cap. A long sleeve and long pant, in contrast to our tradition, is always better. UV protection jackets are available. Coming to the indoor lightings, always LED lightings and fluorescent lightings are safer when compared to the filament lights. And wherever possible, try to give a protection with sunshades. So about sunscreen, you have two types of sunscreen, physical and chemical. They have been proven to be photosensitive and preventing cutaneous and systemic flares. They are available as gels or lotions. And the measure what we see is 30 for indoor and 50 for outdoor. This is going to be for UVB protection, and UVA protection is assessed by penetration activity factor. That is, it should be between 3+ to 4+. The main problem comes here is the quantity of the sunscreen that we use. So for applying it all over the body, you need at least 34 ml for a person who is having a body surface area of 1.73. So this is what a kind of UV protection links we share to our patients so that they make use of it. So this is a kind of lupus awareness exhibitions what we do in our hospital every year and teach them how to use these articles. So the problem with photo protection is about 1/3 of these patients are still not aware about a multicentric study which was conducted on about 600 patients. And with the market going crazy with the sunscreen, everyone claims their sunscreen is waterproof, sweatproof, and sunblock. These claims are totally absurd. And everything should be taken with a note of caution. It should be taken with the help of a dermatologist alone. So coming to the photo protection challenges, again thing is, though initially we were of the fact that photo protection prevents cutaneous flares and systemic flares, recent evidence says that there is no correlation between the disease activity of damage based on the photoprotective scores. Of the main reason being the fact that though people are aware to use photo protection, people are not guided in a proper way how to use these photo protections. So these are kind of dolls we use. In summer, we use it for photo protection, and same doll, we change up the dress and create awareness in our patients for preventing and controlling Raynaud's phenomenon. And this is to indicate that one of the main hand dysfunction is in lupus patients are impaired even by Raynaud's also. So sleep hygiene, I think this will be my last few slides. So a good comfortable bedroom which is having darker colors and with window shades. So this is a better home what you can afford if at all a person is able to afford for that. So there are a few sleep hygiene measures which are indicated. Reading a book or something, having a warm bath before sleep would be helping. Better to stop eating an hour before bedtime. Avoid drinks like caffeine or soda. Turn off all electric devices 30 minutes before bedtime. There is something called a 15-minute rule. If you don't feel asleep, go out to go to the hall, sit there, do something, and come back to the bed after 15 minutes. That will improve the sleep. Wake up, sleep at a constant time and wake up at the same time. If at all you are a person who would take day naps, plan your naps between 20 to 90 minutes on the same time every day. And get moving to sleep earlier, which means physical activity improves your sleep hygiene. But it is not studied yet. So the last but not the least is about the social connect. This is a study on 210 hospitalized patients in which it was found that about 95% were totally uncertain about what disease they are having. They are not getting adequate social support. They are not being trained how to cope up with the disease. So lack of social connect is the key. So as doctors, what we are supposed to do is start listening in addition to medical aspects. We should pay attention to the psychological issues, social factors, and cultural factors. Where they are from, they are married or unmarried, how is the social background, those things should be considered. And we should allocate medical staff to guide the patient's health. And luckily, we have a medical social worker who sits and talks with our patients and who is an MSc psychologist by his own designation. He takes care of these things and makes my job easy. And yes, patients should also make use of the feasible available social support systems. They should be guided to avoid yielding, and there are a lot of suicidal ideations happening in our patients, and our patients should be trained to face lupus with a positive outcome. So to sum up, a balanced healthy diet which avoids processed and deep fried food, with a proper diet plan to maintain optimal weight, a supervised indoor physical activity concentrating on 4 domains of exercises shall improve the fatigue and improve the quality of life. Psychological interventions, counseling sessions, and antipsychotic therapies improve anxiety, depression, and fatigue. Smoking cessation, cold protection, and photoprotective awareness campaigns should be conducted every year so that patients are getting aware. Sleep hygiene needs to be studied. Lupus is tough, so are our patients. So social connect is the need of the hour. The last slide, which is 3 beautiful kids of my lupus cohort of the last 5 years. So the first is a child who diagnosed with lupus at the age of 14 years, and it's about 3 years of follow-up. So she herself, having made a good social connect with the child, she herself has created an art saying that let's make lupus visible. And the second is a boy who was diagnosed with lupus with extensive cutaneous manifestations, doing well with azathioprine, and now he is an engineer joining his first year in Hyderabad. And the third one is a person who is having the longest follow-up of 5 years, who has been suffering from lupus nephritis, still challenging and struggling with multiple immunosuppressants, has now become an agriculture officer in her own mandal, which is a kind of proud what the patients keep sharing with us. So one thing we should remember is medicines alone can't heal lupus. It is our tender love and care which will add on to treating lupus. And I thank you for the patient listening. Thank you.
Thanks, Dr. Vignesh, for the exceptionally brilliant presentation. I think Warangal is fortunate to have you there. Any questions from the audience? It was actually such a great thing to have an app for your population. And generally one of the things, fruit juices, and I think people say like the Tetra Pak fruit juices have more sugar than anything else. So probably it should not be. Do you come across that when we say?
Yes, sir. We tell our patients to take fruits as fruits if possible. If you want to take in the form of a juice, better don't filter it. That will reduce the fiber. And better avoid adding sugars to the juice, because juice itself, it's sweet. We don't add honey to the salads what we eat, which are made of fruits. So that is the way we communicate our patients. So anything that is in excess is not going to good for the patient.
The thing is, what we do, like the sitting is the new smoking, isn't it? Like,
sir? Sitting is the new smoking. Staying idle is the next smoking. Yeah, so I think we should be more aware about it and keep training our patients.
Which are the last question from Dr. Damu?
Do you have any prebiotic food for patients suffering with rheumatology practice?
Yes, sir. So I can't comment on because I'm not an expert in nutrition and other things. But what I would say is the balanced healthy diet, which would include the whatever easily available prebiotic foods like curd or buttermilk, which is the best prebiotic which I would say for my patients. Many of them fear to take curd. That is one thing. And apart from this, what kind of prebiotic I'm not able to get you? Okay, so sprouts, vegetable salads. So these are, I'm not a professional person to comment or talk about it. So this is what my dietitian used to tell about while talking about gut health.
Thanks, thanks, Dr. Vignesh.
Thank you, sir. Thank you.
I would like to summarize by congratulating all the three speakers, Dr. Santosh, Sridevi, and Vignesh, who gave an exceptional presentation today morning. Thank you very much. Thanks for audience for the patient listening.
Thank you, chairpersons. So now we are going to move forward for the third session. And for this, I welcome the chairperson, Dr. Bhuvanesh, consultant rheumatologist at KIMS Health, Trivandrum. So I request the chairperson to introduce the speakers.
So I think we have 3 talks in this session. Can we have the introduction of the speaker? Yeah, good. The first talk will be given by Dr. Mahabaleshwar. So he will be talking on, so it is very clear that I'm a makeshift chairperson, isn't it? Yeah, so he'll be talking about the update in the diagnosis and management of IgG4 related diseases. Dr. Mahabaleshwar has pursued his DM in clinical immunology and rheumatology from Chennai. He is presently working, okay, I can't see it there.
Yeah, he's assistant professor at JSS Hospital, sir.
Okay, so he has introduced himself. Okay, so over to you, Dr. Mahabaleshwar. Thank you.
Thank you for that kind introduction, sir. And I thank the organizers for giving this opportunity. I shall be talking on update in the management and diagnosis of the IgG4 disease. So the agenda is introduction, organ involvement updates, update on classification criteria, emerging biomarkers, IgG4-RD subtypes, and management updates. So IgG4-RD was almost defined around 2 decades ago. It's a relapsing and remitting disease course, and it is predominantly seen in males and in elderly 50 to 70 years, and it often presents as a mass lesion or a organ enlargement, and geographical variance in prevalence is around 0.28 to 1 in Japan and 5 per 1 lakh persons in United States. More than 75% of the patients with IgG4-RD have 2 or 3 more organs involved. And typical organs which are frequently involved are salivary glands, lacrimal glands, pancreas, and retroperitoneum. Now we shall discuss about the updates with respect to the organ involvement. So IgG4 related ophthalmic disease, it is one of the most commonly involved organ. Usually in the last 5 years of literature review, it was shown that orbital and orbital adnexa were more commonly involved. Sclera and intraocular tissues were less commonly involved. There is no gender predisposition, and the mean age of onset is lower than the whole of IgG4-RD entity. And lab investigations, it was shown that these patients have high serum IgG4 levels, IgE levels, and peripheral eosinophilia with cytokines mediating Th2. And histopathology, presence of storiform pattern and obliterative phlebitis is rarely seen in IgG4 related ophthalmic disease. And sialadenitis, like IgG4 involving the head and neck, it is more commonly seen in females, and it has a lower age of disease onset, and the lab findings are almost similar to what I discussed earlier. However, allergic conditions and multi-organ involvement were more commonly seen in patients with sialadenitis. Hypophysitis, it has a slow disease onset and relatively longer disease duration. Panhypopituitarism was the most common clinical symptom, followed by enterohypopituitarism and central diabetes insipidus. And MRI findings showed that like pituitary and stalk were involved, followed by stalk and followed by pituitary involvement. And pituitary biopsy was a highly invasive procedure, so it is difficult to diagnose. However, in 2011, a new diagnostic criteria was proposed where there was no need for pituitary biopsy in diagnosing these patients. And systematic review of IgG4 related respiratory disease showed that 4 patterns are involved mainly in IgG4. It can usually involve as a nodular pattern, small or pericentimeter nodules which are randomly distributed, or it can present with the interstitial lung disease pattern, or it can present as peribronchovascular thickening or ground glass pattern. So with respect to the respiratory manifestation, lung involvement was seen, followed by mediastinal lymphadenopathy, pleural involvement as a pleural effusion, and aorta, thoracic aorta, airways, pulmonary vessels were rarely involved. So IgG4-RD involves the pancreaticobiliary tract, and it is one of the 4 phenotypes which were described. 87% of these patients had pancreatic manifestations in 2 large cross-sectional studies. In fact, Professor John Stone tells like what kidney is for ANCA-associated vasculitis, pancreas is for IgG4 disease. So we should be very vigilant if the pancreas is involved. Autoimmune pancreatitis is the most common pancreatobiliary manifestation. And so autoimmune pancreatitis 1 is more common with IgG4 disease, more in males, elderly, Asian predisposition, presents as obstructive jaundice, whereas AIP2 presents as acute pancreatitis. And pancreas involvement with cholestasis goes more in favor of IgG4 disease. And IgG4 levels are usually high if it is autoimmune pancreatitis 1, whereas these levels are not elevated in AIP2. So IgG4 related retroperitoneal fibrosis. So retroperitoneal soft tissues are symmetrically or asymmetrically distributed around the abdominal aorta, iliac artery, inferior vena cava, kidneys, ureters, and lumbar muscles. And CT, MRI, and FDG PET may help for imaging. However, these methods cannot differentiate between benign and malignant forms of retroperitoneal fibrosis. However, histopathology from the surgical biopsies remains the gold standard. Periaortitis and periarteritis. In a systematic literature review, they studied about these organs, and they proposed that it was more common in the elderly, and most common sites involved were infrarenal, abdominal, and iliac arteries. And elevated inflammatory markers like CRP are common in this disease, which is distinct from other types of IgG4-RD. And distinguishing retroperitoneal fibrosis from periaortitis is sometimes difficult, and the risk of aortic rupture should also be kept in mind. This is a single study, a large study with respect to the IgG4 related kidney disease. Like 125 patients with RKD were included and studied at Mayo Clinic, USA. It has actually 2 subtypes. 94% were tubulointerstitial nephritis, and 16% had MGN subtype. So 80% were males, and 78% presented with acute renal failure or chronic renal failure. 17% had proteinuria, 15% had mass lesion, 80% had extrarenal involvement at presentation, and 90% had high IgG4 levels. 56% had hypocomplementemia. In fact, complement level assessment also helps in monitoring the disease activity if there is renal involvement. Another imaging finding was contrast ion CT scan showed that there was diffuse patchy involvement and multiple low density lesions in the cortex. So other sites, these are the sites which are less involved, rarely involved, like lymph nodes. We have to rule out these findings with multicentric Castleman's. Thyroid, it can present with high TPO antibodies or subclinical hypothyroidism. GI tract involvement, there can be gallbladder wall thickening, or liver, it can present as a pseudo tumor or hepatitis. Skin, it can present as cutaneous nodules or plaques. Bone erosions, pseudo tumors. Testis, epididymoorchitis. Prostate, it can mimic benign prostatic hyperplasia. So we all are aware of this classification criteria, 2019 ACR and EULAR. So it had actually 4 domains: clinical, radiological, pathological, and serological. And exclusion criteria for antibodies, other ANA antibodies was included. And inclusion, there were 8 weighted score of more than 20 points across 8 domains, and it fulfills the classification criteria. And the most common organs involved were considered in this, like kidney, chest, head and neck, pancreas, and biliary tree, retroperitoneum was considered. Like with respect to the retroperitoneum, circumferential or anterolateral soft tissue involvement carried more score, and pancreas with biliary involvement carried 19 points. And cortical lesions in the kidney carried 10 points. Chest involvement in the form of peribronchovascular thickening, and tissue over the band like soft tissue over the thorax carried more points. So, however, this classification criteria, they focused more on specificity, and it had some limitations, like hypocomplementemia was not described, and it was done, 79 investigators were involved in devising this classification criteria, and they had no proper criteria, inclusion and exclusion criteria for taking the case controls. Okay. And so to overcome these limitations, revised classification criteria was proposed by Japanese Rheumatology Association in 2020. There they combined clinical and radiological criteria, serological criteria, and pathological criteria. Clinical and radiological, 1 or more organs with characteristics of IgG4-RD and diffuse or localized swelling or a mass or nodule. They excluded single organ involvement, lymph node swelling, and serologically serum IgG4 levels of more than 135 milligram per dl. Pathologically, 2 items were considered, like it can be diffuse lymphocyte infiltration and IgG4 plasma cell ratio and typical tissue fibrosis. So if clinical and serological domains are involved, it is possible IgG4. If clinical and pathological domains are involved, it is probable IgG4. If all 3 are involved, it is definite IgG4. So how it was different? They tried, they did a retrospective study in 50 patients, and in fact this criteria needs to be validated. So it was more sensitive compared to the ACR classification criteria, but it was less specific. 42 out of 50 suspected cases diagnosed with IgG4-RD, and patients with IgG4-RD had a significantly more affected organs. So IgG4-RD has noticeable patterns of involvement. Atopy is seen. Allergic symptoms are more common in patients with head and neck involvement, and elevated serum Ig levels and eosinophilia is seen. However, the role of allergies in IgG4-RD is unclear. So in 2023, John Stone proposed 2 subtypes of IgG4-RD which would help in management of these patients, like proliferative subtype and fibrotic subtype. Proliferative subtype involves multi-organs like glandular tissues, pancreas, bile ducts and kidneys are involved. These patients will usually have high IgG4 levels, IgE, IgG1 and hypereosinophilia, and they usually have low complements and they are treatment responsive. Whereas fibrotic subtypes, single or multi-organ involvement and lab findings lab markers will be normal here, and they have limited treatment response. This also helps in planning our treatment. So how will you monitor the disease activity? With respect, I have only focused on the markers, immunoglobulin markers, like IgG4 usually is increased in 70 to 90% of the patients, and once the treatment is started, it briskly decreases, and then there will be a gradual fall. It may not completely return to normal, and increase from baseline indicates return of active disease. Also, other markers are high Ig levels at baseline and hypereosinophilia. These patients are more prone for relapse. And complement levels, these are decreased if there is renal involvement, and also it indicates the flare. So damage is assessed by our renal function tests, urinary protein levels, and for liver it is liver function tests, and for pancreas involvement it is HbA1c, fecal elastase, vitamin levels, vitamin and zinc selenium levels. So coming to the effective management of IgG4-RD, so management usually focuses on whether it all depends on the particular subtype of the IgG4-RD. whether there is occasional spontaneous remission, whether it is indolent progressive, whether there is additional organ involvement over time, or whether there is irreversible damage of vital organs. So it can be mainly divided as induction with glucocorticoids, maintenance with low dose glucocorticoids or immunosuppression, and monitoring the disease activity. So actually in 2014, the treatment guidelines for IgG4 were proposed, and it was revised in subsequent conferences. So glucocorticoids are the cornerstone of IgG4-RD treatment. So induction, which was proposed, was 30 to 40 milligram of prednisolone, which was maintained for 4 weeks and tapered gradually over 8 to 12 weeks. And 97% of the patients had therapeutic response. The therapeutic goal is to reduce inflammation and preserve organ function. However, once stopped, 24 to 54% had a relapse, and they usually presented with organomegaly and organ dysfunction. So they proposed some proposed long-term glucocorticoid treatment, like Japanese proposed long-term glucocorticoids for 3 years. However, around 40 to 50% patients had impaired glucose tolerance, and later they thought glucocorticoids plus immunosuppression can be used, but evidence for their efficacy remains slim. However, there are 2 Indian studies which I will discuss later. And maintenance, use targeted therapy or B-cell depletion. So treatment diseases are multifactorial, whether it is proliferative or fibrotic, clinical disease phenotypes, isolated organ or multisystemic involvement, urgency of presentation, like biliary strictures or lymphadenopathy. Like if it is biliary stricture, biliary stenting can be done. And predictors for relapse, which I have already told you, hypereosinophilia at baseline, high IgE levels, and multi-organ disease, and if the serum IgG4 levels are 2 times the upper limit of normal. So age also has a role. It mainly involves the elderly age group. Look for the comorbidities, public health factors, and insurance coverage. So before talking about the new drugs, just want to highlight about the pathogenesis of IgG4-RD. Activated B cells migrate to the inflamed tissues and promote T cell expansion. And then the CD4 T cells induce apoptosis and release of these perforins granzymes. And then there is release of macrophages, clear the apoptotic cells and secrete various cytokines, which causes tissue fibrosis. So newer treatment targets are, like they have targeted CD19, 20, Fc gamma R2b, BAF, and BTK, and SLAM F7. Rituximab phase 2 studies are completed, and however, there was one study where they used rituximab. Induction dose of rituximab for the patients were without relapse for 18 months. However, they relapsed after 18 months. When the maintenance dose was given, they had a better survival. Case series from India. The largest case series is from Gangaram Hospital. 70 cases were studied, and the female to male ratio was 1:1, and orbital involvement was more common. 13% had multi-organ involvement, and azathioprine was most commonly used steroid sparing agent. CMC Vellore, most common involved site was eye. They studied 41 patients. 91% had good response to glucocorticoids, and MMF was the most commonly used steroid sparing agent. And there are other case reports, other case series from Ophthalmology Institute, Hyderabad, and PGI Mayor. So in summary, treatment decisions should be individualized. Glucocorticoids remain the cornerstone for introducing disease remission, and development of novel targeted agents, this has a hope, and lifelong follow-up of these patients is advisable. I want to conclude my presentation with John H. Stone's IgG4-RD lessons. Thank you, sir.
Thank you for that wonderful presentation. It was quite comprehensive. You have covered almost starting from diagnostics to therapeutic aspect of IgG4 related disease. Any questions from the audience? Yes, please.
How early should we keep our eyes open in a single organ involvement? Like you said, subclinical hypothyroidism can also be presenting feature in an IgG4. So is it the CRB or the eosinophilia which should help us, early getting an IgG4 levels done? And how how quickly should we, think of IgG4 in a single organ involvement?
Data with respect to the single organ involvement is very less, sir. Less, ma'am. Even the classification criteria excluded single organ involvement, so it would be difficult. Like we have to focus on the other markers, because 60 to 70% will have multi-organ involvement, and if you are suspecting, better to go for the CT chest and abdomen in these patients, and also IgG4 markers can be tried, ma'am. CRP is increased in head and neck involvement, like.
Is there any entity like secondary IgG4 disease due to underlying autoimmune any systemic autoimmune diseases?
Sir,
secondary IgG4 disease.
Secondary IgG4 disease, sir. Not aware, sir.
What is the treatment of the fibrotic type? You said medicines don't work much.
Yes, sir.
So
like
fibrotic type, any specific drug or anything?
No, sir. It is difficult to manage. So that is how they have classified. Proliferative is responsive to treatment. Fibrotic, it won't work much. Anyhow, they will start with steroids and MMF and azathioprine as per the Indian studies.
I'll ask just one last question. We know that IgG4 disease is a relapsing type in most patients.
Yes, sir.
So what about, have people looked at adding upfront second-line agents like disease-modifying agents in patients with IgG4-related disease, especially if they have, predictors of relapse?
Yes, sir. In the last 5 years, whatever data I went, sir, like I could not get studies where the upfront DMARDs were used, sir. It was like steroids, wait for the response, and then if not responsive, then it also depends on, like if pancreas is involved, maybe they may be more aggressive.
That's what I'm trying to figure out. If there is some kind of an organ involvement or some predictor of relapse, then we should probably. Yes. Okay. Anyway, for lack of time, we'll close this particular talk.
Thank you, sir.
Thank you. For the next talk, I invite Dr. Shiva Prasad. Dr. Shiva Prasad had his DM training from Sanjay Gandhi Institute of Medical Sciences, Lucknow. He is presently an associate professor in the Department of Rheumatology at the JSS Hospital, Mysore.
Thank you for the introduction, sir.
And he would be speaking on jackpot study. What do we learn?
Yeah. At the outset, I thank the organizing committee and the scientific chairperson for giving an opportunity to talk about this. So when sir called me first and asked that you have to talk on jackpot, so I was thinking that I had got a jackpot of bigger thing and I should be speaking about something groundbreaking and other things. But after going through the study, I again messaged him, sir, is this the same study which I have to present? Sir said, yes, it is the same study you have to present. So then I realized that, okay, so let us go through again. After reading 2 times, I thought that at the end of the day, I would be giving only 1 or 2 practical points about this study. So after coming over here, so my jackpot was completely different. So Kelo South Zone SZIRACON was the jackpot for me. Thanks for the organizing committee for the innovative idea. So coming back to the study. So jackpot study, what do we learn? So what was this study basically? So the heading of the study is evaluation of discontinuation of adverse events of JAK inhibitors and biological DMARDs in an international collaboration study in rheumatoid arthritis patient. So that's what the jackpot study is. So it is recently published in 2024. So what is the points which we are going to take home at the end of the day? So it's about the second line of drugs in RA, and here we are talking about JAK inhibitors, TNF inhibitors, and drugs with other modality of action. And what we are bothered about is about the patient characteristic is about the age and the cardiovascular risk. And also the main point which we are going to look into is the adverse events because of all these agents. So we know that after the introduction in the recent 4 to 5 years, so the second line of drug which has become the small molecule, the JAK NSS become more common than the TNF inhibitors. So currently we know that we have got 5 JAK inhibitors, that is baricitinib, figlotinib, pevicitinib, tofacitinib and upadacitinib. Pevicitinib is available only in Japan, so most probably we are not going to discuss majority of those things. So why this study was planned? So this study was planned because of this open label study post-marketing safety analysis. So we know about the efficacy of tofacitinib, but here the idea about the post-marketing safety, the clinical trials and this post-marketing oral surveillance study had got discrepancies, saying that tofacitinib had got more risk for malignancy and major cardiovascular events when compared to TNF inhibitors in patients with RA. So what we know about till this study was planned, what we knew about those things. So the clinical trial, that oral surveillance studies has shown an higher adverse events rates in patients with rheumatoid arthritis taking JAK inhibitors, especially tofacitinib, when compared to persons taking TNF inhibitors or other drugs. So there was discrepancy between the observational studies and the clinical trials. So and then this was in the real world, since there was discrepancies, they planned this study. The objective of this study was to assess and compare the overall tolerability and safety of the three groups of drugs, that is JAK inhibitors, TNF inhibitors and the biological DMRs with other modality of action. By evaluating, the crux of this study was about the discontinuation of the drugs due to the adverse events in the real world population. So the second objective was to explore whether the observed effects are attributable to JAK class as a whole or was it specific for tofacitinib. So what was the methodology? So here patient and publics were not involved with the design, conduct, reporting or any other things. It was a investigator initiated observational study, so aiming to evaluate the aspects of JAK inhibitors and biological DMRs in patients being treated as in rheumatoid arthritis, basically as the second line of drugs. The patients with RA starting on JAK inhibitors or any other second line of biological DMRs were included. So the treatment courses, any patient started on first JAK inhibitors was commercially available. This is not with the study group or the basic molecule. It is studied in the last 4 to 5 years. And here 17 centers were registered for this study. Majority of the centers are from the European group. So what we were interested, or the exposure of interest, was patients who are on JAK inhibitors, basically the 4 drugs which are available, that baricitinib, filgotinib, tofacitinib and upadacitinib. Of this one, if I go through or if you can see, baricitinib was more commonly used in the European groups than tofacitinib or other drugs. Baricitinib was used around like 43% of the patients. Tofacitinib was around like 40% of the patients. All TNF inhibitors which are available were being used, and the biological DMRs of other mechanism of action was abatacept, sarilumab and tocilizumab. Rituximab group was, patients treated with rituximab were not included in this study as it was difficult to define the discontinuation of rituximab. Patients, a single patient could contribute for multiple treatment courses, saying that if the patient has adverse events with TNF inhibitors, they can be shifted to JAK inhibitors or the reverse or to other modality of action of drugs. The outcome, the primary outcome which was based for this study was treatment discontinuation due to adverse event. And this decision was taken by the clinician per se and compared across the treatment groups. So here it is important to note that the discontinuation due to adverse events was the main thing. The second thing, all decision was based on the clinician. The secondary outcome which was looked into was the other reasons for stopping of the drugs, and it was given priorities looking into like whether it was first labeled as adverse events, second others, and the third one was ineffectiveness. So here in this group, the drugs, 47% of the patients, drug was changed to shifted over from one group to other group because of ineffectiveness. Okay, that's first basic thing which we have to understand in this study. The statistical method used in this one was unadjusted and adjusted cause-specific Cox proportional hazard models. The second thing was fine-gray sub-distribution hazard model accounting for other competing risks like stopping for ineffectiveness or pregnancy related things, remission or other reasons. And this was cause specific hazard approach. The total patient courses involved in this study was around 46,900. Total patients involved was around 33,500 around. Looking into the table as such, so we have classified the patient into 3 groups, that is the JAK inhibitors, TNF inhibitors and biological DMRs of other modality of action. At the baseline, almost all of them are similar. So just to highlight the numbers, so in JAK inhibitors there are around 12,000 odd people, odd treatment courses. In TNF inhibitors it was around 23,000 and biological DMRs it was around like 10,000, 11,000 nearby. So the numbers are quite good. Baseline characters of all the disease activity markers and all other things are almost similar. When we look at the crude cumulative incidence of stopping due to adverse events, we can make out that TNF inhibitors, which is the lower one, has got the least adverse events and because for the stoppage of the drug. Next comes the JAK inhibitors, and here the other modality of action has got the highest cumulative incidence of adverse events. Here when we subcategorize all these things of the other modality of action, tocilizumab IL-6 inhibitors had got the largest, highest adverse events, and the stoppage of drug was because of IL-6 inhibitors. So when we look at the crude incidence for discontinuation because of adverse events, it was 4.3 with JAK inhibitors, 3.3 with TNF inhibitors, and 4.4 with other mechanism of action. This is for per 100 patient years of treatment. This is how the calculation was. So coming to particular one by one. So when we look into the individual comparison as a group, JAK inhibitor as a group, TNF inhibitor as a group, and other mechanism of action, numbers we can make out. So here, although the absolute numbers are higher, when we go for percentage, it is around like 0.5% or something like that. So when we see for cause-specific hazard ratio, taking JAK inhibitors as the reference, TNF inhibitors, in an unadjusted one, TNF inhibitors has got a good, what do we say, good effect, and at the end of the day, other mechanism of action has got a very hazard ratio of very high. Similarly, when it is adjusted, again, reference JAK inhibitors and TNF inhibitors score the same, but OMA scores the highest one. So again, when we take in the fine grained subdivision, so hazard reference with the JAK inhibitors, the TNF inhibitors scored better when compared to the OMA one. So when this was compared, or the criteria, inclusion criteria was set as the oral surveillance study. That is what called as RCT duplicate cohort. So when the subcategories into that one, so again, so when it is being duplicated, again under the classification of JAK, TNF and OMA, so with the reference of JAK inhibitors, TNF inhibitors scored better when compared to OMA, JAK inhibitors scored better than OMA. And when we looked for with a cardiovascular risk factor in that one, with high cardiovascular risk cohort, which was defined as age of more than 65 years and having a cardiovascular risk factor of more than 1. In that group, when compared to JAK inhibitors, TNF inhibitors did very well, and JAK inhibitors and OMA were almost the same. So again, after comparison with the class and other things, here the comparison come to drug specific one. So when compared with tofacitinib with other TNF inhibitors and OMA, so when the reference is taken of tofacitinib, again TNF inhibitors scored much better than the JAK inhibitors. The JAK and the OMA were almost the same. That is tofacitinib and other mechanism was almost the same. But when the same thing was compared with baricitinib, baricitinib actually scored almost similar to TNF, but it scored much better than other mechanism of action. So to summarize this study, so as a whole, when we compare in a crude way, so when taken reference as TNF, JAK inhibitors, JAK and TNF did almost the same, but OMA was much more higher. When we compare with RCT duplicate cohort, again, the JAK and TNF almost the same, OMA was much more higher. And when we look for with high cardiovascular risk factors, TNF inhibitors scored much better, and JAK inhibitors and OMAs were almost similar when we take as a group. But when we take as an individual drug, with the reference of tofacitinib, both OMAs and TNF inhibitors did much better than tofacitinib. But for baricitinib, baricitinib was much better than the TNF and the other mechanism of action. So to conclude, so JAK inhibitors did not demonstrate higher rates of discontinuation for adverse events compared with the patient with TNF or other biological DMRs in overall population. But higher risk of discontinuation due to adverse events among those with cardiovascular risk factors and older age was higher with tofacitinib compared to TNF and the other JAK inhibitors. Treatment discontinuation for adverse event comprises wide range of adverse events and includes both patient and the clinician perceived safety issues. The conclusions drawn are specific in RA group, and it is not to be extrapolated to the other rheumatic or musculoskeletal disease. So it needs further evaluation per se with the other disease groups. And here the conclusion in this one is tofacitinib to be used in caution with the patients of age more than 65 and having a cardiovascular risk factor. Other than that, to the previous younger age group less than 65 years, it can be used without any other complication. Thank you.
Thank you, Dr. Shiv Prasad, for dissecting out the finer details of that paper. I'll welcome some questions from the audience.
So, treatment discontinuation because of adverse events. So it must be a major adverse events only.
Yes.
So what are the major adverse events noted in this study? Can we?
They have not mentioned about that one.
Maybe that would be mentioned in the supplementary data?
Yes, I didn't include that one in the supplementary because again, going to supplementary will be other different one.
Any further questions? If not, we'll end this particular talk. Thank you, Dr. Shiv Prasad, for the wonderful lecture. Moving on, the next topic is newer imaging techniques in rheumatology. For this, I invite Dr. Meghna Ram Gavali. She is an assistant professor in the Department of Clinical Immunology and Rheumatology at Nizam's Institute, Hyderabad.
Good afternoon, everyone. We are almost at the end of the conference, and I have a very elusive.
Can you please speak into the mic? Speak into the mic.
Sorry.
Thank you.
Yeah. I hope I am audible now. So there's like lot of data in the last 4-5 years in newer imaging techniques in rheumatology. Enormous advances have happened, and so I will consider this talk just as a starter and something which can ignite us to understand about newer imaging techniques in rheumatology and what all we are going to have it in the future and how it is going to affect our clinical practice, and how our dialogue with the radiologist can change, and while reading research articles also, it will help us to know the newer imaging techniques. So imaging is indispensable in rheumatology, where many times the diagnosis can be elusive, and we have a host of traditional imaging techniques, but they cannot differentiate between disease subsets, and sometimes they are unable to deliver an accurate prediction of disease progression and therapeutic response in individual patients. There's no personalization. So there are many advances happening in ultrasound, PET, specialized MRI protocols are coming, and also disease and organ specific imaging tools have been coming in imaging. So it is crucial to understand the strengths and limitations of each modality and their evidence. Many are upcoming. They are into research studies, trials, or case series. So here in this talk, I'm going to mainly focus on some CT and MR imaging techniques which are coming. So this is the outline of my talk. Let's get to the overview. So here we see a joint which is showing a late pathology of RA, where there is a lot of synovitis, large erosions, bone marrow edema, and there is damage in the articular cartilage. So also there is some trabecular bone loss. So all these findings can be easily seen on traditional imaging techniques like radiographs, low field MRIs, CT scans, and DEXA, and ultrasound. But when you have an early pathology, when there is an early inflammatory arthritis, and you have small erosions, early synovitis, little bit of bone marrow edema, some cortical channel microstructural abnormalities, articular cartilage damage which is early. So all these can be seen with the newer imaging techniques. Like the smaller erosions can be seen on a higher resolution CT. The early synovitis, tenosynovitis can be seen on the ultra high field MRI, that is the 7 Tesla one. Also the bone marrow edema. The microchannels and microstructural instability can be seen on high resolution peripheral quantitative CT images. And the trabecular bone loss can also be seen on the same HR high resolution peripheral quantitative CT. And the another one on the right side, we can also do molecular profile of enthesitis, synovitis, or cartilage. So there are newer imaging techniques which are into that, like optoacoustic imaging and GACSEST MRI, where the gadolinium, presence of gadolinium can be detected. So this is the image showing high resolution peripheral quantitative CT in a RA patient. So on the first, here you see erosion, and then this is after giving methotrexate. We see still there is loss of bone architecture, and then there is some remodeling happening after giving JAK inhibitors. There is some remineralization happening there. In CT, many advances are coming. Spectral CT is one which uses the energy dependent information present in CT images. So it can be a dual energy CT, that is our DECT, and a multi-energy photon counting systems, that is SPCCT. That is spectral photon counting computed tomography. So these techniques, they overcome the routine limitations of a conventional CT. They have little bit of less radiation, they have higher spatial resolution, and less noise. So the signal and noise ratio is better in these images. So DCT, it is a dual energy computed tomography. So it involves the high and low energy, high and low voltage spectra to decompose the material, and it allows accurate visualization of the CP and monosodium urate crystal deposition through the 3D reconstructions. So post the processing of the image, there is color coding in which the purple is the trabecular bone, the blue is the cortical bone, and the green color coding is given for monosodium urate crystals. So it also has been used not only in gout, but it also shows bone marrow edema. So in some cases of fracture also, DECT can be used. And also there are some studies in systemic sclerosis where the skin calcifications, where there are more than 20 to 30% involvement, can be seen on DECT. But predominantly in gout, it can differentiate between gout and pseudo-gout, and sensitivity is up to 89% and specificity goes up to 100%. But it has certain limitations. It can be false negative in early cases of gout in less than 6 weeks of duration, and non-tophaceous gout also. And it may offer a low differentiation between the CP crystals and calcium hydroxyapatite crystals. And only if the deposits are very hyperdense, then they can be seen on DECT. If they are very small deposits of tophi, you may miss it on DECT. So this is a DECT image of a patient with gout. In the you see here erosion, a large erosion and a soft tissue tophi in the great toe. And this is the DECT image. Here you can see the MSU crystal deposition in green coding. And then in the longitudinal image, you see a lot of tophi MSU crystal deposition here at the first MTP joints and along the foot, the joints. So even the location and some amount of volumetric interpretation is possible on DECT. Then recently in 2021, the FDA has approved spectral photon counting CT. Siemens is the first company who has come with the SPC CT. So it detects multiple, so when each individual X-ray passes through a patient's body, that each individual photon is assessed as opposed to a conventional radiograph and CTs. And by counting each individual X-ray photon, more detailed information can be obtained and the spatial resolution is improved and the noise is reduced. And 3D image reconstruction is available. This was from an unpublished image. This actually shows low resolution and a high resolution of SPCT image, where in the first image, you are able to delineate the structures, but here they are more clear and with a higher spatial resolution. So to compare between DECT and SPCT, Stamp, Lisa and colleagues had done a study, and they had studied an excised gout finger, which had a core which is showing a subcutaneous tophus, and the X-ray here is obviously showing a big erosion and a surrounding soft tissue density of the tophus. Then this is the DECT image showing a hyperdense tophus here in green color coding. And here you see the SPCT image, which is showing increased amount of tophus where it is not detected here. And also the volume detection is better here and the spatial resolution is better. And this is then the, of course, the synovial fluid analysis, polarized light microscopy confirming the MSU crystals. So what could be the applications of SPCT? It can very easily differentiate and quantify MSU crystal deposits and differentiate them from CPP and hydroxyapatite crystal deposits. It has much better spatial resolution and lesser ionizing radiation than DECT imaging. And also in early cases of gout and very small deposits also can be detected by SPCT. And it is a less time consuming technique. It can also be used in RA-ILD because of the functional component and increased spatial resolution. Also, if rapid whole extremity imaging is done for bone marrow edema, erosions and synovitis to detect the overall inflammation, SPCT can be helpful. Coming to the advanced MRI techniques, whole body MRI, we already know whole body MRI has important implications in diagnosing and assessing disease activity in many diseases like inflammatory myositis, also in CRMO and vasculitis. And also in axial SPA, there are some studies about whole body MRI when there is disease activity or diagnosis dilemma. And then the newer wipe sequences in MRI and SPA will talk about susceptibility weighted imaging, Dixon MRI, and dynamic contrast enhanced MRI. So Dickoff, Kagi, Thurman and colleagues, they had done a study on improved detection of erosions in the SI joints on MRI by volumetric interpolated breath hold examination. That is the CIMAC study. So here they compared the erosions on low dose CT and T1. T1 is the sequence for in MRI for detecting structural lesions. Low dose CT is the standard we know to detect erosions and structural changes, and these are the wipe sequences. So here in the first one, you see the erosion is not seen on the T1 sequence here, but here on the left lower ilium, the low dose CT is detecting an erosion, and also the MR wipe sequence is detecting that erosion. In the lower one, all the three modalities are detecting quite a few erosions, but here we see that these smaller erosions are missed on the low dose CT and the T1 sequence, which are detected by the wipe sequences. And now even though yet it has not been included in the updated MRI recommendations in axial SPA, but most radiologists and rheumatologists working in axial SPA are using wipe sequences to detect erosions, not to miss erosions, especially when there is a diagnostic dilemma, which does happen quite a few times in axial SPA, and also sometimes in follow-up of patients, whether what is happening to the erosions, where they are healing or not, but more so in the diagnostic category currently. MRI Dixon imaging still needs some study. It is not utilized in clinical practice. It is there in trials. So the Dixon imaging basically, it consists of uniform fat suppression. So T2 is a fat suppressed image, but in Dixon there is uniform fat suppression to allow, this is basically to allow faster imaging, decrease the time required for imaging, and to easily delineate fat from bone marrow edema. So these are the, and Dixon images are carried out in 4 phases. So there is a in phase, there is a fat phase, water phase, and the opposed phase. So these are the T1 fat saturated images. This is the T2 fat sat, and these are the Dixon phases showing various levels of involvement of axial SPA. There is bone marrow edema, bone marrow edema and erosions, and fat metaplasia also. Another technique which is useful in RA is susceptibility weighted imaging, where you can easily look for an erosion in imaging. So everywhere in MRI, T1 is the structural sequence where you look for the structural changes. So here in T1 you are seeing an erosion. CT, it is very clearly seen. And then on susceptibility weighted imaging, here the erosion is more clearly delineated. There is higher spatial resolution and less surrounding noise. And then when you invert the same SWI, it looks almost like an CT, and very clearly the erosion can be delineated. Another thing is a dynamic contrast enhanced MRI, which this image shows a patient of RA who had hand and finger arthritis. So it is something like our power Doppler signal, where we see that what is happening to the blood vessel and the neoplasia, the blood vessel and perfusion analysis. So here in the T1 fat saturated first image, and this is the fractal analysis, which shows a lot of hyperemia, and then there is a reduced blood volume and mean transition time, whether it is slow or whether even if there is a less inflammation with low flow in the vessels, it can be detected on the contrast enhanced MRI. I'm not going into very details of advances in ultrasound, but basically power Doppler we all know is important for detecting synovitis which is active. When there is a positive power Doppler signal, we say that the synovitis is active. But if there is a low flow in the vessels and there is a low grade inflammation, it can be detected by SMI, superb microvascular imaging, which can show subclinical activity in RA, and it can help us titrate our therapy, whether to taper it or no. Then gout, we all know the uses of ultrasound in gout, and there is also contrast enhanced ultrasound. So I'll just show you the image of power Doppler ultrasound and SMI. So on the right, there is a MCP joint. This image is showing a power Doppler signal, and this is the SMI, which is showing a lot of microvascular increased activity, lot of blood flow going on in the synovium here as compared to the power Doppler signal. And here it is the left PIP in the power Doppler. You hardly see any signal. But on the SMI imaging, quite a few low flow signals are seen, which show that the disease is still active, and you should rethink about your tapering or how you want to taper the therapy. Then artificial intelligence and machine learning and in imaging itself can be a different talk. But these AI tools and deep learning algorithms, they help us in the interpretation and diagnosis. Of course, they are very accurate, efficient, and they can give personalized healthcare solution. But they currently need very rigorous validation, ethical and legal considerations are there. We need comprehensive training for that. And there is a lot happening in predictive modeling for RA, SPA, with the deep learning algorithms in their diagnosis, and also in the assessment of treatment response and the scoring, OMERACT scoring and all, also artificial intelligent models are coming up. Then there is something which is coming up about optical coherence tomography in assessing skin and superficial joints. So in psoriasis, psoriatic arthritis, early disease, OCT images can help in early skin involvement and also in systemic sclerosis. So what are the future directions? We can have more personalized treatment, more of precision medicine, earlier diagnosis, better monitoring. And potential areas are AI-driven personalized imaging, integration of multimodality imaging in routine practice. They have a lot of research implications and need to be studied on large data sets. So, thank you. These are my references.
Thank you, Dr. Meghna, for that really enlightening talk. You have touched upon some of the cutting-edge imaging modalities, especially in CT and MRI. And you have rightly, touched upon the artificial intelligence, which is, I think, is coming up in a really big way in how images are interpreted in not only in rheumatology, in medicine as a whole. Okay, some questions from the audiences? Yes, please.
Ma'am, it was a lot of learning from that. I want to ask one, so for example, ultrasound, that imaging, that extra, we are getting better than Doppler. What does it need? That machine needs something else, or does it need a software, or how do we get that?
The technical aspects about the machine, I'm really not sure about because I'm not the expert in that. But it should be same. I really don't know about the technical aspects. But it is an further improvisation in the power Doppler technique, where you can see even when there is a low flow in the synovium of the blood vessels, you can detect early inflammation.
Thank you.
What
Power
kind
Doppler
of
requires hardware as well, not only software, it requires hardware as well.
Hardware as well.
The power Doppler ultrasound probe that has different software, so this also will have a different software.
So the sensitivity of DCCT in gout is 89%. So
yes, 70 to 85% almost.
What about SCCT? Is it sensitivity?
SPCCT sensitivity and specificity is Around, it has improved sensitivity around 95%, I guess, because even the smaller tophi are diagnosed and in early cases. But it has to be validated. That is depending on few studies, so the final thing is not yet.
Okay. Thank you, Dr. Meghna. For want of time, we'll be closing this session. Thank you.
Thank you.
Thank you, chairpersons, and thank you, speakers. And now we are going for the last session of CPC. And for this, I invite and welcome moderator, Dr. Arul Raj Murugan, sir. Associate Professor and Head, Institute of Rheumatology, MMC.
This case is from our institute. So it is an interesting case. Many times our field has become a dumping ground or last resort. When somebody is not able to pick up the diagnosis, the cases are referred to us. Such a case we are going to present today. I invite Dr. Vinod to present the case details.
Good afternoon, everyone. Today's case for CPC discussion is, which is an interesting case of our institute, which is followed for up to 3 years from our institute. So, this is a case of 52-year-old female with 2 children, post-menopausal state without any previous history of surgery. Patient had an initial symptom at 2010. Patient had a right jaw pain. For that, she consulted dentist and diagnosed to have a cavity, and some dental treatment has been done during that time. Then after 5 years, patient had developed increased jaw pain and swelling, and jaw pain is also extended to the left side. Then during that time, the dentist suggested histopathology. That histopathology report showed no evidence of TB or malignancy. Then in 2020, patient developed swelling of lip along with dysphagia and foreign body sensation in throat, and she evaluated outside. They also did some biopsy, and biopsy turned out to be negative for malignancy. 2021, this is the first time patient has evaluated at our RGGH and MMC in ENT department with complaints of hoarseness of voice, dysphagia, and provisionally diagnosed as a supraglottic growth. Then from ENT side, they did a biopsy of oral cavity. That biopsy also shows no evidence of any malignancy. Subsequently, she has turned out to be hepatitis C positive. After hepatology opinion, she was treated with directly acting agents by hepatology team, and she also turned positive for occult hepatitis B infection, and she was started on tenofovir. So, in December 2022, patient had progressive dysphagia, hoarseness of voice, and she also developed breathlessness. In view of increasing breathlessness, patient has been initiated on a tracheostomy and Rayleigh tube have been inserted. Then, during that time, histopathology has been done. There is no evidence of malignancy. So, in view of progressive symptoms not responding to therapy, patient has been empirically started with ATT by pulmonology department. ATT was completed for about 6 months. Just before initiating ATT, histopathology showed suggestive of acute on chronic inflammation. So for chronic inflammation, this is the first time our department consultation has sought. So in view of supraglottic mass, we ordered IgG4 levels, AC and ANCA. Histopathology report with the background of chronic inflammation, we started her on low dose steroids. Then patient, in spite of starting steroids, patient had a progressive jaw pain and swelling in oral cavity, and this time the swelling pathology, the patient pathology has been increasing, and progress to mandibles. Then after some time, there is some partial response to steroids. So even after starting steroids, patient lip swelling and face swelling has been progressive. She also had this new symptom, that is episodic tongue pain. The taste sensation were normal during that episodes without any discoloration. So this is the picture of that patient when she got admitted our rheumatology. So patient had a progressive tongue swelling and necrosis of tongue along with the oral cavity, and finally it leads to mandibular destruction. So in view of persistent and aggressive disease, patient has been started with rituximab 1 gram. Meanwhile, she had some tinea infections, and grisofelvin was started by our dermatology department. So patient symptoms has been worsened, so for that feeding jejunostomy has been done by our medical gastro department. So we proceeded with investigations. So common investigations like CBC, peripheral smear, biochemistries, thyroid, ultrasound abdomen seem to be normal. And occult B, hepatitis B virus and chronic hepatitis C virus levels were being high. MRI neck, which was done during the admission at the ENT department. So it showed diffuse infiltrative lesions involving supraglottis and oropharynx with cervical lymphadenopathy. They did video laryngoscopy, and the CT chest turned to be normal. Cardiac evaluation seems to be normal. In view of progressive supraglottic growth and along with cervical lymphadenopathy, we proceeded with PET-CT. PET-CT also showed metabolically active diffuse heterogeneous enhancing lesion involving floor of mouth, supraglottic larynx with significant narrowing at the thyroid cartilage with multiple cervical nodes, likely to be a neoplastic one. So infective workup like COVID, EBV, CMV, leprosy workup, and sexual transmitted disease workup turned to be negative. Then fungal elements are also turned to be negative. So coming to rheumatological investigation, RF, anti-CCP, ANCA seemed to be negative, ANA profile seemed to be negative, IgG4 was slightly increased, and serum AC levels were within the normal limits. So this is the histopathology of that patient. So they suggested acute on chronic inflammatory pathology. Based on that, we have started on steroids. Then this histopathology showed that we did an IHC. In that, CD3 is positive in almost 20% of the lymphocytes. Then CD20 is 40% of the lymphoid cells. IgG4 was positive in few scattered cells. Then this is the repeat biopsy, which showed that CD3 is positive in almost 40% of the lymphoid cells, and CD20 is 60% of the lymphoid cells. So in view of persisting symptoms not improving with steroids and immunosuppressive therapies, we did repeat biopsy. That repeat biopsy is clinched the diagnosis, and patient was discharged with tapering dose of steroids and antivirals for hepatitis B. Ulcer has been started healing gradually. This is the final picture of that patient after starting appropriate therapy. Thank you.
Thank you, Vinod. Now I invite Dr. Avanish Jafar to offer his clinical discussion.
Can we go to that slide 14? I had told him. Directly to slide 14. He has discussed already the exit and go to slide 14. Yeah, slide 14. You can start from there.
That was correct. I'll check. Then leave it to me. Okay, thanks. Yeah. Good afternoon, everyone. I'm Avnish. I'm from CMC Vellore. And thank you for this opportunity, sir, to discuss this case. And when this case was given to me, I was very much intrigued with the complexity of the case and what all could have gone wrong with her has gone wrong over the period of almost a year. So I tried to summarize what we have got from the case history and examination, as well as what investigation have been given. So this is a middle-aged lady with HCV infection. Viral load was high, and hepatitis B only antigen positive but not active hepatitis B, with a lesion which started in the base of oral cavity with progressive features which led to compression of the airway, compression of the pharynx, probably because of which she needed Ryle's tube as well as tracheostomy. And involvement of mandible also happened, with lips also involved. So this happened despite the fact that she was given empirical ATT also, and there was some steroid use, and adequate treatment for hepatitis C was done, and which had shown clearance later. So multiple biopsies for this patient have been negative for cancer, and tuberculosis has not been found. No AFB has been seen, and negative for fungal elements on the smear at least. And one biopsy is showing granuloma, which was on the data which I was given. So no systemic involvement in labs, negative CT for involvement of chest and abdomen. So it is a localized disease. So missing history and labs which may have helped me a little bit more is if she has any recurrent history of infections in past, any skin abscesses, lung, GI involvement, any history of dental procedure, because the lesion is starting from the base of the mouth or the oral cavity. Any transfusion history, why does she have hepatitis C, hepatitis B positivity? I would like to know any personal history, does she have any habits? Any family history, consanguinity in family? Although it is, as I understand, the patient is 50 years old, but nowadays we are discovering new and new cases. For example, some CGD which is presenting quite late. So biopsy, when I was given the biopsy, what he has shown is not what I had seen. So I had no idea on the caseation, whether there was any caseation, any necrosis was there or not. The granuloma was mentioned, but whether it was a necrotizing or non-necrotizing. Any histiocytes were done or not, or any markers for histiocytes were done or not. I would like to know all those things, and assume evidence of vasculitis is not present because it was not clearly mentioned, but was there any transmural infiltrate of the blood vessels? These things I would have. IgG4 staining was also, it was given now that it was only mild. So I would like to move on to my differentials. So the differentials that I have considered for this destructive granuloma, which has been in the oropharynx and which has progressed over 1 year in an HCV infected patient with hepatitis B carrier status. So I considered these under these 5 headings. So for malignancy, which I considered, which it's a destructive lesion, not obeying any planes, it is going through facial planes. And so midline granuloma is one of the considerations, which is basically most of the time an NK cell tumor or a T cell tumor. However, as you know, that biopsy has been done thrice and they have not found any lymphoma on that. And squamous cell cancer, sometimes you may not get like the biopsy you do is not representative, and you may have 2 or 3 biopsies which, because necrosis is coming, so it can be missed. So these were the malignant differentials. Infections, I think this patient has been going on too well to have tuberculosis also. The tuberculosis treatment was given and she didn't respond. And the cultures were negative again and again. The other thing that which I considered is a non-tuberculous mycobacterial infection. So some slow growers
actually can involve the cervical area and can start from nodes and then produce abscesses. However, this is not an abscess, so that NTM kind of picture is less so. Then I thought of what is the commonest organism which causes chronic infection in cervicofacial area. So this is actinomycosis, which is the commonest infection which affects the cervicofacial area. It can happen in immunosuppressed and immunocompetent. Immunosuppressed, it happens, so it is difficult to clear this. Then I considered nocardiosis. Nocardiosis also, and I will discuss those things in detail later. And leprosy and syphilis would also be a differential here, but leprosy and syphilis have been ruled out in this patient. Autoimmune, I considered limited GPA, sarcoidosis and Crohn's. I would come to details of that. Hereditary, although very less likely, I have also given a consideration on that. So let's start with, then in others, histiocytic disorders and orofacial granulomatosis. So let's come to some of the most important ones which differentials I thought should be ruled out. So midline granuloma, or also known as midline lethal granuloma or Stewart's syndrome. So this is basically NK cell or a T cell tumor which is extranodal and usually progressive tissue infiltration and causes necrosis. The most common site actually is the nose, but it causes a lot of necrosis. You can see the necrosis in this patient. And biopsy will show you the atypical cells, which are lymphomatous, CD56 positive, CD3 positive, and they'll be having angiocentric involvement. Blood vessels are involved in this lymphoma very commonly, and that's why extensive necrosis happens. So can be missed in initial biopsies if you take only the necrotic areas. But there are a lot of points against this. Usually it is rapid progressive. 2-3 months is all you need, and this disease will just necrose through the skin. Granuloma is not seen most commonly. Presence of B cells in the biopsy, which was there, prominent B cells, was also against this. So that is why I think this is less likely. This is one of the picture of patient which has been published from India of a midline granuloma. Limited GPA. So coming on to autoimmune diseases. So limited GPA is possible, is what I think was being treated for when the treatment was given for with rituximab. So ANCA can be negative in limited GPA especially. Almost 40% of ANCAs are negative in limited kind of GPA. Granuloma rather than vasculitis is the finding actually when you do the biopsy, because airways you don't get vasculitic biopsy reports. You will not find biopsy. You will find more of granulomas. But the involvement is more so in the nasal, paranasal areas, orbital areas, or subglottic. And subglottic involvement is mostly in children, although you can have in adults also. So oropharyngeal, when I actually set out to look for cases where there is oropharynx involvement, jaw involvement, I actually didn't find any cases of GPA involving, and limited GPA, it has to be only involvement. So didn't really find that. So both absent ANCA and biopsy confirmation of vasculitis is not there. Would have progressed much faster, I felt. So these reasons why I think it is possible still, but less likely. Other autoimmune disease, I don't think we should consider IgG4 at all in this case, because 1, presence of granuloma, 2, it is progressive and it's going through planes. Usually it has compressive symptoms, IgG4, but usually does not infiltrate and goes through tissue planes and does not destroy the bones most commonly. It usually only causes compression. And also there was no typical features of triad of IgG4 should have a triad actually on histopathology of lymphoplasmacytic infiltrate, which is present in this biopsy. Presence of storiform fibrosis, which is not there. Obliterative phlebitis, which is not there. And IgG4 staining ratio is actually written as mild. It should be more than 40% or so. So this is not IgG4 for me at all. Sjogren's, very unlikely, although it involves that area, Mikulicz syndrome or Sjogren's with gland enlargement. It is not the gland actually, it is not even the lymph node. So Sjogren's with lymphoma also, but also there was no mention of any history of any SICA. So there is no AG reversal, LFT would have told us that. So no clue on blood counts also of leukopenia. So I don't think this is Sjogren's. Sarcoidosis, unlikely again, because it is a very aggressive disease, whatever this patient has. I think sarcoidosis usually is not this aggressive. It does affect the organs, but it does not lyse the bones and does not cause this kind. Also, the site is very unusual. The site for sarcoid can involve sometimes the glottis, but usually causes nodules or something like that. And usually it's a part of a more systemic disease where 90% of patients of sarcoid should have an involvement of the thorax, which this patient didn't have. Also, AS levels were normal. Infections, NTM, very less likely because of AFBs being negative, and a patient is not HIV positive, normal lymphocyte count, not the usual site, no response to ATT. Even though it is modified ATT which is used, I don't think this is. So actinomycosis is my likely diagnosis in this patient because this is the commonest site. 60% of actinomycosis affects the cervicofacial area. Lumpy jaw it is called. It looks like that when I saw the patient's face, and often related to poor dental hygiene or some dental manipulation. That's why I wanted a history of whether this patient has a dental procedure prior to all this starting. Actinomycosis generally not diagnosed until chronic phase. And more so in immunocompromised cases, commonly seen as contrast enhancing mass, which is the case in this case, and also requires lot of cultures can miss actually actinomycosis unless you give the microbiologist this reason, because actinomycosis is actually a common cell of the oral cavity. It can be normally be present, but it will be increased in an infection. So you have to give, and also it's a polymicrobial infection. Although actinomycosis is the main cause, there will be other 4 or 5 bacteria which can grow along with it. So these are the reasons. The only thing against actinomycosis in this case is lymph node involvement is not common in actinomycosis. But lymph node involvement may have been because of a polymicrobial infection which the other infections are causing the lymph node enlargement. Nocardiosis is basically the aerobic variant of actinomycosis in a loose term, which we can say both are branch filamentous bacilli and gram positive, but this is aerobic, that is anaerobic. So nocardiosis should grow easily actually in a culture if you have sent, but it delayed growth happens 3 to 5 days, but it will grow. Anaerobic, it doesn't need anaerobic medium like actinomycosis. Also, nocardiosis usually causes skin disease in an immunocompetent person. An immunocompromised person also, it can cause disseminated infections, but it causes mostly either skin papules or it causes abscesses. Sorry, I'm taking a little too long. Histoplasma.
You can continue. Yeah. For CPC, you cannot restrict time.
Sure, thank you, sir. So nocardiosis is also less likely for me. Then I thought of histoplasma capsulatum, but histoplasma, it can cause painful ulcers, it can cause granular lesions and varicose growths. And it may even be infiltrating, and there are cases where have been reported where there's a mimic of carcinoma. Now points against is, usually patient comes from Gangetic belt or basically from caves or near rivers. They are the patient who get. Although immunocompetent people do get infection, usually that is pulmonary infection. In this patient, if you consider HCV as the immunocompromising condition, may consider this disease, but it should have been easier to pick up. When you do an histopathology, if you look close enough, these will have inclusion bodies in the histopath. There is no mention of that. So because of these things, I think histoplasma is less likely. CGD as a presenting in adults. So I found this very interesting case of 52-year-old, this patient is also 52-year-old, presenting CGD
with an infection pneumonia at 52 years first time. Also, there is a case series of 11 patients which have been reported where CGD or chronic granulomatous disease has been found from 13 to 43 years of age range. Typically, they have infections with catalase positive organism, and they have granulomas which may be related to infection or maybe sterile granulomas, and there may be TB treatment history because people may have considered TB. So the infections are usually because of staph, serratia, nocardia, Burkholderia, and fungus like aspergillus. So could it be a CGD with nocardiosis or CGD with some one of the catalase positive organism? So this is very less likely, I would say, because the age, but it should be given a consideration, and maybe an NBT or DHR should be done in this patient, especially if you have a past history of granulomas. So my final differential based on all the data has been given to me, history and examination and this thing. I think chronic infections are more likely. For me, actinomycosis is the most common because it is easily missed. It needs anaerobic medium for growing, and it is the commonest area of involvement in cervicofacial. That is why for me it is actinomycosis more than nocardia. And midline granuloma, I would still consider, even though biopsy is normal, because it can be missed a lot of times, and maybe the third biopsy has gotten that. And the last I would consider is the ANCA negative limited GPA, for which the rituximab was given. And but I have the area of involvement, the lack of any constitutional symptoms, which can happen in limited GPA, but it is slowly progressive. Overall, I think these are the three differentials that we should consider in this patient. And thank you for the opportunity.
Thank you, Avnish, for the wonderful discussion. Now it's open to the floor. Audience, you can come out with your differential diagnosis.
Can you entertain pyoderma gangrenosum in this?
Sir, pyoderma gangrenosum should have, I understand that, the neutrophilic biopsy findings. Sometimes some small vessel vasculitis can also be seen, but mostly neutrophilic. And so that is why I didn't consider, when I saw the reports, I didn't consider that. And also it was a mass presentation actually. When the presentation was there, it was oropharyngeal mass. First symptom was a mass in the throat.
I think this patient have the almost all the components of our disease. Number one, he had pieces of infection. Infection had initially had hepatitis B, hepatitis C, then fungal infections. Then evidence of inflammation. Initially, he responded very well to steroid. Then again also responded to steroid. Then responded to rituximab also initially. Then there is evidence of granulomas. Granulomas, there is a destructive lesions. So there is evidence of inflammation and granulomas with IgG4 positivity. Even if it is mild, we have to take into clinical consideration. And only thing, the thing is extensive destructive lesion and progressive lesions and not responding to conventional line of treatment. I think it is going for malignancy. So there is evidence of granulomatous disease, maybe a IgG4 related disease with infection, maybe a hepatitis B, hepatitis C, fungal infection, and going for a rare malignancy. I think so. That is my opinion.
Thank you, sir. The only reason I didn't consider IgG4 disease, sir, is because granuloma is an exclusion criteria on biopsy according to 2019 guideline. But I understand what your opinion is, sir.
Any other opinions? The patient was there with us for more than a month. She had very troublesome disease with fluctuating clinical signs, and she developed secondary infections. We thought to lose the patient. Actually, this patient was discharged. On the day of discharge, we got the probable diagnosis, and we discharged the patient with the drugs. Then she was lost to follow-up. We thought patient died. We lost the patient. Only after a few months, the patient's attenders sent the photograph of the patient. She said she is improving. So this is how we came to know that probably we have picked up the diagnosis. Right. Now I request our pathologist, Dr. Rashma Kurian. She is an assistant professor of pathology at Christian Medical College, Vellore.
Good afternoon, everyone. I would like to describe the histopathology images provided to me. So the first one is the lip biopsy. So as we can see here, this is minor salivary gland tissue. These are clusters of mucinous cells. This is a stratified squamous epithelium. There is extensive surface ulceration covered by acute inflammatory exudate. Coming to the high power, the stroma shows dense inflammation, and the inflammatory infiltrates are predominantly lymphocytes, followed by plasma cells, eosinophils, and neutrophils. Here, we can see a few vessels with transmural inflammatory infiltrates, predominantly composed of lymphocytes and neutrophils. So this looks like a vasculopathic picture. I will not call this as vasculitis. Why? Because this is beneath an ulcer. So this is a vasculitis-like picture or vasculopathic changes. Also, there are a few giant cells, multinucleated giant cells, but no well-formed granulomas. There is no necrosis, and I didn't see any atypical looking large lymphoid cells. So this looks like a granulomatous cheilitis. The first differential to consider is an infective etiology. I believe stains were done, the stains were negative, so the infective etiology like fungal organisms and TB are ruled out. This doesn't look like a typical TB granuloma because there is no caseous necrosis and there are no well-formed granulomas. Only scattered giant cells were seen in this biopsy. Next differential to consider is an ANCA-associated vasculitis. With this vasculitis-like picture, with scattered giant cells, eosinophils, and neutrophils, we should definitely rule out ANCA-associated vasculitis. The third differential I would like to consider is overlap syndrome. Considering the age of the patient, there is a supraglottic growth, there are clinically relevant lymph nodes, definitely we should rule out lymphoma. I think CD3 and 20 were done, which showed a polyclonal population, but I think it would have been better if extensive workup was done to rule out a lymphoma, like MIB1 proliferation index and other B-cell and T-cell markers. Other differential to consider is Sjogren's syndrome, but this is not the typical presentation we see in Sjogren's syndrome, the clinical, the pathological picture. Definitely in a lip biopsy, when we see a lot of lymphoplasmacytic infiltrate, we have to rule out Sjogren's syndrome, but these giant cells and ulceration is not commonly seen in Sjogren's syndrome. Talking about IgG4, in IgG4 related disease, we see more of obliterative phlebitis and fibrosis, which is not seen in this biopsy. And the IgG4 count was given as mildly elevated. And does it look like a typical sarcoid as well? Because we are not seeing a well-formed granuloma, and these many lymphocytes we don't get to see in sarcoid-related disease. Coming to the next biopsy. So this is not very clear. I think this is from the base of tongue. This is the stratified squamous epithelium. Stroma is showing inflammatory granulation tissue. And here we can see the filamentous bacteria. This is a gram-positive filamentous actinomycotic colonies. So these actinomycotic colonies, these are normal common cells which we see in the oral cavity as well as in the tonsillar crypts. When it invades the tissue, when it invades the skin or the bone trabeculae, then it becomes pathological. So in this biopsy, actinomycotic colonies were also seen. I think there was no biopsy taken from the jaw or a lymph node. That also would have been helpful in this case, I think.
Thank you, madam. Thanks. But we were not supported by our pathologists because first biopsy they reported as inflammation. Second biopsy, they said there is no malignancy. When we asked them, they said maybe a vasculitis, probable vasculitis. Then we have put the patient on rituximab. And when there was no response to all these drugs, we started tapering the steroid, and we convinced them to do the biopsy again. After third biopsy, then only they gave an oral report of actinomyces. Then with this suspected probable diagnosis, even they have not given the written report. So with the oral report, we have discharged the patient with penicillin. Then after 3 months or 4 months, the patient attenders reported, and they said patient is recovering well. Now she is able to swallow and take feed. So it's a chronic infection, but the clues were the dental procedure, the chronicity, and the localized disease. PET-CT was normal, and all the markers, our immunological markers, were negative. So IgG4 may be deceiving. Many times the level of IgG4 is not enough to diagnose. But better to rule out the chronic infections like this. So that's why we presented this case here. Thank you, madam. Thank you for the discussion. Someone has left his specs, I think. Chairperson, Ruchika Adak, Jacob Anthony.
So thank you all. I'm not going to stand between the lunch between, but we have a small dance program from kids from Udumlapet. The master, Zakir Hussain, is my patient. He's an SLE patient with severe PAH, and again had a very bad disease, and now he's doing well. So he had told that he wanted to contribute something for a conference which I am doing. So kindly bear with us for another 15 minutes. We have a plantain leaf lunch, which is served for all. And we'll make it everything in short and crisp way. And we have the most important validatory function, all the Le SZIRACON part, the scientific papers part. Kindly stay back. Another 15-20 minutes, we'll finish it fast.
Thank you. So now we have cultural programs by the kids, and the guru and the choreographer of those kids is Mr. Zakir Hussain. So we have the first cultural program, and the first is the performance by Pujita S. It's a welcome dance. So I kindly request everyone to give a very good applause and encouragement for the kids.
Hi everybody, good afternoon. I'm Shahrukh Dance Academic. I'm learned in 30 years in Shivanjali from Coimbatore, Vadavalli. You know all of you, dance school, 30 years experience. I'm giving a 2000 program for all over India. Thank you.
Nilamanava Villanava Kashanava
நீர்தானே உயிர்க்கெல்லாம் முதலானவன் நீர்தானே உயிர்க்கெல்லாம் முதலானவன் நான் தேடும் உலகெல்லாம் உறவானவன் ஜெகம் கூடி ஜெகி பாடும் இசையானவன் ஜெகம் கூடி ஜெகி பாடும் இசையானவன் என்னை நாடும் தொடர்கின்ற நிழலானவன் என்னை நாடும் தொடர்கின்ற நிழலானவன் நீர்தானே உயிர்க்கெல்லாம் முதலானவன் இறைவா நதியில் நீராகி நிலவெல்லாம் ஒளியாகி பனியில் துளியாகும் இறையானவா நதியில் நீராகி நிலவெல்லாம் ஒளியாகி பனியில் துளியாகும் இறையானவா புவியில் திறனாகி இதெல்லாம் கருவாகி காற்றில் அசைந்தாடும் நிறைவானவா புவியில் திறனாகி உயிரெல்லாம் கருவாகி காற்றில் அசைந்தாடும் நிறைவானவா வரம் தேடியே உனை பாடினே நீதம் கூடியே மகிழ்ந்தாடினே தலங்கை ஒலியாக சதிராடும் மயிலாக ஜெதியில் ஒயிலாக நடமாடினே தலங்கை ஒலியாக சதிராடும் மயிலாக ஜெதியில் ஒயிலாக நடமாடினே சபையில் இனிதாக இடம் தேடும் முகமாக இதயம் கலந்தோரை புகழ்ந்தாடினேன் சபையில் இனிதாக இடம் தேடும் முகமாக இதயம் கலந்தோரை புகழ்ந்தாடினேன் ரரபப்ப தகரி ரரபப்பரிரபா நீர்தானே உயிர்க்கெல்லாம் முதலானவன் நான் தேடும் உலகெல்லாம் உறவானவன் ஜெகம் கூடி ஜெகி பாடும் இசையானவன் ஜெகம் கூடி ஜெகி பாடும் இசையானவன் என்னை நாடும் தொடர்கின்ற நிழலானவன் என்னை நாடும் தொடர்கின்ற நிழலானவன் நீர்தானே உயிர்க்கெல்லாம் முதலானவன்
And you can give a very good applause for the wonderful Bharadam performance by Poojita. Thank you so much. And next, we are going to have a group dance performance by the kids. And the names of the kids, Parikshit and team, Parikshit, Nalin, Jai Krishwan, Pragadish, Sasti Sharan, and Bhavanya.
அப்பா என்னம்மா ஏதாவது கதை சொல்லுங்கப்பா. சரி சொல்றேன். ஒரு பயங்கரமான காடு, சரியா? அந்த காட்டுக்குள்ள கொடூரமான ஓநாய் மிருகங்கள் வாழ்ந்துகிட்டு இருந்துச்சு. அந்த ரத்த வெறிபிடிச்ச மிருகங்கள் கிட்ட பாவம் ஒரே ஒரு பெண் ஓநாய் வந்து நல்லா மாட்டிக்கிச்சு. ஆனா இந்த பெண் ஓநாய் எதிர்த்து நின்று வேட்டையாடிச்சு. கொண்டு
ஏதாவது கதை சொல்லுங்கப்பா.
சரி சொல்றேன்.
ஒரு என்னப்பா ஆச்சு?
அந்த ரத்த வெறி பிடிச்ச மிருகங்கள் கிட்ட வாராயோ வாராயோ எனக்கு ஒரு கருந்தர வாராயோ 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 உனக்கென.
அப்பா
என்னம்மா?
ஏதாவது கதை சொல்லுங்கப்பா.
சரி சொல்றேன். ஒரு பயங்கரமான காடு, சரியா? அந்த காட்டுக்குள்ள கொடூரமான ஓநாய் மிருகங்கள் வாழ்ந்துகிட்டு இருந்துச்சு.
அப்பா 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 அப்பா
என்னம்மா?
ஏதாவது கதை சொல்லுங்கப்பா.
சரி சொல்றேன். ஒரு பயங்கரமான காடு, சரியா? அந்த காட்டுக்குள்ள கொடூரமான ஓநாய் மிருகங்கள் வாழ்ந்துகிட்டு இருந்துச்சு.
ஒரு என்னப்பா ஆச்சு?
அந்த ரத்த வெறி பிடிச்ச மிருகங்கள் கிட்ட பாவம் ஒரே ஒரு பெண் ஓநாய் வந்து நல்லா மாட்டிக்கிச்சு. ஆனா இந்த பெண் ஓநாய் எதிர்த்து நின்று வேட்டையாடுச்சு. வாராயோ வாராயோ எனக்கு ஒரு கருந்தர வாராயோ 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 உனக்கென விழு குடி பாராயோ. ஓ தீராயோ தீராயோ நொடியில் நெடுந்துய தீராயோ தாராயோ தாராயோ இதயத்தில் எரிபொருள் தாராயோ. ஆடை நீதானே மேடை நீதானே என்னுள்ளே ஆடும் மாற்றம் நீதானே. கால்கள் நீதானே என் காற்று நீதானே என்னுள்ளே ஓடும் ஓட்டம் நீதானே. இருளில் விழுவேன் வழியில் உருவே அழுவேன் அதுவரை உடனே தொழுவேன் கடந்தர உடனே எழுவேன்.
ஆடினமே உன்னை இப்பதற்கே கருவிலே உன்னை ஏந்துவே
நீ பயமின்றி துணிந்து சொல்லு.
So a very beautiful performance by the team. Thank you so much, kids. And now we have the another performance by another team, and this is the team Bharat and team, and there are so many kids for the next dance too. So we welcome all the kids: Bharat, Pragadish, Mohammad Irfan, Steve Joshua, Mithun Sarvan, and Nalin.
சாரி கைஸ், இனிமேல் என்னால் டான்ஸ் ஆட முடியாது, நான் போகிறேன்.
Thank you so much, kids. That was a beautiful performance once again. And finally, we are moving to the last cultural dance performance by the another team. And there are a lot of kids in this team, so let's welcome them with their names. Parikshit, Lakshmita, Bhavanya, Sibana, Sara Joy, Nalin, Pragdish, Mithun, Sasti Sharan, Steve, Bharat, Irfan and Mohammed Asper.
Relax, relax. வா ஓகே வா தண்ணி குடிக்கிறியா கொஞ்சம் மூச்சு நல்லா ரிலாக்ஸ் அவசரம் ஓகே
Mission 9, 8, 7, 6, 5, 4, 3, 2, 1, 0. Plus 5 seconds.
Lift off normal.
Here we have a majestic lift-off of LVM-3 M4 rocket carrying India's prestigious Chandrayaan-3 spacecraft.
Peto tracking.
प्रज्वलन और सफलतापूर्ण उत्थापन LVM-3 M4 रॉकेट का
हम सबके लिए जो जाग रहे बस साथ हमारा मांग रहे विज्ञान से भारत सींच रहे इतिहास के पन्ने छाप रहे है सलाम तुझे इसरो है सलाम तुझे इसरो है सलाम तुझे इसरो है सलाम तुझे इसरो इसरो ने हमें सलाम दिए जंगीर बाबा के सपने पूरे किए मंगल पे तिरंगा फहरा दिए है सलाम तुझे इसरो है सलाम तुझे इसरो 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 हर देश में गूंज रहा नए कीर्तिमान महाशक्तिमान भारत को बना रहा कंधों से मिलते हैं कंधे कदमों से कदम मिलते हैं हम चलते हैं जब ऐसे तो दिल दुश्मन के हिलते हैं कंधों से मिलते हैं कंधे कदमों से कदम मिलते हैं हम चलते हैं जब ऐसे तो दिल दुश्मन के हिलते हैं अब तो हमें आगे बढ़ते हैं रहना अब तो हमें साथी है बस इतना ही कहना अब तो हमें आगे बढ़ते हैं रहना अब तो हमें साथी है बस इतना ही कहना अब जो भी हो शोला बन के पत्थर है पिघलाना अब जो भी हो बादल बन के पर्वत पर है छाना कंधों से मिलते हैं कंधे कदमों से कदम मिलते हैं हम चलते हैं जब ऐसे तो दिल दुश्मन के हिलते हैं सुनो गौर से दुनिया वालों बुरी नजर ना हम पे डालो चाहे जितना जोर लगा लो सबसे आगे होंगे सुनो गौर से दुनिया वालों बुरी नजर ना हम पे डालो चाहे जितना जोर लगा लो सबसे आगे होंगे हिंदुस्तान हमने कहा है जो तुम भी कहो सुनो गौर से दुनिया वालों बुरी नजर ना हम पे डालो चाहे जितना जोर लगा लो सबसे தொட்டது யாராம் ஸ்ட்ராங்கா அடியாம் ஸ்ட்ராங்கா சவுத்து போலை தொட்டது யார் நாம் தானே விக்ரம் லேண்டரிலே கனவு பலித்ததே திறமையால் தானே வல்லரசும் நாம் தானே கனவு பலித்ததே நம் திறமையால் தானே வல்லரசும் நாம் தானே.
Wow, that was an amazing performance. And you can give a very good applause for all the kids for the beautiful cultural dance performance. Thank you so much, kids, and thank you for the choreographer and the team.
வெல்கம் பண்ணிருங்க. ஆமா சீனியர் சார் பிரைஸ் கொடுக்குறாங்க.
ஆமா அதர் சீனியர்ஸ்லாம் பிரைஸ் கொடுக்கயா?
கிருஷ்ணன்குட்டி சார் இருக்காரு.
ராஜாமணி சார்.
கிருஷ்ணன்குட்டி சார் இருக்காரு.
குட்டி. ஐ சா வினிதா மேடம் கொடுங்க. நிறைய பிரைசஸ் இருக்கு. டாக்டர் வினிதா ஷோபா Okay, after a fantastic academic, sports, dance, food, all sorts of feasts at SZIRACON 2024, we have very sadly come to the end of an enjoyable 3-day, lively, wonderful, beautiful, excellent, superb, stupendous. I can't find any more words. Done by the local team so beautifully. We have relaxed so much, we have enjoyed so much, and everybody has got something to take away home apart from good memories. And with that, without any further delay, we'll proceed to the valedictory function. We invite many seniors onto the stage to help us to give away the prizes to all those who have done the laurels. And thank you, little ones, dance teams, for your beautiful, wonderful, excellent performance, dedicated performance. Thank you, one and all. Now I'll hand over to the others to do the honors.
I will announce the prizes. We will start from quiz winners. The winners are Dr. Vishwa, Dr. Akansha from SRMC. ஸ்ரீஹர் தான் அது. ஸ்ரீ ராமச்சந்திரா இன்ஸ்டிடியூட் ஆஃப் ஹையர் எஜுகேஷன் அண்ட் ரிசர்ச். Second prize goes to Dr. Anup and Dr. Mervyn Samuel from MMC. Don't do that, SRMC students. Third place, Dr. Purnima and Dr. Harsha from CARE Cochin. CARE Cochin. Shanice CARE. Next is oral presentation. First prize goes to Jitin Varghese from Trivandrum. Second prize, Dr. Akansha from Srihar again. Second prize, Dr. Akansha from Srihar, Chennai. Third prize goes to Dr. Manyam Pruthi from Krishna Institute. Amrita Institute, sorry. Pruthi Krishna, Amrita Institute, Cochin. Poster presentation. First prize goes to Dr. Suraj Nair from Believers Church Medical College, Kerala. Suraj Nair. Is he available or not? Not available. Second prize goes to Dr. Akalya from IIT Madras. She's coming here. Dr. John Matthew will receive the prize on behalf of Dr. Akalya. CMC collaboration, IIT and CMC collaboration. Third prize goes to Dr. Rahul Vijayan from MMC.
So this year, to encourage maximum abstracts, we have introduced an award for centers with maximum scientific paper presentation. And it was a tie between MMC Chennai and CMC Vellore. They have both sent 15 papers to the. So on behalf of MMC Chennai, Ramesh sir and Ramesh sir also. We have two prizes. We have a prize again, one more sir. First one. So this is to encourage all the centers to send more on papers. So the shared first prize for CMC Vellore. So CMC Vellore and MMC Chennai are like two eyes of rheumatology departments. And the other center, probably the third eye, was Shenoy's Care. Anybody from Shenoy's Care? They had 13 papers. Possibly if Shenoy had known 15, he would have sent even 5 more. Now, Kelo part. So Kelo part, so that was what stopped Naidu and other people from going to the airport early. So cricket, the winners are Telugu Titans, Captain ARK Naidu. Runners, Kannada Uligalu. Anybody from Karnataka? Karnataka? Okay. So team captain was Dr. Dharmanand sir. So table tennis, doubles winner, again Telugu Titans, Dr. Vimal Manik Shah and Dr. ARK Naidu. ఇక్కడే ఉండండి, అన్ని నీరే తీసుకుని పోతున్నారు. For cricket, anyway, the runners up, we'll send it across. This is for the table tennis, doubles winners, Telugu Titans, Dr. Vimal Manik Shah and Dr. ARK Naidu. ARK Naidu will receive in place of him. And we have table tennis winner from Tamilnadu Thalais, Dr. Venugopal sir and Dr. Sami Krishnan sir. Sami Krishnan sir had an extensive practice for this event. So, and he got away with the runners up. Table tennis, madam. Okay. Table tennis singles winner Suresh Adimulam. He left. Okay. On behalf of So table tennis singles winner Dr. Suresh Adimulam, as he has left. Dr. Naidu will take it in on behalf of him. Tamilnadu Thalai were the runners. Dr. Sriram. Dr. Sriram, anybody on behalf of Dr. Sriram? Bonesh is Kerala team. So on behalf of Dr. Sriram, who was the table tennis singles runner-up. So there was increased interest on chess, and as we all know, Venugopal sir topped the list. There's increased interest in chess. For chess, the first prize for the chess first prize goes to Dr. Venugopal sir from Tamilnadu Thalais. And second prize goes to Dr. Kirtana of Kannada Uligalu. Dr. Kirtana. Third prize goes to Dr. Bonesh of Kerala Tuscus. Fourth prize to Vijay Babu sir. Dr. Vijay Babu. And fifth place goes to Dr. Sriram. One prize. The other two prizes we'll give it across. So next we go to Carom. The winner was Dr. Magesh Gaikwad of Telugu Titans. Malli Naidu gare vastunara. Magesh Gaikwad. And runner-up goes to Dr. Meghna Gawali. of Telugu Titans. Illa. And shuttles, mixed doubles, that is carom, runner-up by Dr. Meghna Kavali. Okay, sir. Thank you. So shuttle, mixed doubles, winners are Kannadada Uligalu, Dr. Sivaprasad and Dr. Chaitanya Dharmapalaya. They are not here. We'll send it across. Runner-up were Kerala Tuskers, Dr. Jacob Anthony and Dr. Sanjana Joseph. Kerala runners-up. Runner-up. Mixed doubles shuttle. So shuttle, mixed doubles, runner-up, Kerala Tuskers, Dr. Jacob Anthony and Dr. Sanjana Joseph. So you can. So we need, in view of the multiple events, we had to give an overall championship awards with maximum number of winners. Dr. Ramakrishna Nadu, representing Telugu Titans, will take away the overall championship award. So next year we'll take it from you, Naidu Garu. Mark it. Gifts for the kids. So for an excellent dance performance at the last minute by the kids, actively coordinated by Mr. Zakir Hussain. So we'll just felicitate him with small gifts. So they were doing it very passionately. So that shows their commitment at an young age with a lot of themes. So well done, boys and girls. Well done, Zakir. Well done, the school team, school principal. So who all on a Sunday had a lot of practices. So that shows the commitment. Very nice of you. So nice. So we'll give a big round of applause for the kids. So well done by all of you guys. கோயம்புத்தூர் டீம் வாங்க. எடுத்துக்கோங்க வாங்க.
பெரிய ஆர்கனைசர். நீங்க என்ன மேடத்தை விட்டுறீங்க? Miss, Madam, please come to the stage. Madam, vaanga madam.
Single line.
Single line. நீங்க போங்க. ஆர்கனைசேஷன் டீம் தான் இது. ட்ரெஷரர். ட்ரெஷரர் வாங்க ட்ரெஷரர். பசிக்குது.
So,
three cheers to the Coimbatore team. Please. At least say hip hip hooray. You won't say all that. Okay, 3 cheers. Headed by Dr. Nagaprabhu for his excellent contribution.
So good afternoon all. As I know, I'm standing in front of the lunch. It's a plantain leaf-based lunch, tradition of Tamilnadu. So as was discussed in the inauguration function itself, every South Zone Rheumatology Conference needs to be far better than the previous one. So what we have tried to do is raise the bar and give it to the next team and make it a success. So this is actually intention to improve the quality of South Zone Rheumatology conferences. So it is not possible without the help of all the regional members. All the regional members, the Hyderabad Rheumatology Conference, Hyderabad Rheumatology Association, Secretary, President, the EC committee members, the same way with the Kerala, the same way with the Karnataka, and our own art members, art association. So, I mean, if at all I have to thank, I have to thank a big chunk of people. So, if at all I miss somebody, don't take it to heart. I know I've thanked everybody. And so, to start with, I'll start with the event management team, event management Ranganathan sir, and his team members, the audio-visual team, the team behind the scenes who work around, and the hospitality team by the hotel. So all these 3 days, I've never received any complaint that the hotel has some deficiencies, including the food, the stay, the accommodation part. Whenever we ask for something, they always give it. So that is the part around. The ARS Travels, whom we have a time for the transportation of the delegates, for the faculties. So they have done a huge job providing services at the right time. So that is the support team which are acting around, followed by the the major our supporter, IPCA Laboratories, so who had actually appointed people at all point of time, then followed by our hetero team, overseas, CIPLA, Concord, Pfizer, THIA. So just maybe 2 or 3 I may have missed. So all those they have pitched in at the right time. They have Johnson & Johnson, Wallace, Apex. So they have all pitched in at the right time, and unlike other conferences, we have received most of the money in packet when we started the conference. That gives us confidence to move ahead with the things what we wanted to do. And the last, the performances by the kids, Zakir Hussain, one of my patients, so we had given just 2 days time. Thought something we wanted to do. All the last minute things were happening well in place. So that was one good thing from the Almighty part. So I have nothing to offer from my side. So whatever happened, because the Coimbatore as such was not a prime location. Whenever somebody wants to do a major conference like this, Coimbatore is not the first location, but I now feel that they may have a change. So Coimbatore has shown its ability to host one of the major conferences, and possibly Sivakumar and other team are there. They will get it up from my side and do even more better conferences, maybe Appler or something of that sort. So that's for the zone part, don't take it, man. So அதுக்கு தான் சார் பேரை சொன்னேன் வெளியே வர மாட்டான் இல்லைன்னா so the Coimbatore team, as I told, see Rajamani sir, from day one he often gives up a call and says that I'm watching all whatever you're doing, you're on the right track, I'm behind you, don't worry about it. Same way with the Magesh sir. Jaikumar sir is having some health issues, otherwise he would have been there here with more than 100%, and the other teams have put effort more than 100%. Starting from Sundaram, who has begun for the souvenir part, Nagendran and Sundaram, Sivakumar, as I told you, is going to head up the next conferences, and my able Ali Madheshwaran, so treasurer, because see, I have a loose hand. I'll just put sign wherever it is possible, but it will be questioned by Madheshwaran. So I am now happy that I am not going to give away money like that, because Madheshwaran is there, who is the checkpoint with us. So that is one good team we had, which made this conference a huge success. So we had some problems because of the simultaneous arrangements which were happening. So some of the all occupancy was very less. So we'll try to modify it in the next conferences. We were having a talk about that. If at all we are doing a next conference. So what we can do to all those things, and so those parts are also enjoyed, but possibly we should try to make it in a different way. So we were having some chats about that. We'll give the feedback to the art team, who are basically the brain behind this. So we were like, we were told these are the things which has to be done. We just enforced it here, except the extracurricular part. So all the scientific content, thanks to Arul sir. See, the topics were something like which I would like to listen. Possibly everything is live recorded. If possible, I'm going to look back and see and gain more experiences. The scientific thing is etched with excellent efforts by sir and his team, scientific team. Rajeshwari madam for behind the bones, like organizing chairman as their own roles. So she did a good work. Subramaniam sir. So possibly left early. So the abstract committee, the scientific part, the poster selections, all those things are taken care by him. So that is the scientific part. Then my team, headed by Sasi, so he was like the all-in-all Alag Raja. So he does everything. I just give him the permission to do it. So they take meticulous care that nothing goes out of it. So I know that when they come up with a part, I just need to give an approval of yes or no. So the other team, Saranya, Ramya, Omaga Lakshmi, all those people who had worked here, we have some 15 members who have worked from our support team itself. So they did a good job. Selva, Venu of ITRA was like, he's working as if he was my team member. So same way, the IPCA group member, we had support system. So that is one thing I thought was good for us. So everyone pitched in, everyone worked for us, and that is how this conference is ended. So we are handing it over to the next team. Let us see how this goes. So thank you all, thank you all, thank you all. If at all I have not mentioned anybody, so kindly bear with me. Thank you all for your support, and let's see in the next conferences.